One is today is the Kerala Formation Day, 64th, 66th birth anniversary of the state of Kerala. Today we have joined in this Zoom platform to attend the academic Vista of Kerala Folkon 2020, the pediatric, that is the annual conference of pediatric hemato-oncology chapter of Indian Academy of Pediatrics. This is the 11th state conference. Of the many specialty chapters of Indian Academy of Pediatrics, hemato-oncology chapter is one of the very vibrant chapters. IAP Kanhangad feel honored for granting us the privilege of hosting Kerala Folkon 2020. The COVID pandemic has changed everybody's life totally. So also in these academic meetings, is virtual meeting in on any academic meeting. The virtual online conference is the fallout of the pandemic, the new normal. I am assigned with the present duty of welcoming all of you as the organizing committee chairman of Folkon, and welcome the delegates as well as office bearers and faculties. I have a time limit of 3 minutes, so I am rushing with my duty to make it easy. Fast, I am listing them, of course, not in the order of the status or eminence, since all are equally important. The chief guest of the day, inaugurating Folkon, is none other than the darling of IAP, Dr. Ramesh Kumar, HSD, Honorary Secretary General during the last 2 years and the new President-elect of National IAP. Welcome, Ramesh. Second is IAP, Dr. M. Narayan, who is here. He is the current IAP state. And the designated presiding officer of today's conference is Dr. Guru Prasad. Unfortunately, he couldn't be with us, join us. He is our chairperson of hemato-oncology chapter, Kerala chapter. Dr. Ananda Kesavan, the past IAP state president and the current national vice president, South Zone, will be giving the keynote address today. Dr. Balchandar, the state secretary of IAP, and state and hemato-oncology secretary Dr. Jitin are here to facilitate the conference. There is a galaxy of academicians as speakers present today. One is Dr. Nita Radhakrishnan from Noida, UP. She is from the super specialty pediatric hospital and PG training institute. And next is Harsha Prasad from Mangalore KMC. Next is Dr. Binita or RCC Trivandrum, and Dr. Vedira, I don't know if I have pronounced this correctly, Vedira C. From Tata Memorial Hospital, Mumbai, Dr. Jitin from MCC Tanishiri, Dr. Ajit, my best friend from IFC, and Dr. Manjusha Nair, RCC Trivandrum, will be replacing Dr. Guru Prasad. And with me is the organizing committee members of Kerala Folkon 2020, so Dr. Sugasan and PR IAP President, Dr. Ashton Ketty, Secretary of IAP Kanhangad, Dr. Praveen Arora, my trust on my left side, and Dr. Suresh B, organizing secretary. A very, very hearty welcome to all of you to Kerala Folkon 2020. And last but not the least, I welcome very, very heartily all the delegates present in this Zoom platform, without whom the conference cannot be meaningful. Jai IAP, Jai Hind. Over to you.
Thank you, sir. Next, I welcome Dr. Ramesh, sir. One minute. No. Next, I welcome. Actually, the Guru Prasad has noticed there. So he personally has given his congratulations to Dr. Ramesh, sir. It was unfortunate that he couldn't attend the program. Next, I welcome Dr. Narayanan, sir, IAP 8 President, for giving presidential address.
Good morning to you all. Dr. Ramesh Kumar, President-elect, Dr. Advayasan, National Vice President, South Zone. Dr. T.V. Padmanabhan, Organizing Secretary. Dr. Suresh, Organizing Secretary, sorry. Then we have Dr. Sugadan, President. We have Dr. Ashwin, Secretary. Then the organizer, chairperson of chapter, Guru Prasad will be joining shortly. Senior members, and my dear Academy. What a fantastic morning today, the Kerala Karavi Day, when the celebrations of the landslide victory of our dear Ramesh Kumar is still continuing when we academic session. From the bottom of my heart, I thank each and every one of you for the teamwork you have put up in raising the election campaign. It's after 5 years that we are getting national president. And compared to previous years, the election machinery was at its best. Each and every one of IAP Kerala toiled hard and unbelievable 97% polling, which no other state can ever dream of. I have no words to my thanks to every one of you, and my best wishes to the dynamic Ramesh Kumar, who definitely deserves the post and is the most suitable person for that. Now coming to the FOCON, actually we had planned FOCON in Kanhangad with an intention of visiting Baker Fort and enjoying the hospitality of the Kanhangad IAPH. Unfortunately, Corona has damaged our dreams. Still, it's nice to have all of you in the Zoom meeting. And as Dr. TVP has rightly put it, hemato-oncology is a growing specialty in our state. With the newer innovations coming in many hospitals, and we have many centers doing bone marrow transplant also. And due to the combined effort of pediatricians and hemato-oncologists, the prognosis of many diseases in this specialty improving rapidly. I wish this conference all success, and you have selected CREAM academicians as faculty. The conference will be a booster to all of us. I have another point to make on today, that IAP Kerala is launching another project. It's one of the action plan, that is easy breathing for, TB-free air for every child in Kerala. That's our action plan, which is going to be launched by none other than Honorable Governor of Kerala, Sri Arif Muhammad Khan, with a keynote address from our respected Health Minister. The program is at 4 o'clock. So I request all of you to log in and attend that program. It's also a prime prestigious program of IAP Kerala. So I want all of you to attend that program also. So let me conclude. Wishing you all the best, wishing the conference all the best. Happy learning, delegates. Thank you.
Thank you, sir. Next, I welcome Dr. Ramesh, sir, for inaugurating the session.
Respected President IAP Kerala, my voice is sorry. President Dr. Narayan, South Zone, our Vice President Dr. Anandakeshavan, President-elect Dr. Jayaraman, President of Hemato-Oncology Chapter Dr. Guru Prasad in absentia, Organizing Chairman, our dear Papetan, Secretary, my dear Sureshan, Branch President Dr. Sugadan and Dr. Ashwin Vitti, Dr. Praveen, Dr. Jitin, and all my dear friends in IAP Kanhangad, as well as in the Hemato-Oncology Chapter, as well as in IAP Kerala. A dream morning here today for all of us. As Papetan has rightly put it, the Kerala Piravi Day, where IAP Kerala has got a lot to celebrate. A hard-fought victory, I feel, for something which we can really be proud about. It is IAP Kerala only. I mean, I represent you, but we have got it in a big way. And as I always point out, I'm just fortunate. I thank God Almighty that I am born in IAP Kerala and I am living with IAP Kerala and I am there always with IAP Kerala. This family is unique that you have got, you may even say always second family for all of us apart from your own kith and kin at your home. So unbelievable, amazing. We are well, so much of affection is there between us. We respect each other, we love each other, and we care for each other. And this is an amazing family. And I'm so proud about the team of 2020, Dr. Narayan, Dr. Balachandran, as well as Dr. Anandakeshavan and Dr. Jayaraman, the President-elect, and all the supporting office bearers, plus our past seniors elders, Dr. Satsandakam, Dr. Sukumaran sir, MKC sir. And the seniors who have been the guiding light, we follow them and we at the same time, we groom our youngsters to make ourselves proud. So this is just great going for IAP Kerala. And it's a great moment for IAP Kanhangad to have the FOCON here, the Hemato-Oncology State Conference. And as rightly pointed out by our president, a growing specialty where a lot of enthusiasm is there and a lot to learn for our practitioners also for coming out with an optimal point of care diagnosis. So I'm sure that the deliberations here today with a lot of celebrity faculty, I know Dr. Nida personally and not many are there and very interesting practical topics which are useful in practice are out there. So we are all here for a day of quite a learning experience from hemato-oncology experts for the day. And congratulate IAP Kanhangad for taking up the FOCON in a big way. My good friends in Kanhangad, proud of you all. And congratulate IAP Kerala, the hemato-oncology chapter by Dr. Guru Prasad and Dr. Jitin, all of you for making it big. And once again, I thank all my dear friends in IAP Kerala. There's no need to mention it officially. We are traveling together. We are making it together. We are traveling together, and we will always be together in this journey. I can see Dr. Sudhakaran and almost seniors, all seniors on the zone, all are around. And I don't want to mention everybody. You have all made me proud that this is a great family. So let's keep going. IAP Kerala and the hemato-oncology chapter, and wish all the participants, all the delegates here, a day of excellent academics from the hemato-oncology experts out here. And once again, wishing you all the very best. I officially declare that the conference is open, and I wish the very best for all of us who are out here in this platform. Thank you. Jai IAP, Jai Hind. Thank you.
Thank you, sir. Once again, congratulations. Next, I welcome Dr. Anandakeshavan, sir, National Vice President, South Zone, for giving keynote address.
Very good morning. Respected Chairperson, Dr. Narayanan, Dr. Guru Prasad, our leader, the true leader, Dr. Ramesh Kumar, Papetan, Dr. Balachandran, Dr. Sudharan sir, President Secretary of the Organizing Committee, IAP Kanhangad, my dear friends. ആദ്യമായി രമേഷ് കുമാറിനെ എല്ലാവിധ ഭാവങ്ങളും ആശംസകളും നേരുന്നു. രണ്ടാമത്തെ എല്ലാവർക്കും ഒരു നല്ലൊരു കേരളപ്പിറവി ദിനം ആശംസിക്കുന്നു. 3 കാരണം കൊണ്ട് മലയാളം പറയാൻ ഉദ്ദേശിക്കുന്നു. വടക്കൻ മലബാർ മലയാളത്തിൽ സംസാരിക്കാൻ പറ്റിയൊരു അവസരമാണ്. 5 ബ്രാഞ്ചാണ് വടക്കൻ കേരളത്തിലുള്ളത്. കാഞ്ഞങ്ങാട്, തലശ്ശേരി, കാസർഗോഡ്, പെരിയാരം ആൻഡ് കണ്ണൂർ ബ്രാഞ്ച്. രണ്ടാമത് കേരള പ്രവിധിയനാണ്. മൂന്നാമത് എൻ്റെ ഇംഗ്ലീഷ് അത്ര നല്ലതല്ല, മലയാളം മോശമില്ല. എനിവേ, ഗാന്ധി പറഞ്ഞ പോലെ കേരളത്തിന്റെ ഹൃദയം ഗ്രാമങ്ങളിലാണ്. രമേഷ് കുമാർ ജയിച്ചത് IIP കാഞ്ഞങ്ങാടും കാസർഗോഡും തലശ്ശേരിയും പോലുള്ള ചെറിയ ചെറിയ ബ്രാഞ്ചിന്റെ വളരെയധികം സപ്പോർട്ട് കൊണ്ടാണ്. നമ്മൾ വർക്ക് ചെയ്തത് നഗര ഹൃദയങ്ങളിലല്ല, നേരെ മറിച്ച് ഗ്രാമങ്ങളിലും കൂടിയാണ്. മീൻസ് സ്മോൾ ബ്രാഞ്ചസ് ആണ്. ദാറ്റ് ഈസ് വൈ ദിസ് മച്ച് കേരളത്തിലെ ടോട്ടൽ വോട്ടേഴ്സിനെക്കാട്ടും അധികം ഭൂരിപക്ഷമാണ് രമേഷ് കുമാറിന് കിട്ടിയിരിക്കുന്നത്. 2400 വോട്ട് ഉണ്ടെങ്കിലും നമുക്ക് 3000 ഭൂരിപക്ഷം കിട്ടിയിട്ടുണ്ട്. എനിവേ, ഇറ്റ്സ് എ വെരി ബിഗ് team work under the leadership of Dr. Narayanan and Balendran and the entire team. And I would like to congratulate both IIP Kerala and also Dr. Ramesh Kumar once again. Pediatric hemato-oncology is one of the important chapters of national IIP. Few years back, infectious disease chapter, then respiratory chapter was the best branch of the IIP, national IIP. But during last 3-4 years, continuously IIP hemato-oncology chapter is winning the best branch at national level. Today, I think under the leadership of the Dr. Pappatan, they selected both hemato and oncology chapters together, from anemia to platelet to leukemia. I think they have selected very good topics, and both advanced and also newer conventional topic also selected for this one. So I wish the CME and the conference all the success, and I would like to once again congratulate the people behind the CME, Dr. Jitin, Dr. Suvarnan, Dr. Ashwin, and Dr. Patnavan Sujeshan, all of them. Very, very hearty congratulations. Thanking you. Jai Hind, Jai IIP.
Thank you, sir. Next, I invite Dr. Balachandran, our State Secretary, to give felicitations. Balachandran, sir.
Respected President IIP Kerala, Narayan sir, our South Zone National Vice President Andeshan sir, our elect our National President elect 2021 Ramesh sir, Chairperson and Jitin, and my seniors and my friends. Am I audible?
Yes, yes.
Hello. Am I audible? Okay. So,
Your
being
voice is
elected as
breaking
the
up.
National President elect 2021, said Kerala for electing Ramesh sir to 4 years. Am I audible now?
Yeah.
I'm audible. I still remember the FOCON last year, organized by IIP Talasheri, with Jidin leading from the front, and with Santosh sir and Dr. Jalaluddin. It was a very memorable one for me, as well as the AHA conference organized by IIP Kanhangad with Praveen and Sureshan sir, organizing with Papetan and all. I still remember the reception and hospitality of both the branches as well as the academics. Today also we have very good topics. I'm sure more will join today, being a Sunday. And I congratulate IIP Kanhangad for selecting the topics as well as the excellent organization of this conference. So thank you all. Wish you a happy learning. Jai Hind, Jai IIP.
Thank you, Balachandran, sir. Next, I invite Dr. Joni Sebastian, our Joint Secretary IIP State Branch, for giving felicitations.
Respected Chairperson, Dr. Narayan sir, National President-elect and our popular leader at the National Front, Dr. Ramesh Kumar sir, National Vice President, Dr. T.M. Ananthakeshavan, sir, our vibrant secretary, Dr. Balachandran, office bearers of the chapter, as well as the office bearers of IAP Kanhangad, and of course, the time-tested leaders, the organizing chairperson and organizing secretary of Kerala Folkhorn, and my dear friends and colleagues. In fact, it's my privilege to be present here today on this very auspicious occasion. We have so many things happening today, the great victory day for us, and as far as IAP Kerala is concerned, then the Kerala Piravi Day, and also on this day of excellent scientific fiesta. As always, IAP Kanhangad, as we all know, since even though it's a very small branch, it's always there on the forefront of all IAP Kerala activities. And the branch was always done an excellent performance under the able guidance of experienced, dedicated and sincere leaders like Dr. TVP sir, Sureshan sir, Sugadan sir, and the young dynamic secretary, Dr. Ashwin. And today we have a great academic fiesta awaiting us with some excellent topics and speakers, which were meticulously selected by the organizing team for the practicing pediatricians. Wishing the conference, the Folkhorn 2020, all my best wishes and an excellent academic feast for the delegates present here today. Thank you. Jai Hind, Jai IAP.
Thank you, John sir. Next, I invite Dr. Narayan Naik, past president of IAP Kasaragod, for give felicitation.
Respected President-elect Dr. Ramesh Kumar sir, President Dr. Narayanan, Secretary Balachandra, Folkhorn Organizing Chairperson Dr. TV Padmanabhan sir, Dr. Sureshan, IAP Kanhangad President Dr. Sugadan, Secretary Ashwin, Praveen Arora, Folkhorn Chairperson Dr. Guru Prasad, and Secretary Dr. Jidin. First of all, I take this opportunity to congratulate Dr. Ramesh Kumar sir getting elected as the president-elect of IAP, National IAP. It is a proud moment for IAP Kerala. And on behalf of IAP Kasaragod, I congratulate Dr. Ramesh Kumar sir in this occasion. I also congratulate IAP Kanhangad for taking the conference and conducting the conference in this COVID season. And IAP Kanhangad is always a role model to small branches like IAP Kasaragod. I congratulate IAP Kanhangad, and I wish all the best for this conference. Thank you.
Thank you, sir. So next is my chance only. So respected dignitaries, so I first of all I congratulate our national president-elect Dr. Ramesh sir and the brilliant team effort by the IAP Kerala done behind it. And for today's conference, it is indeed a privilege for me to be here. So last year I was given the secretary post for this chapter. As already all the dignitaries told, that it's a growing specialty, especially in Kerala. At national level, they are doing many activities, but we are still to catch up. So this year we are conducting the conference by IAP Kanhangad. I congratulate them for making this effort. Hope for an academic fiesta today. Thank you all. Next, I welcome Dr. Sugadan, we are President IAP Kanhangad, for giving vote of thanks. Sugadan sir.
Am I audible? Yeah. Good morning, all. Respected Chief Guest, the National President-elect Dr. Ramesh Kumar, Chairperson Dr. M. Narayanan, South Zone Vice President Dr. Ananthakeshavan, Endocrinology Chapter President Dr. Guru Prasad, Secretary Dr. Jidin, State Secretary Dr. Balachandran, Organizing Chairman Dr. T.V. Padmanabhan, and other dignitaries, faculties, and delegates. It is my proud privilege to propose a vote of thanks for this wonderful academic event. On behalf of IIT Kanhangad and Hematology Chapter, I first express my vote of sincere gratitude to Dr. Ramesh Kumar sir for inaugurating this conference and chairing one of the sessions. I would like to thank State President Dr. M. Narayanan and South Vice President Dr. Anantha for gracing this occasion and chairing the session. I express my sincere thanks to State Secretary Dr. Balachandran for facilitating this occasion and for providing the IAP Zoom platform for this event. I express my gratitude to high extent for the Hematology Chapter President Dr. Guru Prasad and Secretary Dr. Jithin for the wholehearted support for arranging and conducting this academic event. I express my sincere thanks to Dr. Johnny Sebastian, Joint Secretary IAP Kerala, Dr. Narayana Naik sir, Past President IAP Kasaragod for their felicitation. I express my sincere gratitude to all the faculties who spared their valuable time for this academic feast. I also thank Dr. Mohandas Nair sir for chairing one of the sessions. I express my deep gratitude to all delegates whose online presence made this conference successful. Last but not least, I extend my sincere gratitude to our organizing chairperson, Dr. T.V. Padmanabhan, organizing secretary, Dr. B. Sureshan, our secretary, Dr. Ashwin, treasurer, Dr. Praveen Arora, and all the members of IAP Kanhangad whose teamwork made the academic event to happen. Thank you all once again. Jai Hind, Jai IAP.
Thank you, sir. So next, we will move on to the academic session. Yes. So I invite Dr. Ramesh sir. I think he needs no introduction. He is the president-elect of Central IAP now, and he's a HOD. HOD and senior consultant of pediatrics in Apollo Adlex Hospital, Kochi. I invite him for moderating session, sir. So we have speaker introduction, sir. Okay,
Yes,
sir. So
Jithin, please have the speaker introduction. I have not shared the CV.
sorry, sir. Sorry for the delay.
What else can I take up? Okay. Good.
No, wait a minute, sir. I will share the screen.
No worries. That will be in the presentation. Okay. So good. Yes. So good morning, my dear friends in Hematology Chapter, IAP Kanhangad, IAP Kerala, and all the delegates who are out in this platform to enjoy the day of academics from hemato-oncologists. I'm so proud about IAP, the FOCON arranged in a big way by IAP Kanhangad, IAP Kerala, and Hemato-Oncology Chapter. And once again, I take this opportunity to congratulate the organizers for having a good amount of academics in the platter in French. Well, friends, we have got as an opening batsman, we have got Dr. Nitha Radhakrishnan with us as the prime faculty for the day. And Dr. Nitha is personally known to me as a great friend, and I've met her at 2-3 Predicons, and I've listened to her, and I'm so enamored of the way that she has gone through the quiz presentations we have had from her. She is the assistant professor and in charge of the Department of Pediatric Hematology Oncology at the Super Specialty Pediatric Hospital, Noida. She's a fellow in hemostasis and thrombosis from the University of Milan. In added on, she has the fellowship in pediatric hemato-oncology, and she has been there as the nodal officer for the hemophilia hemoglobinopathy services, Kodambutha, that is the Noida. and she has been the Vice President of the Indian Society of Primary Immunodeficiencies, the sub-editor on the editorial front, and she has been the sub-editor of the Pediatric Hemato-Oncology Journal Special Edition and section editor for Pediatric Hematology Oncology Journal. And a lot of academics backing up, a great speaker, a versatile person. I know her well in all the many of the sessions. We are proud to have Dr. Nitha Radhakrishnan with us as the speaker for the day. And well, she will be discussing about something which is a very mostly for the practicing pediatricians, the interpretation of the complete blood count, CBC. We have been learning CBC right from our medical school, any amount of time, but still we feel a lot much is left. And many a time we can take a very, very optimal decision. We can narrow down the diagnostic spectrum if we go through the CBC in a big way. Many a time we don't look at the CBC, the bit band, the platelets, or other so many parameters are there what we get from the hemogram. So well, we are sure Dr. Nitha will enlighten us on how best to go about the CBC, how best you can utilize the CBC to narrow down your diagnosis and to point as a pointer for the approach to many confusing dilemmas in clinical practice. Well, I invite Dr. Nitha to open the session and have her deliberations. Please, ma'am.
Thank you, sir. Can I share my screen, Jitin? So before I start, Rameshan sir, ഒരുപാട് സന്തോഷം news കേട്ടതില്. And I think you have achieved something which was unimaginable many years ago. And staying in Delhi, I've seen how people take all this very so seriously, and I know the amount of politics that goes behind it. So great victory. All the best to you, sir, for your tenure. Before I start, I would like to thank the Indian Academy of Pediatrics Kerala chapter, the Hematology Oncology chapter, and IAP Kanhangad for this kind invitation. It's a big privilege for me to be talking in this forum. There are teachers, my teachers are there in the group, and so I hope I give justice to the topic. So before further ado, I'll just start the session. So my topic, the topic given to me is interpretation of CBC. Like you know, CBC is probably one of the most single informative investigation that we have today. Hello, can you hear me? Hello.
Yes,
Clear, right? Yes. Yes. So CBC over the years, even when the time we were students, CBC used to be, it used to be a completely manual process, as in we used to be looking at Newbar's counting chamber and peripheral smear for counts, platelet count and hemoglobin, and it's usually mostly a manual process. From that, it has evolved to a semi-quantitative process, and now it is completely fully automated. And the way for these automated hematology analyzers have kind of taken over everywhere, that is commendable, because even in the smallest of towns and the smallest of laboratories, fully automated analyzers are available now. So with this kind of standardization that is there, very few things actually can go wrong. And if we actually pay attention to the CBC report of an automated analyzer, many like sir just said, a lot of decisions can be based on this one report if we pay attention. So technically, we generally look at hemoglobin, we look at platelet count, and we probably will look at a WBC count and differential if maximum. So if you're suspecting sepsis or something, we'll look at differential. But a lot more information can be gathered from a CBC report, and that's what we'll see in the next few slides. So these are the information which is usually given in a normal automated hematology analyzer. And in addition, there are so many other newer automated analyzers and newer channels that can be set in, which also give us additional information. So I'll just run through what is normally seen and what can be normally done in an OPD practice. So like we know, CBC, the sample is usually taken in an EDTA vial, and we should be aware that it should be collected properly, and there should not be any overfill or underfill. If that is the case, then the reports can go wrong. And when should we run it? It should be run as early as possible, because the more you keep it, there can be artifactual differences in the size of the red cell, inclusions which can come in, and platelet numbers can also go down. So all these abnormalities can come in if you are if you're taking sample and the sample is being run the next day morning, then it would be then all these things can come in. So if you are sending a sample, preferably send it to a laboratory which would analyze it immediately. And technically, anticoagulated samples can be kept at powder grades for up to 24 hours, but that is not preferable. It's preferable to analyze. So this is a normal photograph of a normal hematology analyzer, nothing fancy. So these are the three sets of, these are the three channels in it. These are the three sets of information we have. We have a red cell channel, which will give us hemoglobin, which will give us red cell count. It will give us hematocrit. It will give us MCV, MCH, and MCHC. We will see what these are. And it will give us what is called a red cell distribution width. We have a WBC channel, which this one is giving a 5-part differential. Many WBC channels would go as a 3-part differential. And then we have a platelet channel, which is giving us a platelet count and a mean platelet volume here. This is a standard hematology analyzer. But in addition to these numbers, on your right, we have some more information that is available. It is giving out a RBC histogram, which is what is there in red. And this actually can give us more information than an MCV does. It is giving a platelet histogram, which also will give us more information than a platelet MPV can give. And then there it is giving out some information on the WBC series, basically the granularity and the size of the cells, which are. So it's exactly, these information, if we start putting it into practice, that can help us in a great way. So we'll start with the red cell series. So this is our normal RBC. It is biconcave shape, and because of which there is a central, if you look at it from above, that gives us this area, because it is biconcave, there is less cytoplasm there, and because of it, when you look at it from above, it's giving a central pallor to it. And this is the in the machine, in the automated analyzer, when we see these three numbers come up, one is MCV, one is MCH, one is MCHC. So what is this? MCV is the average of the size of a red cell. MCH is the average hemoglobin content in the red cell. And for a single red cell, what is the amount of hemoglobin which is there inside the cell? That is called an MCHC. So these are the red cell parameters that we usually have. Some of them are directly calculated, some of them are derived variables. It doesn't matter to us. For us, we are getting hemoglobin, we are getting hematocrit, and these numbers. So if anybody wishes to know, this is how it is calculated, but we hardly go into it. And then there is something called red cell distribution width. So how is this important? So as the cell size decreases, so this is a normocytic cell with a central pallor which is around 1/3. As the size becomes smaller, it is microcytosis, and as the size becomes larger, it's called macrocytosis. And this is a normochromic cell. And as the cell becomes less, has less and less hemoglobin, that is becomes hypochromic. And if it has more, or if it is a shape is altered, it is often called a hyperchromic, because it does not have that central pallor anymore. MCV in children, normally in adult value would be around 80 to 94 femtoliters, and this is 87 plus or minus 7. This is the normal adult value. But as pediatricians, we are not supposed to be going by the normal value. Even if the lab is giving out this report, that is not what we usually follow. For MCV in children, there is a formula. For the lower limit of normal would be 70 plus age in years. So for a 2-year-old child, the lower limit is actually 72. So if you get a 75 or a 78, it's going to be a normal MCV for that child. Upper limit of the MCV would be 0.6 into age plus 84. So it is basically 84 upwards, and upwards you can calculate it easily as 0.6 into age. So it's roughly between around say 75 to 90 would be roughly the normal in our pediatric practice. If it is very, very high, so generally we know it is low, we see it in iron deficiency anemia. If it is high, you see in macrocytic cells, which are usually part of megaloblastic anemias. But at times we get very high MCVs, like 120, 130, etc. Then we know there is something wrong with the way it is calculated. So maybe the machine, instead of calculating one red cell like this, there are a couple of red cells which are clubbed together. This happens commonly in red cell agglutinations as part of autoimmune hemolytic anemias, When this is happening, the machine is reading this entire mass as one red cell, and that is why this falsely high count is coming. Also, if you have a lot of immature cells in the circulation, like reticulocytes are there, that also are slightly higher than the normal red cell size, and that also gets falsely taken up, and that also can give a high MCV. So there are conditions where MCV can be falsely high. MCH is basically the hemoglobin content, essential hemoglobin content, which is a degree of hypochromia. That is that can help us in adding to the classification of anemia. And the third parameter is MCHC. And again, this does not really help us much in routine practice. It can just, it is basically a quality control for the machine. But there are conditions where there is the MCHC is what? MCHC is the content, the concentration of hemoglobin inside a single red cell. So if a single red cell becomes dehydrated, or a single red cell is smaller with a higher volume of hemoglobin, higher proportion of hemoglobin, that is when the concentration per cell is going to increase. And this you commonly see in conditions like sickle cell disease, where cells get dehydrated, and condition like spherocytosis, where the size of the cell is actually become low, so that the concentration of hemoglobin is come. So these are the only two practically important conditions where MCHC goes up. Rest of it, MCHC is essentially a quality control, and MCHC can be low in any anemias. So now MCV based, how do we classify? So we'll just go one by one. So MCV we finished, and MCV helps us tell us if the size is small, the size is normal, or the size is high. And small ones we usually see in iron deficiency or beta thalassemia traits, small red cells. These are the rarer conditions. Those highlighted in red are more common. A normocytic cell with anemia, you see usually that it is because the bone marrow is not able to function properly. This actually can occur any infection with anemia. It can occur when there is a bone marrow failure like aplastic anemia, or even when there is a blood loss that happens, that can present with normocytic anemias. Acute blood loss. When there is chronic blood loss, an element of iron deficiency starts setting in. And then the larger cells with anemia, you will see in B12 as well as folic acid deficiency. We can see in Down syndrome. There's a talk later on Down syndrome. So Down syndrome, again, physiologically, you will have larger cells. Newborn babies will have physiologically larger cells. Hypothyroidism, or these conditions can also have macrocytic cells in circulation. So this is about the number MCV. But the same information, probably better information, can be derived from the histogram. So this is a histogram which I showed the earlier curve, which is a red colored curve that we saw in the initial Coulter report. So this is how it is plotted, like a Gaussian curve. So when this is a normal distribution. So when the MCV is slightly high, this starts increasing like this. When the MCV is low, it is pushed to the left. And then when there are two types of cells. So suppose there is iron deficiency and B12 deficiency coexisting in a child. If we calculate MCV, it might be normal, it might be high. And it might be very low if depending on the degree of iron deficiency versus B12 deficiency. So MCV per se, because it's just an average of the numbers, it might be fallacious. But if you look at the curve will definitely show two different peaks. It shows a dimorphic population. For example, if it's a child with iron deficiency anemia who's received a transfusion. So example, just imagine this is a child who was anemic, the MCV was low, and he has received a transfusion and is coming to us. And because of the transfusion, the average MCV now has come back as normal. But the one look at this histogram can tell you there are two different populations of cells which are circulating in the child. And this is the additional information that we get. So here is a girl. She's a 13-year-old girl with a hemoglobin of 6.9. So when I look at the red cell channel, the first report that I want to see is once I look at the hemoglobin, which says that the hemoglobin is low, the next information that we want to get out of it is what is the MCV, and that helps us mentally classify it into microcytic, normocytic, and macrocytic. So here the MCV is coming as 67.1. MCH and MCHC are also parallelly low. So for me, this is a straightforward nutritional anemia from the red cell parameters. So the red cell parameters, if I look at this histogram also, that is also slightly shifted to the left, which tells me that it's probably a nutritional anemia, that is iron deficiency. But if you look at it, one more step of it, like in what do I expect in a normal straightforward iron deficiency? A normal straightforward iron deficiency should have a normal WBC count. There should be no problem in the WBC series at all. and the platelets are usually higher than normal. So these two informations are additionally going to help me in telling that this is just simple iron deficiency. But in this child, this 13-year-old girl has a WBC count which is slightly on the lower side, and a platelet count is also not high. It is normal, but it is not high. So these two things again tell me that maybe this is not just a nutritional anemia, only iron deficiency. Maybe there is something more. I would want my pathologist to see the smear and tell me whether there is any additional feature of B12 deficiency in this child. So these kind of information can be gathered from a CBC report, even without the iron levels or B12 levels, etc. This information can be easily taken out. Now the next information. So after MCV, MCH and MCHC, the next thing that we can gather from a Coulter report is what is called a red cell distribution width. So red cell distribution width is a statistical term. What is it? It is the distance between the RBC. So here, this is a normal peripheral smear. Imagine the red cells are almost looking each, they're almost same. They're all of them are similar looking, and the distance between the red cells also would be almost the same. There's no wide variation in this. So when this red cell, the distance between the cells or the distribution width is calculated and it's plotted, this is how it is going to come out as. It's a normal distribution here. But imagine a child who's having, say, B12 deficiency. So you have large cells which are circulating in the circulation. So the distance between a normal cell and a large cell is going to be different. Some of them will be closely spaced, some of them will be far spaced. So because of that, the average distances are going to increase, and that is why this basically tells us this red cell distribution width is the distance between the red cells, and it is a measure of the size of the red cell. So if my RDW is increasing, I know that there are red cells of different sizes in the peripheral smear. That is all that information is in. And if you actually look at it very closely, many a times we don't need a peripheral smear to go ahead. So the information which is given out is pretty good if it is a very well standardized machine. And this is given out in two forms. Some machines report it as standard deviation, some machines report it as coefficient of variance. The normal levels are also given. So let's see how it can help us. So here you have a child who has a hemoglobin of 3.5 and a red cell distribution width is coming as 24. So you have an MCV of 36. So extremely microcytic cells, low anemia with extreme microcytosis, and a red cell distribution which is coming as 24.2. So in this same child, when you're evaluating post a transfusion, you can see even the histogram is telling you the same information. The red cell distribution width also gives you the same information. There are cells of different sizes that have come up suddenly, and that is why both the RDW has increased as well as the MCV has increased just because of the transfusion that the child has received. So based on now, with anemia, we had hemoglobin, we had MCV, and one additional level of complexity if you add, you can have hemoglobin, MCV, and red cell distribution width. And red cell distribution width just tells you, in practice, what happens is red cell distribution width is increased only in nutritional anemias. That is a simple dictum. So if you have microcytosis with increased red cell distribution width, it is iron deficiency. If we have macrocytosis with increased red cell distribution width, that is usually B12 or folic acid deficiency. So these two things, very, very useful investigations, which in one go tell you that this is okay. So suppose it is macrocytosis, but the red cell distribution width is coming back as normal, then I would be worried. Then I'll think that it is the red cell distribution width is normal means bone marrow is producing cells at the same size. So there is no nutritional deficiency in that child. Then what is the problem? Why is there anemia? The anemia and macrocytosis would be because there is some other problem in the bone marrow which is not producing cells properly. So that would make me think decide for a bone marrow aspiration and biopsy further. So this is like again a quick reckoner which can come out of your CBC reports. Now another dictum in CBC reporting for red cell series is a rule of 3. Basically, when you have a hemoglobin, when you have RBC count, you have hemoglobin, and you have MCV. So these three informations are available with us immediately whenever you look at a Coulter. So this is a Coulter report that has come out. So the dictum is that the red cell RBC count into 3 is the usual hemoglobin that we have. So usually we know around 3.5 million RBCs are if 3 or say 4 million RBCs are there. And 4 into 3, that is 12, would be your normal hemoglobin. So this is a very easy calculation. So whenever this dictum is not followed, then you know that there is something which is wrong in the study. Then that is not your normal pattern of reporting. So here is a child has come with a hemoglobin of 10 grams and a MCV of 59.6. So hemoglobin of 10 is less than 11, definitely anemia. And MCV is 59.6. That means there is significant microcytosis. So I should feel that this is the commonest causes of microcytic anemia are 1, iron deficiency anemia, and 2, at least in this population, North Indian population, the first thing we'll think of is beta thalassemia trait, the second differential after iron deficiency anemia. So now, if I want to proceed without doing an HPLC, what will I look for? I will look for a RBC count. My RBC count is coming as 5.7. For a normal nutritional anemia with a hemoglobin of 10, my RBC count should have been somewhere in 3.5 bracket. Here it is coming way more than that. So here it means that the bone marrow, it is not a simple nutritional anemia. In a simple nutritional anemia, as the hemoglobin comes down, the bone marrow production of red cells is coming down. So your RBC count is actually coming down. It is proportional to the degree of anemia. Whereas in a beta thalassemia trait, because of the degree of anemia outside, the bone marrow is overworking. The bone marrow says, no, I want, if the hemoglobin is 10, the bone marrow will work more to push more red cells out. And that is why your RBC count is high. And this will definitely tell me that there is a possibility of an underlying beta thalassemia trait that I should worry about, because the simple rule of 3 is not working in this calculation. So iron deficiency anemia, you get red cell count, which is proportionate low, and beta thalassemia trait, your red cell count is increased to your degree of anemia. I hope that is clear. So even without RDW, this rule of 3 is actually helping me differentiate between an iron deficiency anemia and a beta thalassemia trait. So this, although these two pictures have come from two different sources, this is what I want to say. This is a hypochromic microcytic blood picture. Both of them are hypochromic microscopic blood picture. The one on the right, if you can see, they're all uniform cells. It looks like they have come out of a factory that just produced from the beginning. They're all uniformly small cells which are hypochromic, which are being produced. So this is a typical pattern you will see in beta thalassemia trait, where your hemoglobin will be low, your MCV will be low, your red cell distribution width will be normal, because the distance between, there are no big cells and small cells here, because all the cells are almost same, and the red cell distribution width will be normal in this group of, in this, if we do in this Coulter report. Whereas on the left side, if you see, iron deficiency anemia is not starting on one day. It would have started, say, 3 months back. So the red cells which were initially formed would be little normocytic cells with hypochromia. As the degree of iron deficiency anemia increases, more and more microcytosis sets in, more and more hypochromia sets in. So you have different sizes. So cells they're not produced on a single day, they're not being produced small. There is a degree of microcytosis that is coming. So there are normal cells, there are smaller cells which are also coming. So your distance between the cells are going to be different. So again, hemoglobin low, MCV low, but here my RDW is going to be high. And that is, again, this is how a peripheral smear would look like. Even without this, a CBC can also tell you the same information, provided it is done properly. So this was about the red cell channel of a CBC report. Another investigation which helps us in a CBC is a reticulocyte count. Why I am mentioning it with the CBC itself is that many of the newer automated hematology analyzers can actually give us a automated reticulocyte count nowadays. So even without a peripheral smear and a reticulocyte count being done manually, we do have this information also available. What is a reticulocyte count? Reticulocyte count is an immature red cell which has come out of the bone marrow. So if the red cell count, if immature red cells are coming out, that means that the bone marrow is working more than that is normally supposed to work. So these are the red cells. And when they are immature cells, they have what you call RNA in those cells. And because there is RNA, so the nucleus is extruded out of the, when the cell is developing, after the pro-erythroblast stage, the nucleus is coming out, but the cytoplasm still has RNA in it. And this RNA can be measured by what is called a supravital staining. For postgraduates, supravital staining means you are not fixing the cell and we are not killing the cell before we are putting a dye. These are stains put on live cells, and this cell, the stain is called supravital staining. And this stain is picking up the RNA in the cell. And these are live RBCs when this is being tested. And this actually, if the reticulocyte count is high, that tells you that the bone marrow is functioning more than it normally should be. If the reticulocyte count is low, it means that's less functioning. And again, to make it more streamlined, you can correct it for the degree of hemoglobin. So if your reticulocyte count is, hemoglobin is say 5 grams, and then you get a reticulocyte count of say 5%, you want to know whether that reticulocyte is corrected for that degree of anemia or not. And that is what you look at, corrected reticulocyte count. You can correct it for the hemoglobin, or you can correct it for the PCV also. It's the same, essentially the same calculation. And similarly, there are other calculations for absolute reticulocyte count and production index, etc. Always mostly helpful for aplastic patients. So from MCV based calculation and RDW based calculation, there's another degree of complexity now, that if you can add a reticulocyte to this complication. And reticulocyte count helps in two situations for us. One, we need to know if there is hemolysis or not. So if you have a low hemoglobin situation where you are not considering anemia, nutritional anemia, you are considering hemolysis in the child, whether it's peripheral, there is some jaundice, there is an organomegaly also, there your reticulocyte count definitely will help us. If you have an acute drop in hemoglobin, a child who has come in with fever followed by dark colored urine and a hemoglobin which has suddenly dropped, you are suspecting either a autoimmune hemolytic anemia or a G6PD, there again your retics would be very, very high. That helps us. So I isolated anemia situations, retics definitely help. It also helps in conditions where there is normocytic anemia, or maybe there is pancytopenia associated, where you want to know how is the bone marrow functioning. Should I really go ahead and do a bone marrow? In those situations also, the retic in hypoproliferative states, retic will be low. Whereas in conditions where it is megaloblastic anemia, it would be essentially normal reticulocyte count or slightly low. It does not be very, very low. So these are practical situations in routine practice where a retic count can be put to use. The second channel in that Coulter report was the WBC series. WBC series, classically, we've been looking out from the peripheral smear, and there is a manual way of calculating differentials. But nowadays, the machine reports it as it's almost like it's a laser technology that is used. Each single cell is being analyzed by the laser for the size as well as the complexity of the cell. And there is a scatter plot which comes out of it. So from this plot, we know that how complex the cells are. So in a normal WBC series, you have cells which are highly complex, which would be the neutrophils because they have granules inside them. They are less smaller size cells which are less complex, that would be the lymphocytes, and the larger cells which would be the monocytes. So this is essentially what we get out of a 3-part or a 5-part differentials. So these are two children. These two children have essentially the same hemoglobin. If you can see, hemoglobin is 3.19 here and it is 3.09 here. This is a girl who is like around, I think she's 15 years or so. I don't, the age is not shown. She's 15 years. She's come with a hemoglobin of 3 grams. And this is a child who is around 9-10-year-old boy who's come with a hemoglobin of 3.19. So if I look at the WBC series, again, WBC series is 1,800 WBCs, here 1,900, almost essentially ditto children. And neutrophil count is, so there is neutropenia here and there is neutropenia here also. There is thrombocytopenia here and there is thrombocytopenia here also. But what is the additional information that is helping me make a differential without going ahead with the reticulocyte count or a smear or a bone marrow is the MCV. So if you can see, sorry. So if you can see here, this is so let's see this child first. So it's a 3.9 hemoglobin with an ANC of 215 with a platelet count which is less than 5,000. Extremely severe thrombocytopenia in this child, and an MCV which is coming as 98. 98 is like the upper limit of normal for this child. So here is a child, in this child, I would probably consider this is a bone marrow failure syndrome. A retic would definitely help me, and a bone marrow definitely should be done for this child. And in this child, because the MCV is not very high and there is severe anemia and very severe thrombocytopenia, I'm not even considering anything else other than a bone marrow failure in this child because of the mere fact by the degree of thrombocytopenia in this child. Whereas if in this child, if you see the MCV is coming as 119, definitely very, very high MCV. And in this, and platelets are low, but not very low either. So I would probably ask for a smear first in this child and ask them to look for hypersegmented neutrophils and additional features of megaloblastic anemia in this child. And if there are very classical features of megaloblastic anemia, may avoid a bone marrow in this child, then just straight away start treatment for B12 deficiency in this child. So this is how a well-read CBC can actually help us differentiate between different conditions. Although parameters are almost the same, but there are additional information which is available. So after red cell and white cell series, now we have the platelet count. Again, earlier we used to have manual platelets where you have the rough calculation as 1 platelet per oil emulsion field would be approximately 15,000. For postgraduates, if you see 1 clump in a peripheral smear, that is equivalent to 1 lakh. So that is enough, and there is no need for any further, you don't really have to go through. So again, a platelet gives you a similar histogram which is there, and information like this is a normal platelet, but here you can see there are some things which are going on abnormal here. This is because there are very, very small cells which are there. These are probably fragmented red cells which are coming here, extremely left. Whereas here, there is a second peak which is coming here, which tells you that there are large platelets which are there in the circulation. So the machine may not pick it up, but a histogram definitely tells us that. So before when we get a patient with thrombocytopenia, the first thing we look for is, if it is unexpected, then you ask yourself, is it correct? Is it true thrombocytopenia or is it pseudo thrombocytopenia? Many a times in children and even in adults, we can see conditions where platelets may be falsely low. So this is one condition where there is EDTA depend. I told you that EDTA is the anticoagulant of choice when we run CBC samples, and this EDTA, the normal people, around 0.1, 1 in 1,000 normal people can have what is called naturally occurring anti-EDTA antibodies. So if I take my sample, if I have this antibody inside me, and if I take my sample in EDTA, all my platelets are going to clump to each other, or it is clumping around a neutrophil, and this is called satellitism. And because of which, when the machine rates it, machine cannot pick up these clumps. Machine will just look at small fragments which are supposed to be in the platelet channel. And because these clumps are there in the periphery, the machine does not pick it up. The machine also will not pick up if there are fibrin threads in the circulation. And because of which, many a times false reports of platelet count can occur, especially in small babies when we are taking out samples like this, one drop by drop when it is falling into the tube. Coagulation can start inside itself. And many a time this fibrin mesh comes inside the tube itself, and especially if it is not shaken properly, and this can lead to false thrombocytopenia. And when this happens, if you are suspecting an EDTA dependent thrombocytopenia, then you take a sample in citrate or heparin and run it. The same platelet count can be run, or you look at a manual platelet count with a finger prick. You can take a smear and see. Another information which you will get from the platelet channel is the mean platelet volume. Mean platelet volume normally is between 7 to 12, and this means the average size of a platelet. So if you have smaller platelets, that means the bone marrow is not functioning. If you have larger platelets, that means the bone marrow is hyperfunctioning. So if you have large platelets with low platelet count, that means there is some peripheral destruction happening. The platelets are being produced more and more by the bone marrow. Another information which we get is called immature platelet fraction, which is given out by many machines these days. Immature platelet fraction means it's exactly like reticulocyte count. It is the immature part of the platelet which still has RNA inside it, and it is just prior to the platelet series. So just prior to the peripheral release of platelets. So when you have immature platelet fractions coming up, that means that the bone marrow is functioning properly and platelet counts are going to increase. This is helpful, especially when you look at it in a trend. Like say, suppose you have dengue fever, and if your platelets are like 5,000, but if your immature fraction is high, that means that the bone marrow already has started recovering, and in a day or two, your platelet count is going to increase. So you don't have to really worry about transfusions. Even though the platelet count is 5,000, if the child is stable, you might hold off transfusions. So this is how information helps, and this for dengue, this has been put into practice as well. So if you have, again, thrombocytopenia approach, I'm not going into these details, but one period around 2 for the evaluation. And when you see essentially red cell series for a 4-month-old baby, this is okay. And platelet also, WBC series also, 4-month-old baby, 17,000 TLC, neutrophils of 2,000 is normal. There is a physiological lymphocytosis that you see in this age group. So that part is also okay. When I look at the platelets, platelet count is around 20,000. MCV is coming as 7.4. So what am I considering in a 4-month-old baby, otherwise well baby with severe thrombocytopenia? Possibilities are neonatal onset, all those conditions like neonatal alloimmune, isoimmune thromb, all that would be out by now. By 4 months, all that should have recovered. So I am basically left with conditions that are inherited thrombocytopenias. Since it's a boy, one of my differentials is Viscott. I can easily rule it out based on an MPV itself. And this child, when we further evaluated, this child turned out to be congenital amegakaryocytic thrombocyte. So it's an inherited thrombocytopenia with a normal MPV. So again, there are some conditions like Bernard-Soulier and May-Heglin. All those conditions will have macrothrombocytopenia. So these information can come out of a CBC report quite easily. And the last part of a CBC analysis is definitely a peripheral smear. Even though we get a lot of information from the CBC Coulter itself, still we can't rule out, we can't replace a peripheral smear. So, and peripheral smear is usually read like this. So how would you practically approach a CBC? Always when you have a Coulter report with you, look at it whether it is a single cell line or it is a bicytopenia or a pancytopenia. If it is just low hemoglobin that you're getting, check the MCV first, the RBC histogram first, and may need an RDW to tell whether it is nutritional anemia or not. If you have only low platelets, you check MPV, you check the histogram, decide whether you want to do a bone marrow, you want to do how to proceed with that, whether it is ITP, sick child, well child. And if it is bicytopenia or pancytopenia, then you look at the neutrophil count. Differentials are very, very important. If the ANC is low, then you know there is a marrow failure that has started, marrow is suppressed or bone marrow is failing. MCV helps us in pancytopenic situations also, especially for megaloblastic anemias. And the degree of thrombocytopenia, like I just demonstrated, severe degrees of thrombocytopenia is usually associated with bone marrow suppression. And always ask for smears where you have normocytic, macrocytic anemias. Always look for peripheral smear. Microcytic, hypochromic, single line involvement might just avoid a smear and just treat with iron. All thrombocytopenias ask for a smear. All pancytopenias ask for a smear. I'm just skipping this part just to show a couple of more interesting. So now we are all facing this COVID-19 crisis. In COVID-19 also, there is a lot of information that can be got from a CBC. COVID-19 CBC always show lymphopenia in the acute phase. The immediate, in first 3 or 4 days of fever, there is significant lymphopenia and neutrophilia. So an 8,000 WBC count with 7,500 neutrophils and 400 lymphocyte in this day and age should be COVID unless otherwise proved. There would be monocytosis like we see in IMN. This information is there. Like we see in typhoid, we do get eosinophilia in COVID-19 as well. So one of the classical, especially now that in December, January, we're going to be seeing influenza with COVID-19. So eosinopenia is again going to help us differentiate between influenza and COVID-19 because eosinopenia is a classical feature of COVID-19 and not this thing. And peripheral smear would show you, like in IMN, we will see reactive lymphocytes. We can see some unusual neutrophilic inclusions which have been described for COVID-19 and some other pictures as well. And these pictures actually, this degree of lymphopenia is found to be prognostic in COVID-19 as well. And I think I'll end this talk here and I'll be happy to take questions. And before I conclude, just one more line that we have to familiarize ourselves with what is beyond hemoglobin, TLC and platelet count. If we start looking at the red cell indices more and start correlating with our peripheral smears and start looking at trends of recovery, that will give us a lot more information. Thank you.
Thank you. So we will have questions after this session, actually, 2 talks. Due to some reasons, Ramesh sir has to leave this meeting. So I invite Dr. T.V. Padmanabhan sir to continue the session. Padmanabhan sir. Nidha ma'am, can you stop sharing the screen?
Sure, sorry, sir.
Padmanabhan sir?
Am I audible?
Yeah, now audible, sir.
Thank you, Dr. Nita, for that lucid presentation on a common topic, but very important topic. It was quite enlightening. Most of the time, we read the CBC reports with a flourish, ignoring many aspects, which I also was doing till I heard your talk. These histograms and all are generally practitioners choose to ignore, but it should not be ignored. That is the lesson I learned today. So, Kusum sir, welcome. Which session? Same. Okay, questions we will have it after the next session. The next session is evaluation of anemia in children. It is by my neighbor, Dr. Harsha Prasad is from Mangalore, KMC Hospital, Mangalore. He is a consultant pediatric oncologist. And KMC is a very, very familiar place for us. So Dr. Harsha Prasad is here to deliberate on evaluation of anemia in children. His areas of interest is blood cell disorders in children, immune-mediated cytopenias, acute lymphoblastic leukemia in children, supportive care in cancer, and primary immunodeficiency disorders in children. So over to you, Dr. Harsha Prasad.
Shall I share the screen?
Yes, sir. You can start the sharing, sir.
Yes. First of all, I would like to congratulate Dr. Ramesh Kumar and IAP Kerala branch for winning this election and to become president-elect. And I also thank Dr. Jitin, Dr. Sureshan, Dr. Ashwin for arranging such a wonderful meeting and inviting me to talk on evaluation of anemia. And I would also like to thank Anita, who did a wonderful presentation analyzing the complete blood count Coulter report, and that make my presentation a little quite easy. So thanks, Nita. Now, coming to the objectives of my presentation is to know the common causes of anemia. How can we investigate? How can we pick up non-nutritional anemia in a pediatric outpatient clinics? And to understand how do different kinds of anemia present. So in the next 30 minutes, I would briefly touch upon the history and examination, which is essential for any evaluation of any problems or any patient, especially so in a case of anemia. What I would do, I will go through a case which I have been seeing and managed in a child for the last 5 years. And in between the case findings, I would discuss upon why I did that test and what are the implications and how do we evaluate in such scenarios. So this is about a boy, currently he's 6 years old, but I have seen him first at the age of 15 months in 2015. He was referred to me for evaluation of anemia by a pediatrician as he wasn't responding to the iron supplement for a month. They thought it is iron deficiency anemia and they have treated with iron supplement, but not getting better. So when someone refers to a child with anemia, so again, the clue is history, detailed history and examination. So first of all, we would like to know the age of the child. So how does that matter? If a neonatal anemia is entirely different, anemia in infancy is different causes. Usually iron deficiency anemia you do not see in less than 6 months old children. So that's why age is quite important. For example, very rarely transient erythroblastopenia of childhood, which comes around 2 years of age. The Fanconi's anemia, usually bone marrow failure syndrome, presents usually after 4 years of age. So age is very important to know the type of anemia they can have. And then the onset, how long this been symptomatic, is that short history or long-standing history? And that also gives, if someone has been having long-standing history, usually it is nutritional related or bone marrow failure related rather than hemolysis. Then we need to know the sex of a child, whether it's a boy or girl. Some of them are inherited causes of anemia, especially X-linked if it is G6PD deficiency after having some medicines develop sudden anemia. If it is a boy, you can think of some kind of RBC enzyme deficiency, and that's why you need to know them. Caste, usually we do not ask a caste in as such, but in some conditions of hemoglobinopathies, as you know, in Gujarati community, Sindhi community, Mahad community, and some communities in Bhatkal, some GSB community, some Gauda community near Sulya. So you need to know the caste and the region where they are coming from as well to get to know what kind of anemia. And especially in tribal hills and foothills, we do see some sickle cell disease cases as well. And we need to know detailed dietary history, kind of, was it an exclusively breastfeeding child when we started weaning? And is there any history of suggestion of pica? So is there what is the amount of cow's milk protein the child is taking? So that's also very important to evaluate as well. Coming back to recently, I had 2 or 3 cases were referred because of anemia. But when you take detailed history, you know there was some problem with the bowel problems, having alternate constipation and diarrhea. When diarrhea having 3 to 4 times, little bloated tummy, tummy pain, intermittent going on for 3 years, 2 to 3 years, you know you are dealing with some kind of gut problem. It could be inflammatory bowel disease. If the child is an adolescent girl, you need to take the detailed history of menstrual periods as well, which could be the reason for anemia in those children. And the drugs and infections such as malaria also helps us to come to the conclusion. If child already been on iron supplement and not responding to iron, so you need to ask in detail, what is the dose of iron? What is the molecule of the iron? What frequency are they administering the iron supplement? Is the child compliant? And how they're taking that iron supplement, is with the food, without the food, with the milk, without milk. So that all gives some kind of to us to analyze further. We also need to know whether the child has got developed jaundice, what kind of child has got the urine, because jaundice and color of the urine, high colored urine or dark colored urine, it may be some kind of intravascular hemolysis. So that will tell us to go towards another direction. Also very important to know the birth history. Was the child born prematurely? Premature children known to develop anemia. So you need to know that. Was the child had neonatal jaundice? Did the child require exchange transfusion? Because usually that tells us we are dealing with some kind of hemolytic anemia. We also need to know the neonatal surgery, some kind of congenital anomalies or atresia, strictures in neonatal age group could be a manifestation of developing bone marrow failure like Fanconi's in the later age group. Family history, whether it's a consanguineous parents, how are the siblings are doing, how is the mother? Again, a very, very important history is how was mother during pregnancy? Was she anemic? Was she transfused any blood during that time? And what was her baseline hemoglobin during the first booking of antenatal booking bloods? You also need to know whether gallstones were there in any of the family members. And what I have seen is, I have seen a couple of hereditary spherocytosis children where they didn't know, the family members didn't know that they have got a blood-related condition, but they do say that they did have splenectomy surgery when they were 20 or 30. So that also, so if they don't come up with the blood-related problem, you need to ask the history of gallstones and splenectomy surgeries. And you also need to know the developmental history. So with that, you all know that depending upon the age, normally at birth, the hemoglobin is around 17 to 18, then drops around 2 months of age. So if someone refers to 2 months of the hemoglobin in a term maybe of around 10 or 9.5, it could be a physiological anemia of infancy. You wouldn't do, you just follow them up. And Anita already mentioned about the MCV part. The red cell volume, and which is very, very important in classifying anemias as well as in evaluating anemias. You also know that the age of onset of the anemia. For example, as you know, the children are born with around 70% of hemoglobin F and 30% of hemoglobin A. And over the next around months of time after birth, the hemoglobin around 6 to 7 months hemoglobin F is almost replaced by hemoglobin A. So by and large, the beta thalassemia major usually presents between around 5 to 6 months of age. So coming back to my case, who was referred for not responding to oral iron supplement at the age of 15 months. So the history, what all we need to ask. So same thing, this boy used to have many episodes of breath holding spells, which was the scariest thing for the parents to watch child having stopping breathing, turning blue, and frequent episodes. That's the reason they kept on coming to the regular follow-up as well. And with the history, he was born at term 2.8 kilos, no NICU stay, no neonatal jaundice. He was born to second-degree consanguineous parents, no other medical illness in the family. Mother hemoglobin was around 10 during pregnancy. She wasn't transfused. This boy has got one elder brother who is doing well. He's developing normally. There is no history of seizures or developmental delay. So once you take on the detailed history, I haven't come back to the iron part. I will come back to it in a while. So when you examine a child with the evaluation of anemia, the growth is better and better of any pediatrician. That is a must, whether you are a hematologist, whether it's an oncologist, whether you're a rheumatologist, growth one has to look into thoroughly. So whether the child is height, weight, head circumference. Sometimes if the child hasn't grown for 6 months or a year, if there is a good growth chart, itself will tell you that if a chronic renal failure, they might come with the short stature. So that itself will tell you, looking at the growth. If someone has got head circumference very small, probably this could be one of the bone marrow failure syndrome. So that it helps us to classify them. Look out for any congenital anomalies. Look out for any dysmorphism. Look out for nail changes. It could be koilonychia or dyskeratosis congenita associated nail changes. You have to look at the pigmentation. It would be perioral hyperpigmentation or knuckle hyperpigmentation. Look at for cephalo spots. Look at the oral cavity. Look for any oral leukoplakia. Look out for any lymphadenopathy or organomegaly, which usually indicates that we need to refer these children to hematologist for further evaluation if someone has got significant organomegaly and lymphadenopathy. So here is a boy with the girl who has got abnormal thumb. This kind of thing usually comes up with Fanconi's anemia. You could see here a increased what we call as hemolytic phases with the skull bone hyperexpansion. Here is a maxillar hyperexpansion, malar prominence is seen in hemolytic phases. This is a classical of hemolytic phases. And then you could look out for icterus, triradiate thumb. You could see it in a pure red cell aplasia congenital, diamond blackfan syndrome, and always look for hepatosplenomegaly. Coming back to my case, this boy at 15 months weighing 9 kilo, length of 79 centimeter, reasonably falls between around 9 to 25 centile, head circumference average for his age. He has got pallor, but no icterus, no dysmorphism, no congenital anomalies, no lymphadenopathy, no organomegaly. So coming back to because he was referred because he was not responding to the oral iron supplements. So this may be a common scenario for a pediatrician as well as us, someone who has not responded to oral iron therapy. How do we go about? The possibilities are the child is not taking the medication at all. You think you have prescribed, but not taking at all. If the child is taking, it could be ineffective treatment, means supplements are not given as prescribed, dosage may be suboptimal, dietary changes are not made. Somebody who has been drinking a cow's milk of 2 liters to 2.5 liters per day, dietary changes are not made, and still they continue to drink cow's milk like that, bound to have persistent iron deficiency anemia. And you are not given iron supplements for enough duration. If the medicine has been given and being taken as prescribed, then it's not being absorbed as you would wish. That could be the reason for not responding to iron supplements, such as in a case of malabsorption syndrome. It could be atrophic gastritis or autoimmune gastritis. H. pylori infections are not common in children. It could be a cause for a refractory to iron supplement in a teenage and adolescent girls and boys. Otherwise, less than 10-year-old, it's not that common. Medications taken in association with the interfering absorption. This is something very common. Many of the times iron supplements are given along with the breastfeeding or soon after the breastfeeding or just before the breastfeeding. Usually milk will prevent absorption of iron. Congenital causes for iron malabsorption. These rare entities such as genetic inheritance, the reason being. Cow's milk protein I already talked about. Meckel's diverticle means already ongoing blood loss in addition to the absorption problem and inflammatory bowel disease. Other possible reason, it could be child is not at all iron deficient. So in that scenario, relook the diagnosis. What are the alternative diagnosis for this child who is not responding to iron? Always look out for thalassemia. So Neeta just mentioned about how on a Coulter, you would look into the Coulter report, the CBC report. You will look into classify into thalassemia trait from iron deficiency anemia. Look, think about lead poisoning. Take the history of any alternate medicines or with the pica, or sometimes starting with as pica, but eating the paint leading to lead poisoning. Look out for any anemia of chronic inflammation, copper deficiency, and the bone marrow related problems. It could be coexistence of another disease in addition to iron deficiency anemia. That's very much common, especially coexistence of iron deficiency plus thalassemia trait, very much common in our population. Look out for those conditions. Concomitant malignancies, concomitant chronic renal failures are very, very rare associations, but can happen. Concomitant vitamin B12 association usually common in this peripheral smear is usually gives some clue. The last possibilities are ongoing hemolysis, ongoing blood loss in spite of giving iron supplement. These are all very rare causes where some telangiectasias, ongoing bleeding from the gut is the reason for the iron not responding, the hemoglobin is not responding to iron supplement. Very rarely we do miss that. We had one child presenting with pulmonary hemosiderosis, looking like hemostasis and iron deficiency anemia, and required some steroids and other medicines for that child. So look out for other systemic history and examination as well in these children. So normally when you evaluate a child with anemia, majority of the times, good history and general physical examination, good complete hemogram, which includes all the red cell indices, including RDW, good peripheral smear, creatinine, reticulocyte count, gives most of the answers. In addition, if you need more, these are the following tests you need to do. Serum iron indices such as serum iron TIBC transferrin saturation and serum ferritin. Look out for LDH, haptoglobulin, bilirubin, and urine for hemoglobin. You need to look out for intravascular or extravascular hemolysis. Do the direct Coombs test to classify into immune or non-immune mediated hemolysis. Thyroid function test, especially majority of the children would have had thyroid function test by the time they come to us, so it may not be that useful. And do the vitamin B12 and folate levels. This, by and large, completes the basic work of iron deficiency anemia. Doing genetic studies, doing bone marrow, doing rare things, usually rare. Coming to my child, after a month, I think that before they started, hemoglobin was 7.9. And after starting iron supplement for a month or 5 weeks, the hemoglobin was 8.6. So if someone has got iron deficiency anemia, by and large, by 3 to 4 weeks, they should gain at least 1 gram of hemoglobin. That means they are responding to iron deficiency anemia. White cell count is 14,900. Platelets are high. It could be reactive thrombocytosis, or it could be just because of iron deficiency anemia, where you normally see thrombocytosis because of increased thrombopoietin stimulation. And neutrophils, always look out for the differential. Though you are talking about anemia here, always look out for the differential count, whether it is a neutrophilic predominance, lymphocytic predominance. If it is very much lymphocytic predominance, then you need to think about alternative causes as well. Because this child came with on iron supplement, we simultaneously did the HB variant analysis, which was normal, almost the HbA2 2.4. We would usually say beyond 3.5 is thalassemia trait. If you look into the RBC indices of this boy, the MCV is very low and RDW is high. That means different sizes of the red cells are there in the circulation. So microcyte, normocytic, little some are the macrocytic, majority of microcytosis. So it indicates usually classical iron deficiency anemia, and RBC volume is lower, 4.7. So with the creatine also, we did at this first instance. I always do creatine, which you should not miss, because rarely you come across a child with chronic renal failure in association with iron deficiency anemia. Here it was 0.3. So this rule of thumb already Nita has mentioned. What is the lower limit of MCV for the age? Is there for this boy 71 is the lower limit, and here we have got MCV of 60. And the RDW is 14 to 16 is normal for the age, normal here it is 22. So on the basis of red cells, usually we classify into microcytic, normocytic, and macrocytic, which again Nita talked about. And the iron deficiencies, the common causes for microcytosis are iron deficiency, thalassemia, lead poisoning, some sideroblastic anemia, and anemia of chronic inflammation. And the normocytics are mainly the anemia of chronic inflammation, autoimmune hemolytic anemia, some of the hemolytic anemias in the normocytic. Macrocytics are bone marrow failure plus hypothyroidism and vitamin B12 and trisomy 21. Coming back to the iron deficiency, in a classical iron deficiency anemia, serum iron level will be low, TIBC will be high, and ferritin will be low. Whereas in thalassemia minor, all may be normal or slightly high. In chronic disease, ferritin will be high, and iron level as well as transferrin saturation will be low. Coming back to my child, at 15 months, his ferritin was normal. So above 30 is the cutoff in our lab, 52 was normal. However, serum iron, our lab cutoff is 59, it was 20.2, TIBC is 280, but transferrin saturation is 7%. Anything less than 10% is severe significant iron deficiency anemia. Normal, it is around 16 to 20%. Serum iron divided by TIBC into 100 is the transferrin saturation. Reticulocyte count is 1%. When you correct it for the hemoglobin, it's less than 1%. Peripheral smear, there are no abnormal cells, no basophilic stippling. This just microcytic hypochromic anemia with anisopoikilocytosis, and HB variant analysis has been normal. So I thought iron deficiency anemia likely to be nutritional, and there is a history that mother was giving iron supplement because it was difficult to administer iron supplement. She was giving soon after breastfeeding. So I thought it could be because of the absorption related to the milk. And I also changed from tonoferon to another sodium ferriditate gluconate to ferriditate molecule. This is something majority of the times we do changing the molecule. It might help. But having said that, if you look into the evidence-based medicine, there is no much advantage, no much evidence to say one over the other. Then I followed him up a month later. So a month later, his hemoglobin improved to 10.1. So 8.6 to 10 is a good response. It indicates that he has got iron deficiency anemia. Reticulocyte count remains almost same. though the hemoglobin improved to 10, this boy continued to have intermittent breath holding spells. So that's why I asked them to continue the iron supplement. Obviously, when you suspect iron deficiency anemia and treating iron deficiency anemia, you need to give iron supplement at least for 4 to 6 months, at least 2 to 3 months after normalizing the hemoglobin to replenish the stores. So what are the factors affecting the erythropoiesis? You need to know when we evaluating the child with anemia. It could be bone marrow related, it could be erythropoietin related, it could be the multiple nutritional factors, which all we talked about earlier. This is the same slide Anita also displayed earlier. So the 5 steps if you ask me to evaluate child with anemia, good history and general physical examination, CBC and peripheral smear, looking at the RDW in addition to MCV to classify into the type of anemia, looking at the iron indices, reticulocyte count, and this is the hemolysis to look out for any hemolysis. So that will give us to the direction where we are going to diagnose and what's the underlying condition. It's also talked about reticulocyte count. If the MCV is normal, then we look into the reticulocyte count, which will tell us whether it is because of lack of production or increased destruction. So the lack of productions it could be nutritional related or it could be bone marrow failure related. The increased destruction could be because of the hemolysis. Either it could be membrane or it could be autoimmune or it could be enzymes or hemoglobinopathies. This is a classical picture of, you could see the hemoglobin is completely normally 1/3 is hypochromic, and here it is spirocytes with the clue in the CBC is MCHC is high. Usually it should be 34, and reticulocyte count high, bilirubin is high. So if you stick to the structure what we talked about just prior to this, you should be able to diagnose most of the anemias. Come back to my child after 6 months after on oral iron supplement with the sodium ferriiditate, with making sure that good complaints and no history of no other symptoms. His hemoglobin remained at 10, it hasn't normalized. His MCVs remained MCV 67.3. His RDW still high. That means still his iron deficiency not corrected in spite of 6 months. There is no other GIT issues. So one of the things we do whenever someone is not responding to look out for any absorption issue, commonest at this age by around 2 years of age, it was whether he has got celiac disease. Celiac disease is usually screening tests and tissue transglutaminase antibody, which was negative in this case. He still has got breath holding spells, but has come down. His hemoglobin was around 10.1. At 22 months of age, his hemoglobin remained same. I repeated iron deficiency anemia. Iron indices, again, transferrin saturation is low. Ferritin is normal, slightly higher range, above 150, 154. Serum iron level is low. I also repeated HB variant analysis second time because you all know that iron deficiency can mask thalassemia trait. Because HbA2 levels, the gamma chain productions are hampered when there is iron deficiency state. So HbA2 level may be falsely normal low in a iron coexistence of iron deficiency anemia. That's why I repeated HB variant analysis. It was normal as well. And he has completed around 6 to 7 months of iron supplements, and the parents were finding it difficult to administer. Then I said we could stop iron supplement and see. Also talked about other possible causes of microcytic hypochromic anemia, because here the iron indices are suggestive of iron deficiency except the normal ferritin. Also talked about alpha thalassemia trait and sideroblastic anemia. But he used to follow up every 3 to 4 months. At age of 2.5 years, 2 year 4 months, his hemoglobin is remained same with the high RDW, low MCV. At that point of time, I did the alpha thalassemia multiplex PCR. It is not a I would say, complete test to rule out alpha thalassemia, because the genetics of alpha thalassemia is difficult. There are deletions, non-deletional changes. There is no one test which will completely say that there is no alpha thalassemia, but whatever the 3.7 or 4.2 mutation on the PCR was negative. He also did lead level, which was less than 5 microgram, which was also normal. So here we have got a boy who has responded to begin with, not completely responded. His hemoglobin remaining around 9.6 to 10, and he's otherwise developing normally, looking pale and getting easily tired. Apart from that, no other symptoms. What would you do here? So what was the cause for his persistent low hemoglobin? Would you subject him for upper and GI scopy, which if it were adult, one would have subjected in the first presentation. But in children, GI, upper GI, lower GI scopy, we do not know that often, especially less than 10-year-old children. So the follow-up also, after around 4 years of age, we repeated serum ions again, looking same, 4.5 years of age. So here again, looks similar of hemoglobin 9.1, persistent microcytosis, and now low iron and low transferrin saturation, and ferritin is near normal. And similar RBC indices again 6 months later as well. Always transferrin saturation low and serum iron low and near normal ferritin. So then we subjected him to bone marrow to look out for sideroblastic anemia. But in sideroblastic anemia, normally you will have high iron, high ferritin, and ringed sideroblast on the bone marrow, which weren't there on the peripheral smear or iron indices, not on the bone marrow. Then what we have left with is looking at any iron refractory, iron deficiency anemias, looking at we did the serum hepcidin. Hepcidin is very important regulator of iron absorption. If the hepcidin level is high, iron absorption is not good to the membrane TMPSS receptor. So in our boy, hepcidin level was high. So what next we are going to do in investigation such a child is to doing the genetic studies for iron refractory iron deficiency anemia. Here, the NGS done for showed there are 2 mutations in the 2 gene. One is T3 gene and another one is TMPRSS 6 gene. This is gene for a congenital sideroblastic anemia. This is gene for IRIDA, iron refractory iron deficiency anemia. So both genes, it is a heterozygous mutations. Normally, both these conditions are autosomal recessive, but here it is heterozygous gene mutations. Whether they are causing the problem in this boy. So we did the parents' iron indices, which are normal, transferrin saturation 39. In father's CBC is completely normal, and father's HB variant analysis is normal too. Mother's HB variant analysis normal, CBC is normal. But when we sequence Sanger sequencing of both mother and father's bloods, father is heterozygous mutations for both these genes, but he's completely asymptomatic. How this child developed then, both gene mutations, but symptomatic. So the likely explanation here, after discussing with the geneticists, etc., probably variable penetrance, though it is autosomal recessive conditions, heterozygous mutations can sometimes cause IRIDA. Here we think the IRIDA is the TMPRSS 6 gene mutation is the most problematic than the sideroblastic gene, which is silent in this case. Currently, whenever he gets too tired, he feels tired. He's on intermittent iron supplement with the vitamin C tablets. So someone who has not responded to oral iron supplement, and you are confirmed that is iron deficiency anemia, you always supplement vitamin C tablets along with the iron syrup or iron tablets. So it will help in the iron absorptions, and his hemoglobin is maintained between 9 to 10.5 gram. So following up in once in 6 months currently, otherwise he's well. So This is just about, we talked about the evaluation of anemia, in particular microcytic hypochromic anemia. I chose this case because of this is a common scenario you are all coming across in a routine day-to-day cases where microcytic hypochromic anemia, iron deficiency, poor response to iron supplements, what all you need to think about. Though iron is a rare condition according to literature, but studies from India showed around 10 to 11% of children with iron deficiency anemia could be because of inherited iron absorption problems. As Neeta said, whenever we see a child with anemia, always give importance to not only the one cell, to the WBC, the subsets of white cell counts as well as to the platelet. So if it is a pancytopenia, by and large, majority of them end up in a tertiary care center for further evaluation. However, the commonest cause for pancytopenia in our setting is megaloblastic anemia or nutritional related. How do we pick up? With the good history, good examination, and good basic workup, what we have already mentioned. So history, the majority of them are vegetarian. The mild icterus will be there. Small spleen tip will be palpable. Very high LDH will be there. Mild increase in the bilirubin, high MCV, high increased RDW. Sometimes the segmented, hypersegmented may or may not be there for examination. Mild evidence of hemolysis on the peripheral smear and DCT negative. You always can give a trial of vitamin B12 injections and folic acid and iron supplement and see the response. But beware, once you start the vitamin B12 injections, the platelet count may drop for first few days before it's starting going up. And other possible causes for pancytopenia, these are the common things in a tertiary unit we come across: inherited bone marrow failure syndrome, aplastic anemia, paroxysmal nocturnal hemoglobinuria, acute myeloid leukemia, myelodysplastic syndrome. These are all overlapping each other. We need to do extensive investigation, including cytogenetics and molecular genetics. With this note, I will summarize. So to evaluate a child with anemia, always take a detailed history and good physical examination. Look out, do a complete blood count. Kindly, please do not just HBTC platelet. So do complete blood count. Insist on getting the red cell indices, and you already now know how to interpret the CBC. Look out for MCV and RDW. Peripheral smear is not required in every child, but if non-responders are in a case of anemia, it always better to get it checked. Classify the iron deficiency on the base, anemia on the basis of MCV and RDW. That will help us to tailor the further workup. Microcytic anemia commons are iron deficiency, thalassemia minor and major. Normocytic anemia, kidney failure, CRF, chronic infection and inflammation. Macrocytic, nutritional plus bone marrow failure. And if you are treating yourself both iron deficiency and or megaloblastic anemia, always anemia is not a diagnosis. It is a presentation. You need to find out why someone has developed iron deficiency or someone has developed vitamin B12 deficiency. So majority of the times in our setting is nutritional or poor nutrition or improper nutrition is the reason. However, if someone presents with the repeat iron deficiency or anemia, always we need to subject them to extensive investigation to look out for the cause for these. The reticulocyte count will help us to classify between the lack of production from increased destruction. If more than one cell line affected in association with the organomegaly, lymphadenopathy, positive direct Coombs test, these things always indications to refer to the tertiary unit. This is the last slide where you could by and large come to one conclusion from doing the test according to this algorithm. Thank you very much for patient hearing.
Thank you for the beautiful presentation on evaluation of anemia. Case study. Anemia continues to be a public health problem, even in developed countries. Though it doesn't cause much morbidity, it do cause mortality in the form of, even though it doesn't cause much mortality, it do cause morbidity like growth retardation and learning disabilities and all those problems. So it is very, very important for all the practitioners to know about various anemias and management. Of course, it is mostly iron deficiency anemia. But then there are other anemias, especially when it is, as you said, it is presenting repeatedly, refractory way. It has to be evaluated and treated. Yeah. So this is the time for questions. First question is to Dr. Nita Radhakrishnan. The importance of eosinophil count in evaluation of fever. Am I right? Fever. Yeah. Importance of eosinophil count in evaluation of fever. There is one more question. Reticulocyte production. Is it to Dr. Nita or Dr. Asha? Second question. Yeah.
Nita, madam.
I will answer one by one. I saw the questions. I'll take it up one by one. So that eosinophil count, I partly replied. Partly spoke about it in the talk itself, that eosinophil counts do help in some fever evaluation. So classically, we know that eosinopenia is a part of enteric fever. And other than this, now among these recent COVID infection also shows eosinopenia. So these are two classical conditions where you see. Eosinophilia is seen with a lot of infections, as in a lot of conditions you do find eosinophilia. So unless it's very high, we don't really do much about it. After correction of infection also, if eosinophilia is not responding, then definitely go ahead with evaluation, treat deworming, all that is done. The second question was on reticulocyte production index. I would need, can I share my slides again, Jitin?
Yes.
So I need a picture to explain that. So I actually did not keep it in the earlier part of the discussion. So once I saw the question, I thought I'll discuss. So this is how a reticulocyte reticulocyte comes into the circulation. Sorry. So this is how a red cell series develops. And this is your late normoblast, which is the nucleated red cell. Okay, so in hemolytic conditions, we start seeing nucleated red cells in the circulation because bone marrow is pushing out everything as much as possible, it is pushing out. So nucleated red cells are seen in hemolytic anemia, many hemolytic anemias like thalassemia. It is found in any condition where the bone marrow egress is quick. Now, after this, what happens is it loses its nucleus. Now, after it loses its nucleus, then is this phase called reticulocyte count. And this is the one step prior to that of a red cell. And here from this phase to the red cell, it takes usually 24 hours. That is when a normally maturing cell occurs. So what happens is when your hemoglobin is low and your bone marrow is trying to produce more and more cells, more and more reticulocytes are coming out. Many a times with the degree of anemia, the time that is spent by a reticulocyte in the periphery is actually more. It is not just 24 hours. So as the degree of anemia increases, maybe it pushes reticulocytes a little faster out. So because of that, the maturation time in the periphery may be 24 hours plus another 24 hours, so 48 hours. So when I'm doing reticulocyte count today, I need to know two things. One, is the reticulocyte count corrected for the degree of anemia? So that is what I look at. That is what I call as corrected reticulocyte count. So that means what? So if I'm saying my hemoglobin is say 12 grams and my reticulocyte comes as 1%. A baby I'm seeing has a hemoglobin of 4 grams and that reticulocyte also is coming as 1%. But the value of 1% retic for me versus the value of 1% retic for that 4 gram hemoglobin is entirely different. So the reticulocyte count, since it is a percentage, it also always should be calculated, it should be analyzed with respect to the hemoglobin or the MCV. Hemoglobin or the hematocrit. So that is called corrected reticulocyte count. So you can correct it to the patient's hemoglobin with a versus a normal hemoglobin, or the patient's hematocrit versus a normal hematocrit. So if I'm correcting versus by hemoglobin for the child with 4 gram hemoglobin, retic of 1%, 1 into 4 divided by, for that child hemoglobin should be around 12. So 4 divided by 12, that will be 4 by 12 would be 1 by 3. That is 1 into 1 by 3, that will be 0.3%. So even though the retic count for me as well as that 4 gram hemoglobin child is 1%, but the value it offers, the number actually is 0.3%, because when you correct it to that hemoglobin, it will be only 0.3%, which shows that bone marrow is not functioning normally. It is less than 5%, 0.5%. The same calculation, since hemoglobin and hematocrit are interlinked values, it can be even hematocrit correction also. For that hemoglobin of 4 gram, the child's hematocrit will be it will be again into 3 only. So that again, if you calculate against a normal hematocrit.
Can bone marrow examination be avoided on the?
Sir, I am coming to that, sir. So this this is how you calculate a corrected reticulocyte count. Can you hear me? Can you hear properly?
Yes, ma'am.
Now the next part of the question was reticulocyte production index. So that is what I mean by this part. This image is important for that, because when a retic comes out, normally in a normal human being, it spends only 24 hours before it becomes a red cell, because before it loses all the RNA and becomes a red cell. And so this period can increase if your hematocrit is low. So if your hemoglobin reduces or a hematocrit increases, the number of days that the retic is spending outside in the periphery is actually increasing. So if I am taking suppose that child's hemoglobin is 4 gram percentage and retic comes as 3%. So for that 4 gram, the 3% retic will have the 4 gram means hematocrit will be say around in this range only, less than 15% only. So that less than 15% hematocrit, the reticulocyte is spending 3 days in the periphery. So if I'm getting 3% value, that means I'm calculating yesterday's retics also, day before yesterday's retics also in that calculation. So I want to know exactly that 3% is then high. So I want to correct it for the duration of time the retic has spent in the periphery. And that is what you calculate by reticulocyte production index. So again, you calculate correct reticulocyte count like this, and then divide it again by the maturation time. So our calculation of reticulocyte count was for that baby of 4 gram percentage. If the reticulocyte count is 3%, the calculation of corrected reticulocyte count will be 3 into 4 divided by 12. That will be 1%. Now, of this 1%, days in the peripheral blood would be 3 for that child, because hematocrit is 12%. So then divided by 3. So that will be again coming to 0.3%. So reticulocyte production index will be extremely low. So that way I know that although the pathologist told me that a hemoglobin is a 4 gram percentage and a retic is 3%, it is erroneous, because I cannot go by that plain reticulocyte percentage. I have to calculate it. I have to correct it for the degree of anemia. I have to also correct it for the number of days that the reticulocyte is spending in the periphery. That is called reticulocyte production index. And then after that index is got, we showed both me and Harsha showed the same table, which says that if the index is less than 2.5, it basically means that the bone marrow is not functioning well. I hope I am clear.
Yes, ma'am. Yes, ma'am. Yes, please.
Yeah. There was one more question on bone marrow can be avoided in ITP, right? I'm just stopping my screen share. Just a minute. Okay, so the question regarding bone marrow in ITP, right? That bone marrow question was on ITP. We would basically look at, so now current ASH guidelines say that if your hemoglobin is completely normal, WBC is normal, your differentials are normal, peripheral smear doesn't show anything at all suggestive of a lymphoma leukemia process or anything else which is suspicious of a bone marrow failure, and the child is absolutely well, no fever, no lymphadenopathy, no organomegaly, nothing like that, then you can probably avoid a bone marrow for ITP, and you can even give steroids that is the recommendation. See, recommendation is coming out of US. So for them, patients are presenting early. Patients are presenting all treatment that has been received is documented somewhere. Whereas in our condition, many a times steroid use is not documented. Many patients receive Ayurvedic treatment which may have steroids in it. So all these things compound to our decision making. So if I'm not comfortable, I would definitely go ahead and do a bone marrow. But if it is a very well educated family, they're presented immediately and it's a classical ITP, we might, if a peripheral smear is good, we can avoid a bone marrow and just go ahead and treat. Of course, if you are doing, if you're treating with IVIG, no need for a bone marrow. But if you are treating with steroids, be very, very careful about all this because at times leukemia can be missed.
There are 2-3 questions to Dr. Nida, but that has been already answered in the chat box, and we are short of time. So I pass on the questions to Dr. Harsha Prasad.
Yeah.
Yeah, the question is, any preferential staining in bone marrow examination? And the role of IV iron therapy in that particular case?
Yeah. Thank you for the question. First of all, role of iron therapy. Currently, we do have reasonably less side effect or almost nil side effect iron parenteral iron preparations such as iron sucrose, iron dextran, iron ferric carboxymaltose injections. Usually, the majority of them are licensed beyond 12 years of age group. Having said that, I have administered these medicines for those children on whom oral iron supplements have not done because of the various reasons, either absorption related or issues related with the administration. Parents are finding very difficult to administer oral iron therapy. Some children do develop a diarrhea with the iron supplements. So in those scenarios, I have used around 3 or 4 cases of children with iron deficiency anemia with the parenteral iron therapy. I have chosen both iron sucrose as well as ferric carboxymaltose. Having said that, if an adolescent girl comes up with iron deficiency or boy comes up with iron deficiency anemia, I do offer them a parenteral iron versus oral iron. And my preference, because of majority of the teenagers finding it difficult to take oral iron supplement tablets, so usually they go for parenteral iron therapy. So for them, I calculate iron requirement and give parenteral iron supplement. The second question, was there any question regarding bone marrow? I didn't hear properly, sir.
I think in your patient, they are asking if Prussian blue staining was done in the marrow.
Yes, yes, sir. That was done and it was negative. There are no, it was said 2 to 3 plus, but the iron staining and there weren't any ringed sideroblasts.
Okay. Yeah, may I add something to something Dr. Harsha has said regarding parenteral iron therapy? I think it is mostly underutilized, parenteral iron therapy. It is there since 4 or 5 decades, and especially in adults it has been used without much problem. But it is very surprising that children seldom receive IV iron therapy, even in those research cases. I don't know why.
Yeah, all guidelines recommendations is for oral, because oral iron therapy does as good as IV if you are able to make sure that they are able to take this, because it's just 1 or 2 teaspoons of iron syrup. Why you want to subject them? Though parenteral irons are reasonably safe, you still see some kind of anaphylaxis reactions, flu-like illnesses, headache, and urticarial rashes, and they need to be at least daycare admission. So if you are able to make sure that child is able to take this iron supplement, then it's always better, and it's always worthwhile to try with oral than IV. Though it is safer, reasonably safe, but you could do it beyond 10 or 12 years of age group at this stage.
Okay, fine, sir.
Can I add, Harsha?
Yeah.
I think IV iron is only needed for inflammatory bowel disease. There hardly any other condition. Most of it is corrected by oral only. You just have to titrate the doses, maybe give it at night so that they tolerate it better. give it after a meal. I know absorption does reduce after a meal, but tolerance improves. So you can just try it after a meal also, although technically we don't give, we should not supposed to give. So all these things improve. So IV is not needed unless there is blood loss happening at an extent which is more than what you are giving. So in which case IV might be required, but out of say 500 iron deficiency anemias you see, probably one might require IV iron, not more than that.
Yeah, thank you. It is sort of assuring compliance. I can make assure compliance. Okay, the next question is iron deficiency anemia with the B12 deficiency is management. Dr. Harsha.
I'm sorry, I can't hear you. Sorry.
Iron deficiency with B12 deficiency management.
Management of IDA with B12 deficiency.
Okay, so yeah, the combination of iron deficiency and nutritional vitamin B12 folate deficiency are very common. They present sometimes, though in the RBC indices you talked about, MC is high, then it is megaloblastic anemia. Sometimes MCV may be normal range, but it was a megaloblastic anemia because of association of iron deficiency along with them. We do see once in a while. In those scenarios, as the requirement of iron will be more to production of the more red cells when you supplement vitamin B12. So you always give vitamin B12, folate, and iron in all these cases. Do we need to investigate in more for this to find out the reason for dimorphic anemia? That depends upon the each child clinical settings. Majority of them are nutritional. So you usually follow them up closely, but you end up giving all the 3 supplements for these children. You have to give.
Yeah, the question is difference between RWD-SC and RDW-CV, and which should be used?
It is just a different way of calculation. If some machines calculate it as SD, some machines calculate as CV. It depends on the Gaussian distribution. Where are we calculating it? So both have their normal values. You can take either of them. It depends on your machine which is giving out the report. Both are okay.
This question is, should all children start on iron supplements?
They started on vitamin C.
And we started on vitamin C from first.
Yeah, very good question. Very valid question. To increase the absorption of iron supplements, should we add vitamin C for every child whom we start? Well, it's not usually required because majority of them they do really well with just 2 or 9 supplement. So I wouldn't, but in the guidelines from the BJ Heme or other European guidelines, there the vitamin C cost is high to do a combination of iron with vitamin C. That's why they suggest usually with no vitamin C to begin with. In India, if you are able to find it difficult or they are not able, the kind of children where already been tried with iron, certainly I would prescribe iron plus vitamin C. If I am seeing the first time contact, and then I would just give iron, any iron molecule with the good elemental iron dose of nearly 4 to 6 milligram per kilo, and follow them up. If there is no optimal response by 3 to 4 weeks, that means if there is no increment in the iron hemoglobin, at least 1 gram, and you are made sure that it is iron deficiency anemia, in those scenarios, then I add vitamin C.
So thank you, Dr. Nida and Dr. Harsha Prasad. We are late by 1 hour. And there is one more question to Dr. Harsha Prasad, which can be answered in the chat box. We will move on to the next topic.
Thank you.
Thank you very much.
Thank you for the excellent session, both Dr. Nida and Dr. Harsha. So we'll move on to next session. I invite Dr. Ananda Keshavan sir. He needs no introduction. He is the South Zone Vice President of IAP. So I invite him to moderate the next 2 sessions.
So, once again, good morning. Now we'll have 2 sessions on leukemia, and we have eminent speakers from RCC also. I think the first topic is by Dr. Binida on basic principles of treatment of leukemia in children. So leukemia is the commonest malignancy in children, and it is the first systemic malignancy cured also. So I think the most important factor in the treatment of leukemia, prognostic factors, first one is that early treatment. Second thing is that supportive treatment. There are so many other prognostic factors also. And also there is a lot of changes happened when we are studying about the leukemia. There was only a minimal number of drugs, and a combination treatment is developing. Cranial radiation was there. Now there are so many newer treatment. Elastinous induced cranial radiation needed or not. Genetic markers to find out the drug sensitivity, and also to whether to also predict prognosis. So there are so many developments in leukemia also. To speak all these things, we have an excellent speaker, Dr. Binida. She's a pediatric oncologist, and she's from RCC. In this aspect, I want to say many thanks to RCC, because all our patients from Trishul Medical College. Previously, we used to treat leukemia in Trishul Medical College itself, but due to advance in investigation and some problem in giving special care to this patient, nowadays we are not treating children with leukemia. So my to highlight all this, we have Dr. Binda, and also I also request Dr. Binda how to improve the center of treatment centers of leukemia, because previously we had centers of leukemia, now we are not treating it. So how to we can improve the number of centers treating leukemia? Not only the follow-up with the centers, but the beginning and also all the 3-4 phases of treatment. How can you improve in our setup? So with this few introduction, I hand over the mic to Dr. Binida. Over to Binida.
Thank you, sir.
Screen share ചെയ്തോളൂ.
So, good morning, everyone. Jitin, am I audible?
Yes. Continue.
Thank you. I would like to thank IAP Kanhangad and the organizing team, including my dear friends Guru Prasad and Jitin, for having given me this opportunity to speak to all of you regarding the principles of management of pediatric acute leukemias. As we know, acute leukemias are the commonest malignancies in childhood. The commonest, of course, is acute lymphoblastic leukemia, and then comes acute myeloid leukemia. Acute lymphoblastic leukemia accounts for nearly a quarter of all the malignancies in childhood, and acute myeloid leukemia constitute around 4% of all the childhood malignancies. So, as for the current WHO classification of myeloid neoplasms and acute leukemias, we basically have the lymphoblastic leukemias and the myeloid leukemias, and then we have a few acute leukemias of ambiguous lineage. So the B lymphoblastic leukemias can be classified as not otherwise specified, that is, they do not have any recurrent genetic abnormalities, and then we have the B lymphoblastic leukemias with recurrent genetic abnormalities. Similarly, in acute myeloid leukemia as well, we have AML with recurrent genetic abnormalities, without genetic abnormalities, which are the not otherwise specified group, then therapy-related myeloid sarcomas and myeloid proliferations related to Down syndrome, which is actually a next talk. The acute leukemias of ambiguous lineage basically include the undifferentiated leukemias and the leukemias which express both the myeloid as well as the lymphoblastic elements in their antigen expression. So basic epidemiology, the commonest, the age group at which the ALL commonly presents is in the 2 to 3 year age group. The various risk factors for developing ALL have been studied in detail. The exact etiology is still unknown. But the primary accepted risk factors for ALL include prenatal exposure to X-rays, postnatal exposure to high doses of radiation, and any previous treatment with chemotherapy. And various genetic conditions are also known to be associated with ALL, which include Down syndrome, neurofibromatosis, Bloom syndrome, Fanconi, ataxia telangiectasia, and Li-Fraumeni syndrome. Now, one of the important questions that we often face is having a brother or sister with leukemia, does it increase your risk? Some studies have shown a slightly increased chance, but the overall risk is still low. So the question is, just because a child has a leukemia, will the brother or sister have leukemia? It's almost no. The risk is very low. Whereas if it is an identical twin, the risk is much higher. And the risk is still higher if the twin is presenting in the first year of life as an infant. And again, having a parent who develops leukemia, as an adult also does not increase the risk of a child developing leukemia. The signs and symptoms, we are all quite aware. Mostly they're non-specific: fever, pallor, and bleeding related to the bone marrow involvement, bone pain, which is caused by leukemic involvement of the periosteum or aseptic osteonecrosis, lymphadenopathy. Lymphadenopathy is quite a common manifestation of many infections, and we usually treat them with oral antibiotics. So if we have a persistent or progressive lymphadenopathy that is not responding to our antibiotic therapy, we should consider the possibility of a leukemia. Then headache can be a manifestation of ALL. Usually it is because of CNS3 involvement, or sometimes it can present as painless unilateral testicular enlargement. Sometimes they can present with mediastinal mass. Usually it is more common in T-cell ALL with a high initial WBC count, and they can be associated with pleural effusions as well. When there is a huge mediastinal mass, the two most important things to be remembered is it can sometimes be an emergency. They can present as a superior vena cava syndrome or as a superior mediastinal syndrome. Superior SVC syndrome is essentially when there is a compression by the mediastinal mass on the superior vena cava, causing swelling, plethora, and cyanosis of the face, neck, and upper extremities, or a suffusion of the conjunctiva, dilated veins over the chest and neck, etc. When the same mass causes a compression upon the respiratory tract, it produces a superior mediastinal syndrome with respiratory symptoms, dysphagia, and chest pain. In children, usually they don't occur as separate entities. They usually occur together as a single entity, which is a superior mediastinal syndrome. So once we have all this, once we have a constellation of signs and symptoms which could suggest an acute leukemia, we proceed further with the diagnostic evaluation. First is the complete blood counts. As we know, anemia is very common, occurring in almost 80% of children with acute leukemia. Thrombocytopenia with a platelet count less than 1 lakh occur in 75%. But the point to be noted is, despite this high prevalence of thrombocytopenia, the incidence of severe hemorrhage is quite low. They usually present mostly with skin or mucosal hemorrhages. Severe hemorrhages, especially into the internal organs or intracerebral bleed, is quite common. So if there is a bleeding, a severe hemorrhage that is out of proportion to the platelet count, a higher index of suspicion for an APML or an acute promyelocytic leukemia would be there. So anemia and thrombocytopenia. As far as the WBC count, even though we usually tend to think that leukemia presents with an elevated count, it can either be a normal, an elevated, or a depressed WBC count. Sometimes they can have a pancytopenia presentation. And if you look at the diagnosis, initial diagnosis is by the peripheral smear, which will show the presence of lymphoblast, and serum biochemistries have to be done even at the referring center, at the initial center. The initial pediatrician who sees a child with a suspected leukemia should always be doing the serum biochemistry, which includes a uric acid, renal function test, calcium, and phosphorus. Elevated LDH will also point towards a tumor load, and definitely take a chest X-ray to look for a mediastinal mass. Mostly we get patients who are referred from other centers after having undergone these investigations, the counts, the smear, the serum biochemistry, and a chest X-ray. So at these points, there are certain things that a pediatrician should be well aware of when we are referring a patient to an oncology center. One is adequate hydration has to be ensured, and you should ensure that there is an adequate urine output. It's not always necessary that we go for IV hydration. Oral hydration is also sufficient. And allopurinol can be started. Always advise them to avoid extraneous potassium in the form of fruits or fruit juices should be avoided during the travel. And if there is any focus of infection, cover with an IV antibiotic. Avoid packed red cell transfusion, especially if the total count is very high, because there can be an increased viscosity of the blood if you administer packed cells, and that can predispose to leukostasis and its related complications. And platelet transfusions can be given safely if we are suspecting, if there's a platelet counts are very low and we are suspecting the possibility of a cerebral hemorrhage. But while giving transfusion, the most important thing we would like to stress is we should avoid steroids as far as possible. In case of a transfusion reaction, it would be better to manage with avil or adrenaline. And in case you give steroids, please do notify the oncology center, because the steroids, even with a single dose or 2 doses of steroids, the whole picture in the bone marrow can be altered and the diagnosis will become difficult. So if any steroid has been given, please do notify the oncology center. So these are certain important points while we are referring patients from a primary care center to a secondary or a tertiary level center. Right. Now, as I mentioned earlier, so once we receive the patient in RCC, what we usually first do is we do the repeat counts and we look at the peripheral smear. So a peripheral smear is important because it will help us to differentiate whether it is a lymphoblast or a myeloblast. A lymphoblast is usually smaller than a myeloblast, and it will usually have a larger nucleus. The nucleus will almost be filling the entire cell. The cytoplasm is very scanty. Whereas in a myeloblast, the nucleus is still large. The nucleocytoplasmic ratio is still larger, but the amount of cytoplasm will be slightly more. It will be more of a granular cytoplasm, and we will be able to occasionally be able to see an ORRODS, especially in M2 type of leukemias, AMLs. For a definitive diagnosis, bone marrow has to be done. More than 25% blast on the bone marrow will confirm the diagnosis of an ALL. Occasionally, if it's a pancytopenic presentation, bone marrow biopsies may need to be done. Then we go for the flow cytometry. The flow cytometry will help us in the diagnosis by, there are certain specific lineage markers. For example, the B lineage markers are CD19, which is more specific, CD19, then CD20, 22, and 79A. The expression of kappa or lambda, the light chain restriction, usually indicates a Burkitt lymphoma, Burkitt leukemia. T lineage markers, the most important is cytoplasmic CD3, the other markers being CD2, CD5, and CD7. Among the myeloid markers, cytoplasmic myeloperoxidase is very important, and then CD13 and 33 are also important. A myelomonocytic lineage in an acute myeloid leukemia can be diagnosed by the expression of CD14 and 64. Megakaryocytic lineage by this expression of CD41 and CD61. The CD45 is a common lymphoid marker. Now, this is one of the most important slides. So once we have a diagnosis of an acute lymphoblastic leukemia by a flow cytometry, then our next important thing for deciding the treatment, we have to risk stratify the patient. So risk stratification not only depends upon the clinical as well as the lineage, it also depends upon the cytogenetics. So the most important cytogenetics of ALL are depicted in this picture. All these parts marked in blue indicate the important recurrent genetic abnormalities or mutations seen in B-ALL. Those marked in red indicate the ones seen in T-ALL, and these seen in yellow or yellowish-orange color, they indicate the rather newly detected or newly confirmed types of prognostic factors or cytogenetics in ALL. So one of the most common is ETV6 RUNX1. ETV6 RUNX1, the importance it's seen in nearly a quarter of the ALL patients, around 22% of patients, and it usually confers a good prognosis to the child. Hyperdiploidy again confirms, it also shows, indicates a favorable prognosis ALL. Whereas MLL rearrangements, which is classically associated with the infant leukemias, are associated with the poorer prognosis. The TCF3PBX1, traditionally the translocation 119. This is the classical translocation 1221. This is 11q rearrangements, MLL rearrangements, which is seen in infant ALL. The translocation 119 initially was thought to produce an increased chance of a CNS disease or a CNS relapse, but now with aggressive CNS directed therapy, the prognostic significance has come down. It is considered to be an intermediate prognosis. BCR-ABL1, we are all familiar with the PH chromosome. The Philadelphia positive ALL confers. Earlier, it used to, I'll come to that in a slide later, the prognostic value of BCR-ABL1. And recently described ones are the BCR-ABL1-like and the intrachromosomal amplification of 21, which are all poor prognostic markers in ALL. Then in case of TALL, the major genetic abnormalities are the mutations of TAL1, TLX3, LYL1, etc. So it is important to understand the genetics of ALL because it is very important in the risk stratification and sometimes in deciding specific targeted therapy. The favorable prognostic factors combined together are one, age at diagnosis, less than 1 year, more than 10 years, poor prognosis, 1 to 10 years, good prognosis. Female gender has a slightly better prognosis. WBC count more than 50,000 at presentation has got a poor prognosis. Immunophenotype, generally T has got a poorer prognosis than the BALS. CALA negative BALS have a poorer prognosis than the CALA positive BALS. If the CNS disease is positive, that is what we say by the CNS3 status. That is, the CSF is showing the presence of blast with more than 5 leukocytes per microliter and showing the presence of blast. CNS3 status and a traumatic lumbar puncture showing blast are indicate an unfavorable prognosis. This genetic features they have already mentioned. The most importantly, hyperdiploidy and the ETV6 RUNX1 positivity showing a good prognosis. Hyperdiploidy, PH chromosome, 11q rearrangements or MLL rearrangements for the currently KMT2A showing a poor prognosis. Then, apart from these features at diagnosis, a clinical and the cytogenetic features at diagnosis, the most important critical factor determining the outcomes in ALL is a treatment response. So what are the major treatment response factors? One is a prednisolone response. So initial part of treatment of ALL is usually giving a 7-week course of prednisolone prephase. So at the end of prednisolone prephase on day 8, the blast count will be assessed. So if the absolute blast count on day 8 is more than 1,000, it is a poor prognosis. But if it is less than 1,000, it's a good steroid responder and the outcome is going to be good. Similarly, the remission status after induction, that is the initial 4 to 5 weeks of chemotherapy, we expect the bone marrow to be M1 marrow, that is less than 5% blast. But if the bone marrow is not in remission with a blast more than 5%, at the end of induction, the prognosis is still guarded. And then comes the important point, which is coming up in a big way these days, is a minimal residual disease or the MRD in the bone marrow. Just a few words on MRD. What is minimal residual disease in ALL? So normal, it is essentially detecting a residual disease in a bone marrow, which is not usually detected by our conventional morphological criteria. So morphologically, if you look at the bone marrow slides, you'll be able to pick up 1 leukemia cell in 20 normal cells. But if we do it by the flow cytometry or by the PCR assays for the specific markers, for the specific gene rearrangements, or the specific leukemia, specific immunophenotype, the sensitivity is much higher. You can detect 1 leukemia cell in 10,000 normal cells by flow cytometry or even up to 1 lakh normal cells by using PCR assays. If you use NGS technique, you can detect even 1 leukemia cell in 1 million normal cells. So this MRD assay, where you detect the residual cells which are not detected by the conventional bone marrow morphology, is very important prognostic factor. And the higher levels of end detection MRD have a poorer prognosis than those with the lower or undetectable levels. Classically, they are done at 2 points. And the most important points, one is end induction, the other is end consolidation. So if after 4 or 5 weeks of induction chemotherapy itself, if the MRD becomes negative, it's the best prognosis. In case it doesn't become negative at that point, you repeat an MRD at week 12, that is the end of the consolidation phase. I'll come to these phases in our next slide. So it is end of consolidation phase. You do the MRD. If the MRD becomes negative at that point, it becomes a intermediate prognosis. But if there's still a detectable or a high MRD, the end consolidation is a worst prognosis. So based on all these clinical features, genetic, cytogenetic features, based on the treatment responses, usually a risk assignment is done before deciding on the treatment. And this risk assignment essentially varies from group to group, varies from institution to institution, depending upon the availability of the techniques for diagnosis and for risk stratified. What we follow in RCC is a BFM 95 protocol and the risk stratification slightly modified because Here they put the initial WBC count as less than 20,000, but we usually put it as more than 50, less than 50,000 is taken as standard risk. So first, it's easier to learn from the high risk. So high risk is poor steroid responder, that is day blast count more than 1,000. No complete remission by day 33. If there is a pH positivity, if there is an MLL gene rearrangement, they are all high risk. Now, standard risk is no high risk criteria, WBC count is less. They say age between 1 to 6 years, but because based on the NCI criteria, we usually take it as a WBC count less than 50,000 and age between 1 to 10 years and only BALL. PALL will invariably be going to the medium risk. This is quite an old classification, and as times have evolved, more and more factors have been introduced into the risk stratification system. Each group has its own highly complex system of risk stratification, but essentially these are the major factors: cytogenetics and, as I mentioned earlier, the MRD. So if now they have incorporated MRD to include an MRD more than or equal to 10 raised to minus 3 at week 12 to be included in the high risk category. So once we have risk stratified, it is the treatment. One important, as Anandakeshavan sir told in the beginning, pediatric ALL is one of the diseases, one of the malignancies in childhood in which the survival has really increased over the past maybe 30 or 40 years. If the history of ALL is very interesting. So in 1948, transient remissions were introduced by aminopterin. Antimetabolites were introduced by 1960s. And it is by around 1970s that combination chemotherapy and effective CNS-directed therapy was started. And with that, the survival started improving. The use of combination chemotherapy. Various groups came into being, be it the BFM, the COG, the St. Jude research team. Everyone started using combination chemotherapy on a trial basis. It's always a trial. The patients are mostly included in trials and given combination chemotherapy. So that really helped in improving the survivals, and the various phases of treatment were modified by adding elements or by reducing elements, like changing the drugs that are used, using dexamethasone instead of prednisolone, using extra doses of peg-asparaginase, use of peg-asparaginase per se, increasing the doses of asparaginase doses. So that all happened over the 1970s, 80s time period. And by that, the survivals increased still further, maybe around 60 to 70%. And then came the genetic studies. Now it is almost an it's mostly based on, there are assays, there are analysis for genes encoding for the drug metabolisms, so that it's sort of an individualized treatment. And by 2010, 2013, we are in the phase of chimeric antigen receptor, the CAR T-cell therapies and monoclonal antibodies like blinatumomab. So by the early 2000s itself, the survivals had increased to as high as 70 to 80%. These are the various study groups. So many study groups are there, each having their risk stratification, each having their own treatment schema. But in general, the survivals are in the range of 70 to 80% with the current treatment therapy. Current treatment for ALL. So this gives us COG data just to tell you how the survivals have increased over the years. From around 10% in the 1960s, the survival has increased around 80 to 90% in the COG group when it reached around 2006 to 2010. Similarly, the St. Jude data, this is a 15-year survival for children. It increased from nearly 10% at 15 years in early 1960s to around 90% by the year 2010. So that is a success that has been attained in the treatment of ALL over the past 50 or 60 years. So I'll just briefly go through what are the treatment elements in ALL. The treatment of ALL is basically a risk-adapted, a response-based, based on all the factors we have been discussing so far. So it is a risk-adapted, a response-based treatment. There are different phases of treatment. First is a remission induction therapy. Second is a consultation. By remission induction chemotherapy, what we aim to attain is the bone marrow should attain a remission. The bone marrow blast should go less than 5%. Then comes the consolidation of the intensification therapy, where we aim to eradicate the residual blasts in patients who are in remission by the morphological criteria. Included along with this consolidation intensification phase is the extra compartment therapy, which is mainly targeted at the CNS. CNS is a sanctuary site. The blast can sort of hide inside the CNS. So we have to tackle them separately. So that's a CNS preventive therapy, the extra compartment therapy. And then we have a long maintenance therapy phase where we aim to stabilize the remission by preventing the re-emergence of a drug-resistant clone. So, as I mentioned, the first phase, remission induction, typically lasts around 4 weeks to 5 weeks. 98% of children will achieve complete remission by the end of this phase. The 2% who do not attain a remission by this phase 7 ultimately have a poor prognosis. And the drugs that are used are vincristine, corticosteroid, L-asparaginase, and intrathecal chemotherapy. So that is a 3-drug regimen. Vincristine, steroids, L-asparaginase, most important elements, with or without an anthracycline. So some groups use anthracyclines only if it's a high risk. Some use a lower dose of anthracycline if it's a lower risk, the standard risk category. So that's why I put it as a plus or minus anthracycline depending upon the risk of the patient. So these are the agents which are classified 98% achieve complete remission. Then comes a consolidation phase or the intensification phase. Most of the group use a BFM backbone. That is the biggest group. The BFM, which is a German and European group basically. So they have the most number of patients, and most of the groups use their BFM backbone for therapy. This includes various, as we see here, various combinations of drugs. 6-merc anti-metabolites, cytosine arabinocytes, 6-mercaptopurine, alkylating agents like cyclophosphamide. And again, then there is a reinfection phase where repeat the infection phase again. So all these factors have been tried in different combinations. It is not one uniform protocol that is followed across the world. There are various modifications of this protocol. Some using more doses of vincristine, asparaginase. Some use escalating doses of methotrexate, etc. So there are various, but the essential things are you use alkylating agents, you use antimetabolites, you give methotrexate basically for targeting the CNS. So these are the, so after induction, before we reach the maintenance phase, these drugs are given in various combinations. The CNS preventive therapy is given. So CNS prevention is mainly attained by cranial irradiation, intrathecal drugs, methotrexate or by IIIT, and the use of drugs that penetrate into the CNS like cytarabine, dexamethasone, and high-dose methotrexate. So high-dose methotrexate is giving 5 grams per meter squared of methotrexate. It should only be given in a center where we can ensure adequate hydration of the patient, adequate glucose rescue, and if possible, there are facilities for doing the serum MTX levels. High-dose methotrexate can be given at 5 grams per meter squared. Then the role of cranial irradiation. Initially, it was cranial radiation for all the medium risk patients. Then it came down to giving cranial irradiation only for TALL patients. And now most of the groups use it only in very rare selected situations where the patient is CNS, where the patient is having a TALL with a very high count, say more than 1 lakh. So that they are at a very high risk of CNS leukemia. You want to prevent a CNS leukemia, a very high risk patient only. Cranial irradiation is given because of the concerns of long-term side effects. But mostly if the patient is CNS3 and they're above the age of 2 to 3 years, you give cranial radiation treatment at 18 grade. Right, so that is an extra compartment therapy. Then this initial phases of induction, consolidation, and extra compartment therapy will be completed in around say 6 to 7 or 8 months time, and then there is a long maintenance therapy. At this point, mostly our patients will be coming to the periphery, and the patients will be receiving oral methotrexate and 6-mercaptopurine with or without vincristine, dexamethasone pulses. So the starting doses for 20 milligram per meter squared per day of methotrexate, and for 6 it's 50. So why I'm saying that it's a starting doses, the doses that is that 20 or 50 is only a starting dose. The dose has always got to be adjusted based upon the myelosuppression. Our aim is to keep the WBC count between 2000 and 3000. And so the dose intensity is very important. Non-adherence to treatment is associated with a significant risk of relapse. Now, so that is a basic treatment, and the total duration of maintenance chemotherapy is for 2 to 3 years. What we give is 2.5 years from the start of treatment is the total duration of maintenance therapy. At this point, they are very during this phase they are very prone to develop febrile neutropenia and related complications. Then, apart from the routine standard risk or the high risk BALs and GALs, we do have some special circumstances where additional therapy will be indicated. One is a pH positive ALL, which is seen in around 3 to 5%, mostly older children. They were generally considered to have a poor prognosis in the pre-tyrosine kinase era, but with the introduction of imatinib, with early exposure to imatinib and a continuous exposure to imatinib, the outcomes have generally improved for the Ph-positive ALLs with survivors as high as 70 to 80% without a hematopoietic stem cell transplantation. And newer tyrosine kinase inhibitors with more potency, more CNS penetration like the Zartinib have also come into use in Ph-positive ALLs. Then this is another upcoming area, the pH-like ALS, which are usually associated with the ABL1 rearrangements, CRLF2 rearrangements, and JAK2 rearrangements on genetic studies. That they again are very resistant to conventional treatment with high levels of MRD, resistant to L-asparagines and anthracyclines, and a very poor outcome. But again, they also respond quite well to tyrosine kinase inhibitors like imatinib or Dasatinib, and even JAK inhibitors like ruxolitinib are also being tried in various trials. And this is one important role. Unlike counseling a parent whose child is above 1 year, the counseling for a child with an infant having diagnosed with ALS is actually quite different, because infant ALS are generally associated with a poor prognosis. They will usually have very high risk features at presentation, like a high initial count, massive organomegaly, CNS leukemia, etc. And the chemotherapy protocols, they express both the ALL markers as well as the myeloid markers. Chemotherapy protocols integrate both the ALL and the AML treatment elements, but still they're associated greater resistance to therapy, higher rates of injection failure and treatment, classically associated with the MLL or the KMT2A rearrangements in almost 75%, very poor prognosis. Most high-risk ALS, high-risk infant ALS may request stem cell transplantation. Even with that, the outcomes are quite guarded, especially if the child is less than 6 months. If the total count at presentation is more than 3 lakhs. Okay, now just quickly go through acute myeloid leukemia as well. This classification we have seen earlier. So the basic diagnostic workup is almost the same as for ALL, but the one difference is bone marrow blast percentage required for diagnosis of AML is more than 20%. And if you have a recurrent cytogenetic abnormality, then you do not need even that 20% cutoff for the diagnosis of an acute myeloid leukemia. Again, as we mentioned for ALL, in AML also, there is a risk stratification into the favorable risk and the high risk acute myeloid leukemias. So the favorable acute myeloid leukemias are those associated with recurrent cytogenetic abnormalities, translocation 821, inversion 16, the NPM mutated, SEPA mutated, etc. And the 1517 is actually a separate entity, the PML RARA, APML, very good prognosis. The adverse prognostic factors are the monosomy 5 and 7 and the whole list of 11, except 111 which comes here, the whole list of MLL rearrangements seen in AML is associated with the poor prognosis, high-risk AML. So these are the favorable risk AMLs, and all the cytogenetic abnormalities, including the FLT3 ITD, 11q rearrangements, monosomies of 5 and 7 are all high-risk AMLs. So it is important to know the risk, because the current treatment is based on the risk of AML. And granulocytic sarcomas, it is actually considered, myeloid sarcoma is taken as a separate entity in the current WHO classification. They can either occur along with an AML, before the presentation of an AML, or after treatment completion of AML at relapse. Usually associated with M2, they are so with the translocation 821, which is a good prognostic indicator, and the presence of granulocytic sarcomas are usually associated with good prognosis. Even if it is an isolated, the important point is, even if it is an isolated granulocytic sarcoma without a bone marrow involvement, we usually treat as if there is a systemic disease. And if it does not respond completely to the systemic chemotherapy, radiation must be given. The general aspect of treatment in AML is they should prefer, the best outcomes are if you treat them within the context of various clinical trials. So based on the risk stratification, the attempt is to avoid over treatment in the favorable risk and to increase or enhance the treatment in those with a poor prognosis. Again, as for AML, despite with the use of intensive chemotherapy and other modalities, the survivals have increased from 5% to nearly 60%. But in India, the outcomes are still less, with only around 30 to 40% survival rates for AML. AML treatment, very short duration, only 2 phases, induction and post-remission. Induction essentially to attain remission, and post-remission to consolidate the remission that has been attained. Maintenance therapy is not part of the most pediatric AML protocol except the BFM protocol, and in acute promyelocytic leukemia where there's a long maintenance therapy. Another difference from the, so two basic differences from ALL therapy. One, there is no role for maintenance therapy. Second, CNS irradiation is not generally necessary in patients, either as prophylaxis or as treatment if it clears with a systemic therapy. The injection in this group of acute leukemias AMLs is with cytarabine and anthracycline. Most of us have heard about the 3+7 regimen, 3 days of daunorubicin plus 7 days of cytarabine, around 85% attained remission. The concern here during the remission injection phase of AML is the anthracycline toxicity. So various trials have tried using other agents like using mitoxantrone instead of anthracycline to reduce the cardiotoxicity. Some have tried giving liposomal daunorubicin instead of the usual daunorubicin to reduce the toxicity, with actually good results. The toxicity has come down, and in centers outside India, most of them have either AIE or ME, the mitoxantrone or the idarubicin or the liposomal daunorubicin as their induction anthracycline. Antibody conjugates like gemtuzumab and targeted therapy with midostaurin and sorafenib for the FLT3 mutation have also been tried in various trials. The post-remission therapy is very important. The basic question is it a high-dose chemotherapy or is it an allogenic stem cell transplantation? The decision will depend upon what is the risk. If it is a low risk, stem cell transplantation is not required. They usually will have very good outcomes with just chemotherapy, high-dose chemotherapy. High risk, you give chemotherapy or you give stem cell transplantation, the outcomes are still very guarded. But the recommendation is you preferably go for allogenic stem cell transplantation if the patient is a high risk. So those two are very clear. Low risk, mostly chemotherapy only. High risk, mostly transplantation only. Intermediate risk, there are conflicting evidence regarding the role. And so mostly now it is taken as if it's a refractory AML or if the MRD is positive in an intermediate risk AML, it's better to go for allogenic stem cell transplantation. But in AML, the most important thing is the supportive care. Prophylactic antibiotics and antifungals are very important in AML care. Severe infections, prolonged profound neutropenia, severe infections, drug-resistant infections are quite difficult to tackle. Infections can occur in AML. So management of infections is important. The neutropenia has to be managed with long-term use of GCSF. Blood transfusion support is very important in AML treatment. And the monitoring for cardiac toxicity is another essential component of the AML treatment. So in the treatment of acute leukemia, the present concern is one is it is risk-based, second it is response adapted. The third thing is we are always trying to balance a cure with the late effects. As I mentioned, all these alkylating agents, all these antimetabolites, the cranial radiation therapy, everything is associated with long-term side effects like neurocognitive, cardiac dysfunction, skeletal, cataracts, obesity and metabolic syndrome, neuromuscular, with a higher chance for a second malignant neoplasm, even based on the drugs that you give, those of radiation you give. So the biggest challenge is to balance the cure with the late effects in these children suffering from acute leukemia. Thank you. Thank you so much.
We will take the questions. Yes, sir. We can take the questions after the session, sir. Mirza madam, can you stop sharing the screen?
Yeah, just a second. Chitan, you'll have to help me stop share. Yeah, thank you. Yeah, done.
Okay. Another question, sir? Another question, sir, is the
the moderator of this session, Dr. Anandakeshwaran, has taken a short break. He has informed me. So I am here to take over. So the next session, we move on to the next session, that is leukemia in Down syndrome. The speaker is Dr. Manjusha Nair of Regional RCC, Regional Cancer Center, Trivandrum. And this particular session was supposed to be handled by Dr. Guru, and he couldn't make it. So Dr. Manjusha Nair is here. Thank you, Dr. Manjusha, for taking over the topic from Dr. Guru Prasad. So we all know Down syndrome is a very common problem, and it is associated with a lot of medical conditions like congenital heart disease, GIT problems, and cancer. And ALL and AML is a very, very common association with Down syndrome. So Dr. Manjusha will enlighten us with the genetics, management, survival, and all those things connected with Down syndrome. Over to you, Dr. Manjusha. And just give a brief introduction. She had her MBBS from Trivandrum Medical College, Defending Pediatrics from SIT Hospital, Trivandrum, PG Diploma in Adolescent Pediatrics and Pediatric Palliative Care Training from MNJ Hospital, Hyderabad. Special interest is in pediatric pain and palliative and supportive care. So that is Dr. Manjusha. Over to you.
Manju madam, you can share the screen now. Manjusha madam? Okay. Unmute madam. Unmute. Microphone symbol click ചെയ്താൽ മതി. Okay.
Forgot it. Yeah.
Screen share ചെയ്യാൻ ഒരു share screen എന്നൊരു ഓപ്ഷൻ കാണാം.
Okay. Yeah, thank you.
Over to you, Dr. Manjusha. You have.
I'm sorry for the trouble. Yeah.
Just fine. We have given the introduction of the topic as well as the speaker. Now it is over to you.
1 second. Yeah. Thank you, IAP Kanhangad. Am I visible, Jitin? Am I audible, Jitin?
Yes.
Yeah. Thank you. So thank you, IAP Kanhangad, for this opportunity. I hope I am a good replacement to Guru. So shall I start? So today's topic is on leukemia in Down syndrome. So why this topic is important as a pediatrician is because you are going to see Down syndrome children in the daily practice, and we need to know what are the hematological abnormalities associated and how to tackle with that. Of course, we all know that they are at more risk for leukemia. Rather than the management of leukemia, how to monitor and look for the complications is what is important for us as pediatricians. So Down syndrome children can have a lot of problems. As newborns, they can have present with non-specific cytopenias, or they may have a condition, a transient condition called the transient myeloproliferative disorder, which we are familiar. We have been reading about that in our theory classes, and maybe we might have seen some cases also. Coming to the infants or children, the two major hematological problems that they are going to have is acute leukemia and myelodysplasia. Now, the acute leukemia could be acute lymphoblastic leukemia or acute myeloid leukemia, and myelodysplasia also may be found. So basically, I'm going to focus on my talk regarding these two entities, transient myeloproliferative disorders. When do you look for that? Why and how it occurs? What is the relationship with the acute megakaryocytic leukemia? Which kids to treat? Do all kids need treatment, or you need to treat only some kids? By treating, can we prevent the transformation to leukemia? And how to monitor these babies, Down syndrome babies, how to monitor them for transient myeloproliferative disorder or leukemias. And about leukemias, of course, they are managed in a cancer center, but then still, as pediatricians, we would like to know whether AML or ALL is more common, what is the treatment, whether you give the standard treatment as for the leukemias or you do some dose modifications for them. What are the problems anticipated? Because most of these children, while they are on treatment, on maintenance treatment, they might come to pediatricians for the problem. So what are the problems we can anticipate? And then what is the, I'm sorry, the last slide should be what is the prognosis. So we would like to know the prognosis also, because most of the times you need to counsel the parents. So about transient myeloproliferative disorder or transient abnormal myelopoiesis, it is a clonal disorder of hematopoiesis seen in Down syndrome children. The main features are it classically occurs in the newborn period, and it is characterized by circulating blasts in the peripheral blood. Now, blasts may be there even if their counts are low. Child may present with cytopenia or like leukocytosis, but circulating blasts and normoblasts will be there in the blood. It is transient. It is there in the name itself. It is transient. That means that spontaneous regression occurs in majority of cases. And it is exclusively linked to trisomy 21. Now, trisomy 21 can be either constitutional or mosaic, but the linkage is to the trisomy 21. So when to diagnose the transient myeloproliferative disorder? Of the Down syndrome, do everyone develop that? No, the incidence is seen only in 5 to 10% of newborns. But then there is a catch here. Even though the overt manifestations or the peripheral blasts are seen in 5 to 10%, in the another 10% of cases, their children don't have any clinical manifestations or peripheral blasts, but they can be having the GATA1 mutation. The last point that I have told, the mutations may be seen in the blast. So that is considered as the silent TMD. So if you count them also, the total incidence comes to around 17 to 20% of the children with Down syndrome. The median age of diagnosis is within the first week and rarely beyond the 4 months. Most of them get diagnosed at around 2 months of age, rarely goes beyond 4 months of age. Classically, there is the leukoerythroblastic picture will be there with circulating blasts more than 10%. And these blasts will be morphologically and phenotypically looking like the AML blast, not like the ALL blast. And mostly they will be of the megakaryocytic lineage, and blasts may show the GATA1 mutation. A blast will show the GATA1 mutation also. So this diagnosis can be challenging if the child doesn't have the phenotypic features of the Down syndrome. In patients with mosaic Down syndrome, the diagnosis can be challenging. We will think of other DDs like the sepsis, intrauterine infections, or prematurity related complications, metabolic disorders also. So much so that when transient myeloproliferative disorder is clinically suspected, it is recommended to do a cytogenetic karyotypic analysis. So even if the child phenotype is normal, the trisomy 21 should be looked for. Clinical presentation, as I told earlier, these children may present with cytopenias or leukocytosis. So cytopenias, the child may come to the clinic with pallor or bleeds or a febrile illness. 10 to 15% of these children may have even hyperleukocytosis, which means that WBC count will be more than 1 lakh per cubic millimeter. So they can present with hyperleukocytosis also. Around 10% of these children will have, now TMD is a very systemic disorder. So it will affect so many other systems also. 10% of the children may present with coagulopathy, with increased risk of disseminated intravascular coagulation, which is very fatal in these children. Children may present with hepatomegaly, splenomegaly, but generally generalized lymphadenopathy that we see in the acute leukemia is not very common in the TMD. In the newborn may present with delayed hyperbilirubinemia without any other cause. The cause may be TMD. Children may present with liver or renal dysfunction or failure. There may be pulmonary manifestations. So these are actually very uncommon, but if there, it is going to be very high risk. That is effusions, respiratory failure. It occurs because of the massive hepatomegaly. These children have massive hepatomegaly, and secondary to the massive hepatomegaly or the pulmonary congestion due to the high counts, pulmonary manifestations may occur. CNS manifestations like seizures, altered sensorium are very uncommon. Important point to note is that there may be an asymptomatic presentation also. So like child is coming for a routine immunization visit or a routine follow-up visit, and we just send a blood count and find the blasts in the peripheral blood smears. May happen with or without leukocytosis. So there is another presentation like that also. Newborns may present with very severe disease also. like marked hepatosplenomegaly, effusions, multi-organ failure. All this happens due to the blast cell infiltration. And in the fetus, there may be hydrops fetalis or stillborn. So now what is the pathogenesis? How this transient myeloproliferative disorder occurs? It is considered as a pre-malignant condition. So there are very few conditions in pediatric oncology that a pre-malignant condition exists, and this is one of the pre-malignant condition. So here what happens, as we all might have heard that the pathogenesis of cancer is by the genetic mutations, or we call it as the hits. So here the trisomy 21 forms the first hit. That is, trisomy 21 itself is responsible for the abnormal hematopoiesis, especially of the megakaryocyte and the erythroid lineage. Their differentiation, maturation, everything is affected because of the trisomy 21 per se. There are certain genes located on the chromosome 21, like the RUNX1, ETST, these are the cancer-linked genes. So these, always the extra copy will be there in case of the trisomy 21 patients. And also trisomy 21 per se causes immunodeficiency by altering the T cell, B cell, all the multifactorial mechanisms. It itself causes the immunodeficiency, which predisposes to development of TMD. So this is the first hit, but this itself, just the presence of trisomy 21 is not enough to cause the disease. There is an additional mutation called the GATA1 gene mutation. So this is considered as the second hit. So in the megakaryoblast, there is in the short arm of chromosome X, there is a key hemopoietic transcription factor belonging to the GATA1 family. It has an essential role in the megakaryocyte and erythroid differentiation, and there is a mutation in this gene which results in a shortened protein. The normal protein is not formed. Instead of that, the shortened protein is formed, and that will impair the growth and differentiation of the fetal or embryonic hematogenic progenitor. So what happens is abnormal accumulation of these megakaryocytic progenitors will occur. So where does it occur? So this change, or this GATA1 mutation, or this abnormal hematopoiesis is seen to begin as early as the second trimester of intrauterine life. So in the fetal condition, the liver is the major hematopoietic organ. So that is why liver is most affected during the intrauterine life. And that also explains why these some fetuses will present with hydrops, just newborns, like they present with stillbirth, they present with the severe disease. It is because of the liver infiltration. But then after birth, the hematopoiesis will shift gradually to the bone marrow in the postnatal life. So the abnormal clone will die off naturally. So that will explain why it gets spontaneously resolution. So now there is another entity called the silent TAM, as I mentioned earlier. These children will be with Down syndrome, but will not have any clinical signs of TAM or increase in peripheral blood blast, but the mutation will be there. So there will be minor clones carrying the mutation. So they are also regarded as one form of transient abnormal myelopoiesis only. So this picture demonstrates the evolution or the natural history of the TAM. So if we can see some children will present with the large clones. So they will present with the more severe disease. And the children who have small clones at birth, they will just present as the silent TAM. The symptoms depend on the largeness of the clone. Both will have regression. Both of these will regress within the under 6 months, and both of them carry the risk of future development of the myeloid leukemia of the Down syndrome. This we will be coming to later. How it develops into the myeloid leukemia will come to later. Yeah. So this slide is showing the natural history of TMD again. Some percentages to remember, because we need to counsel the as pediatricians, we need to counsel the parents. So what happens to children with Down syndrome? TMD. Around 5 to 10% of the total Down syndrome will only present with TMD. Of that, the major chunk will resolve. Around 15 to 20% will result in early death because they'll be presenting with very severe disease and multi-organ involvement. Around 13 to 30% will progress to the, of these 10%, only 30% will progress into the Down syndrome related myeloid leukemia. And after treatment of Down syndrome related myeloid leukemia also, around 80 to 85% survival is expected. So this is roughly regarding the natural history of the TMD. So blasts of, one slide was missed, I'm sorry. So what is the relationship between transient myeloproliferative disorder and the megakaryocytic leukemia? So this transformation occurs, as I told in the previous slide, around 30% will transform. But what causes this transformation? Nobody knows. Only trisomy 21 and only GATA1 mutation is not enough to transform into the myeloid leukemia. So there may be additional factors that are operating. So people have found that there may be additional genetic mutations in the chromosomes. See, lot of chromosomal mutations may be there, number 1, number 6, number 7 deletions, additions, all may happen. These all have been demonstrated. Also, the mutations in the cancer-related genes may occur, like this JAK, TP53, FLT3. These are all cancer-related genes. So additional mutations in cancer-related genes are also found. There is one theory that the clonal evolution, like this TAM, when this transient abnormal myelopoiesis blast itself, they have the genetic heterogeneity, so that some certain clones may get selected during the overtime. When this disease resolves, over time what happens is some clones, they don't resolve and they get selected over the others, and then they try to proliferate and expand. So that causes the AMKL. That is also one of the hypothesis that is being looked after. And another mechanism is the tumor microenvironment. Now, in many cancers, this epigenetic dysregulation is something that is how the outside factors will affect, how the microenvironment factors will affect the genetic mutations. So that is being found out. It is being found out in the trisomy, the transient myeloproliferative disorder also. So blasts of both transient myeloproliferative disorder as well as megakaryocytic leukemia are essentially the same in immunohistochemistry or in the mutations or in the morphology. So it's very, very difficult to distinguish between the two conditions. Then how do you know? How do you make sure that this is a TMD or this is one AMKL is coming? So 2 points to differentiate are: one is age. Generally, transient myeloproliferative disorder is never seen after 6 months of age. So after 6 months of age, if such a picture and such a blast picture with such a trisomy 21 and GATA1 mutation is seen, we are suspecting a megakaryocytic leukemia. Also regarding the blast percentage. So even though blasts are there in transient myeloproliferative disorder, the number is very less. Around 10% or 15% circulating blasts will also be there. Like in the previous talk, Dr. Benita told, you need at least 20-25% of the blast to diagnose it as megakaryocytic leukemia. So that is how you can make sure that it is a AMKL. So now the question is, like, as pediatricians, we are sitting there. So we want to know which of these children. We know that 30% will develop the AMKL, but which child will develop? So people have tried to study. So 3 oncology group studies, these large cooperative group studies, because one trisomy 21, the incidence itself is less in the population. Of them, only less number get the TMD. So number of patients will be very less for the individual people to recommend. So they have found the cooperative groups, and the cooperative group studies, people have these groups have tried to assess like what causes the risk, certain children, whether they are at increased risk of developing the megakaryocytic leukemia. So these 3 trials, this pediatric oncology group, this is the BFM group, which is the European group, and the children's oncology group. These trials found some factors which may affect the transformation. For example, so this one group found that there are additional chromosomal abnormalities at the TAM phase only, so that may persist. Some of them found that children, who present with pleural effusion at diagnosis will later develop AMKL. All these are just findings of the studies. At present, there is no evidence that you can predict the leukemic transformation based on the presently available tests or presently available study results. Now people are going for the molecular studies. So they have found that as I mentioned earlier, one shortened GATA1 protein is the product of this genetic mutation. So if you can measure the level of those GATA1S levels, people have found that the children who have low levels, So they have the, they can be predicted to develop the megakaryocytic leukemia, or maybe the type of GATA1 mutation. Studies are going on. There is no recommendation, but these are the recent evidences. So at present, it is not possible to predict. Now the important question is, do we need to treat all? We are seeing, we are sitting in a OP or in a private practice, we are seeing this child with a transient myeloproliferative disorder. Do we need to treat? Do we need to refer to the oncology for treating? So the natural history is spontaneous resolution. Within months, it will resolve. So of that, we can be somewhat reassured that it will rear. But there are two concerns. The concerns are early death. Why early death occurs is child may be okay now, but may develop progressive symptoms like leukocytosis or ascites or liver dysfunction, and may lead to early death. So that is one concern. Another concern is, of course, transformation to leukemia. So both cannot be predicted. So what is needed is close follow-up and monitoring. For treatment purpose, that is why they have been classified into two groups. So low risk is the group with transient abnormal myelopoiesis who have clinical manifestations like hepatomegaly or the cytopenias, but there are no life-threatening symptoms. Whereas high-risk patients, these form only around 30% of the patients with the TAM. So they have these high-risk features like the WBC more than 1 lakh, or hepatomegaly with severe liver dysfunction, DIC, effusions will be there, ascites will be there, severe edema, serous effusions, cardiorespiratory, or the liver function abnormality. So they are considered as, all the life-threatening symptoms are considered as, children with the life-threatening symptoms are considered as high risk, and they should be sent for treatment. So now you have two groups of children, those with life-threatening symptoms and those without. So how do you go about monitoring these? So children with without life-threatening symptoms, it is suggested to monitor with full blood count and liver function tests. So those of us sitting as the periphery should be aware enough to know that LFT should also be done. Full blood counts and LFT should also be done 1 to 2 monthly until there is spontaneous remission. And if there are persistent abnormalities, then child may be referred for further tests or analysis. Then all children who, suppose this has spontaneously resolved, or suppose there is no history of TAM and we don't know whether it was a silent TAM. A child has come to us, we should monitor every 3 monthly. Then the guideline is for monitoring every 3 monthly until the age of 2 years. And then after 2 years, if the peripheral blood, we are monitoring the child, everything is okay, then even then monitoring should continue 6 monthly until the age of 4 years, because till the age of 4 years is the time when there is chance of developing a acute myeloid leukemia. Anything abnormal in between, in this monitoring period, any abnormal blood counts should make us refer the child to oncology center for doing the bone marrow studies. So now coming to the treatment. Treatment is of course done at an oncology center, but we as pediatricians should know that who is going to get the treatment. When we refer a child, we should know that whether the child will get the treatment or not. So treatment is reserved for the severely symptomatic or high risk patients. So aim of treatment is not to, unlike in the aim, like in the previous talk, we heard that the aim of the treatment is to eradicate the leukemic clones and to keep it at the lower level. Here, the aim of the treatment is not to eradicate the abnormal clone, but the prevention of early death. Why? Because the clone eradication occurs as a spontaneous process. We want to prevent the early death. So that is why we are giving the symptoms. So what is the problem here is that we all as pediatricians, we know that this condition is going to resolve spontaneously. Then why to start chemotherapy? Down syndrome child only, he will not tolerate chemotherapy. So why to start chemotherapy? That is the question that is coming in a general pediatrician's mind. So what happens is, if we delay in starting the treatment, then potentially life-saving treatment, we lose the chance that we get to save this child. So for our information, in low doses, cytarabine can be given. It has a low toxicity only. These children tolerate. So this is the take-home message for all pediatricians who are watching this, that cytarabine in low doses has low toxicity only. Trisomy 21 children will tolerate the treatment. So this has been tried by large pediatric oncology cooperative groups. They have found out regimens. So the COG has found one higher dose of regimen of 3.3 milligram per kg per day into 5 days. Only that much is needed. And BFM has found a lower dose range, 0.5 to 1.5. There is a big difference between these two. Of course, in this COG study, they found that around 90-95% of their children had toxicity also. So always this treatment should be given in an oncology center only with facility for supportive care. So this is the cytarabine treatment. So why cytarabine? So what is the relation between this cytarabine and the blasts of the megakaryocytic leukemia? This presence of GATA1 mutation, what it does is it alters the expression of genes involved in the metabolism of cytarabine. There are two enzymes, cystathionine beta synthetase, which is involved in the generation of the active metabolite of the ARAC. It is called the ARACTP, and that is what is contributing to the anti-leukemic activity. So, and there is this enzyme cytidine deaminase that will inactivate the ARAC to the inactive product like the ARAU. So here what happens is there is overexpression of the activating enzyme and underexpression of the deactivating enzyme. So that is why these blasts are very much sensitive to the effects of the cytarabine, and that is why only low doses are also needed for the control. Along with that, some anti-apoptotic protein like BCL2, these are found to be lower expressed in the AMKL blast. So that if you give chemotherapy, the apoptosis, chemotherapy-induced apoptosis, that is one mechanism by which the leukemic cells are eradicated by giving the chemotherapy. This mechanism is enhanced so that more apoptosis is there and you get a control over the disease. So that is why extremely sensitive to even lower doses of cytarabine, so that higher doses may result in the significant toxicity. So recommendation of treatment for this child, always you have to assess all the neonates with the transient myeloproliferative disorder for life-threatening symptoms. Do a clinical examination, do an LFT, and a peripheral smear, and we have to closely monitor. Of these, any child with life-threatening symptom, please refer for treatment without delay. Treatment with low-dose cytarabine, and treated children should be closely monitored for neutropenia and sepsis. Of course, if the child is coming with liver disease and a liver dysfunction, it may not respond to only one course. So maybe repeated courses may be needed. That will be taken care of at an oncology center. And previously exchange transfusional leukapheresis, because as I told earlier, some of these children may present with very high counts. So actually these may help to reduce the acute count reduction, but it's not a definitive treatment. Definitive treatment is low-dose cytarabine only. Now the question is, does the treatment prevent transformation to megakaryocytic leukemia? It's $1 million question. Everybody wants to answer because there is a pre-leukemic condition. You want to know something like, by doing something, if I can prevent the leukemia, it will be so nice. So there was this big study called the TMD Prevention 2007 study. It's a multi-center study of low-dose cytarabine to prevent myeloid leukemia in children with Down syndrome. The result of this study was that low-dose cytarabine successfully induced remission in these children and prevented early death. So our aim for starting treatment is, achieved, but it did not help in resolving hepatomegaly and did not prevent transformation to megakaryocytic leukemia. Further studies are going on. People are constantly trying to find out whether we can prevent. But at present, there is no evidence to support the use of routine cytarabine. A child who does not have life-threatening symptoms also, if you give cytarabine, if the whether the AMKL can be prevented, there is no evidence like that. So it is not recommended. Only for the child with symptoms or the high-risk children, you give the cytarabine. So now, this is the point I discussed earlier only. Now, what happens if the child with less blast percentage or blast percentage, child is coming first time to us and it is not, I'm sorry, there is one more slide. Yeah, this is the recommendation for monitoring of newborn with Down syndrome. So now here we are talking about normal newborn with Down syndrome or suspected Down syndrome who has come to us. There are guidelines which came in 2018 by the British Journal of British Society of Hematology. And they have recommended that first you see this child, you examine for organomegaly, cholestasis, hepatopathy, skin rash, pericardial or pleural effusions. And within the first 3 days of life, this is a normal newborn who is coming to us for a visit. So within the first 3 days of life, or the child who got delivered in our institute. So within the first three days of life, do a full blood count and blood smear. And you have to assess for the peripheral blood blast cell percentage. So if by these tests and by the clinical examination, we suspect that TMD is likely, then we should send for the additional tests like the LFT, chest X-ray, echocardiogram, and abdominal ultrasound. And then we should constantly monitor. Any neonate with a blast percentage of more than 10% or clinical features suggest you should be discussed urgently. So any child with the previous test abnormal and with the clinical features of TMD, pediatric oncology discussion should be discussed with the pediatric oncology and regarding the further monitoring. Now, any neonate with a blast percentage less than 10%, or suppose blast percentage is not performed in the first 3 days of life, or in whom you don't know, phenotypically doesn't look like Down syndrome, so we did not send the blast percentage, or there was significant intrauterine growth retardation so that the blast count may be suppressed. Still, we should be considering to be at risk of clinical problems and should be monitored. First 4 to 8 weeks of life, we should monitor these children regularly. So that was about the transient myeloproliferative disorder. Now coming to the second part, that is the leukemia. So we all know, we have studied in our in pediatrics training period also that leukemia in children, Down syndrome children have a 20-fold higher risk to develop any type of leukemia compared with children without Down syndrome, and they have 400-fold excess risk of developing M7 type of AML or the acute megakaryocytic leukemia, particularly in the younger children. And we have studied during our PG days that the leukemia subtype ratio AML is to ALL is 20 to 80, that is 80% lymphoid and 20% myeloid in the general population. Because of the higher prevalence of this myeloid leukemia in younger children, this shifts to the 60% lymphoid and 40% myeloid. So the point to take home is still commonest leukemia is ALL only, not AML. Only thing is AML, the prevalence is more, that the percentage is more, that's all. So now I will come to the ALL and AML separately. Before that, challenges in total for treating leukemias in Down syndrome, what are the challenges? So earlier what happened is survivals were uniformly poor because as we all know, we will all think that Down syndrome child may be having so many cardiac problems, maybe having prematurity, growth retardation, hypotonia, so many problems. Will he tolerate chemotherapy? So they used to withhold chemotherapy, especially the toxic chemotherapy like the anthracycline and all, with concern for toxicity. So what happens is they used to get the inadequate treatment. But then that resulted in the increased number of relapses in these children. And these children, it was very difficult to tolerate the stem cell transplants and other treatments given for the relapsed leukemia also. So people now in the modern studies, they have proved that then what happens, there are developments in the supportive care. So now aggressive supportive care can be given, and they have proved that the comparable survivals can be achieved by giving standard treatment and the aggressive supportive care. So the problem is that because they are extremely sensitive to the chemotherapy drugs, so treatment related mortality is very, very high. So you get good survivals, but at the same time, you may lose children during treatment because of the toxicity. So it is kind of balancing the cure and the toxicity. So like the speaker before told, the ALL treatment is balancing the cure and the late effects. Here it is balancing the cure and the immediate effect. You get the immediate toxicity, immediate treatment related toxicity. So how do you do that? We'll come to that later in the each subtype. So myeloid leukemia of Down syndrome, as I already told, commonest subtype of AML. But then in the, how common is megakaryocyte leukemia in other children? It is very, very extremely rare. So peak incidence of AMKL in Down syndrome is by 2 years of age, and almost all will appear by 4 years of age. Then frequently what happens is this Down syndrome patients who are having this transient myeloproliferative disorder, they will show a myelodysplastic phase with thrombocytopenia and all preceding the development of ALL. So when that phase occurs, we need to be vigilant and alert that this child may go in for a leukemia. Down syndrome children with no history of TMD will also develop AMKL, and risk for MLDS will remain the same for the mosaic children also, because trisomy 21 is there. They also are having high risk for developing the MLDS. So diagnosis and all is as for our normal myeloid syndrome only, bone marrow test and everything we have to do and prove the diagnosis. And how do you treat them? That is the main thing we, as pediatricians, we want to know. Do we give them the standard treatment, or do you do some modifications in treatment? So the point here is these blasts are extremely sensitive to chemotherapy drugs. Cytarabine I already told earlier. They are also sensitive to anthracyclines and etoposide. So these three drugs are the backbone of any AML therapy. So they are extremely sensitive to all these drugs. So the treatment is to give 4 or 5, 3 or 4 courses of these combination chemotherapy. See this one in this protocol, this is the ML2, this is the standard, protocol that is being followed and adapted in the major centers. So there is one induction course, and then this is, cytarabine lower doses, and then you give the consolidation with high dose cytarabine. See here the dose is 1 gram every 12th hourly. So that is around 2 gram per meter square. Here it is 100 milligram, here it is 500 milligram. So escalating doses of cytarabine you give, you induce the remission, and then you consolidate with the cytarabine. That is the main principle of treatment. And then this has to be supported with aggressive supportive care to deal with the infections and complications. So now the modification in the treatment is that there are special nomograms for children for calculating doses of cytarabine and anthracyclines. Down syndrome specific nomograms are present. Dose has to be calculated. Dose reduction is also given, as we saw in that slide. Dose reduction is also given for dose reduction is also given for children with body weight less than 12 kg. Also, that dose reduction is given. Then cranial radiation and maintenance therapy. These two are avoided because studies have shown no benefit with these one. So that is the basic therapeutic modifications or interventions that we do to prevent the early or treatment related toxicity while maintaining the good survivals. So after the treatment, we should like to know what is the prognosis. So this is a chart from the BFM study for AML. See if we can see this one is this uninterrupted line is the non-Down syndrome myeloid leukemia, and this one, these two lines are the chart for the Down syndrome. So actually they respond. See in this 98 one, the survival is as good as 91%, and here it is around 70%. So the prognosis is fairly good, around 70 to 90% survival with aggressive chemotherapy. If you are able to prevent the early deaths, that much survivals can be achieved. So it's actually a favorable leukemia. So this we were talking about children who are less than 4 years of age, who have this trisomy 21 and the GATA1 mutation. What happens to older children? By the time they are more than 4 years of age, this TMD blast might have, TMD clone might have gone, and the GATA1 mutations might have disappeared. So in the child who is older than a child with Down syndrome who is older than 4 years of age, diagnosis of GATA1 mutation is recommended, because if they don't have the GATA1 mutation, this favorable response to chemotherapy, which we have discussed earlier, does not happen. So their prognosis is worse, and similar to non-Down syndrome children with AML and especially M7 leukemia carries a very, very, very bad prognosis. So these children also have that much bad prognosis only if this mutation is not there. So in children less than 4 years, in 85-90% of cases, the mutation will be there. So we need not test for that. But in children more than 4 years of age, we need to test. If the mutation is present, we will treat according to the Down syndrome myeloid leukemia protocol. If the mutation is not present, we have to treat with the general AML protocol with the aggressive therapy, and still the prognosis is going to be bad. So this is a very important point for us to know, that age impacts the prognosis in case of a MLDS. Now coming to the ALL in Down syndrome. Clinical presentation, management, everything is similar to that of the non-Down syndrome ALL. The normally, like Dr. Benita told, all the factors, clinical features, risk stratification, everything is the same. But the prognosis, when you see, it is significantly poor. So why with standard treatment, the prognosis is poor is that they have higher relapse rate. and the higher treatment mortality. So these two contribute to the poor survivals. And as we saw, the myeloblast will have the better sensitivity to the chemotherapeutic agent. But unfortunately, the lymphoblasts do not have those mutations and all, and they don't demonstrate greater sensitivity to the chemotherapy agents. So in the ALL, the previous speaker has talked about a lot of, favorable cytogenetics, unfavorable cytogenetics. So exclusively, so these cytogenetics are not present. So it is essentially a normal cytogenetic ALL only. The favorable cytogenetics is also not present. The unfavorable, like the BCR-ABL, that is also not present. And there is no infant leukemia, and it is exclusively B immunophenotype. TALL is very, 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 very uncommonly seen in the Down syndrome. Then these two gene expressions, the CRLF2 and the Icaro-zinc factor 1, they are actually mutations which are associated with the bad prognosis in the other AMLs. So they are found in other ALL. So they are found in case of Down syndrome ALL, may contribute alone or in combination with both, may contribute to the bad survivals. Treatment is, as the speaker before me told, multi-agent chemotherapy, all the phases of treatment, all the supportive care, all the initial management of the tumor lysis syndrome, everything is the same. Everything should be given with the same intensity to the Down syndrome child with the ALL also. But here, aggressive supportive care should be given. And here the problem is early recognition and management of infections. So they are bound to have Down syndrome specific problems. We should anticipate those problems and we should take care of that. Then we can achieve a comparable survivals. Treatment related mortality is actually 5-fold more than in the non-Down syndrome cases. Why it occurs in Down syndrome is because of the underlying immunodeficiency, then deficiency of the B cell, T cell numbers, functions, everything is altered. And so what happens is once a febrile neutropenia sets in, the chance of high risk life-threatening complications are more. And always they will have this oral and perianal mucositis. So there is constant epithelial breach also. From there is always chance of infection spreading into the bloodstream and high complications. So these contribute to the mortality. What we should anticipate problems while treating a child with Down syndrome in ALL, what we should anticipate is with steroid therapy, there is high incidence of hyperglycemia that will lead to the complications. There is increased risk of induction complication and induction death. While in the first 4 weeks of intensive chemotherapy is called as induction, there is very high chance of induction related death in case of a Down syndrome child. Oral mucositis and typhlitis. The bowel problems incidence is higher than the non-Down syndrome children. There is higher incidence of anthracycline related cardiotoxicity, maybe acute cardiotoxicity or maybe later cardiotoxicity. There is higher incidence of severe systemic toxicity with methotrexate. Methotrexate is a drug which is used almost as a backbone of treatment for ALL, and there may be systemic toxicity, severe toxicity with methotrexate. And there is always increased risk of infections during the maintenance phase because of the prolonged immunosuppression by the chemotherapeutic agent as well as Down syndrome per se. So what do we modify here? So we adjust the dose of the anthracyclines here. Then after intrathecal methotrexate, we give the leucovorin rescue to prevent the systemic toxicity and oral mucositis. High-dose methotrexate blocks, which are the backbone of the cranial CNS-directed therapy in the ALL. High-dose methotrexate blocks are actually recommended as 3 to 5 grams per meter square. But they will not tolerate this one. So we start at the lower dose. We start at almost 1/10 the dose. See, this dose is called the intermediate dose only. So 500 milligram per meter square, which we will start, and then we will increase as per the tolerance of the child. And then in case of delayed intensification, there is a phase called delayed intensification where you get high dose dexamethasone you give for 4 weeks continuously. So maybe we will give it 2 weekly, or we will give it interrupted, 1 week off, 1 week on, to prevent the hyperglycemic complication and avoidance of cranial radiation. So these are the modifications that we do in the standard ALL therapy. Now, what about anthracycline toxicity? As many of us pediatricians will think, these children are having cardiac toxicity because of the congenital heart disease. It is not like that. There is no evidence that anthracycline related cardiac toxicity is associated with congenital heart disease. It occurs because of the altered expression of the superoxide dismutase and carbonyl reductase. These are involved in the oxygen radical and anthracycline metabolism. These genes are located on the chromosome 21. So since additional chromosome 21 copies are there is more toxicity. That is the reason for the toxicity. So that dose-adjusted anthracycline treatment can be given. If we check the echo, we check the LV ejection fraction. If the function is normal, dose-adjusted anthracycline can be given. There is no need to withhold the anthracycline, because if we withhold, the relapse will be more. Then similar to the methotrexate. Methotrexate is a very important drug in the treatment of ALL. Down syndrome children have altered folate metabolism. So this gene for the reduced folate carrier, this reduced folate carrier is the one which helps the intracellular accumulation of the methotrexate. Only if it accumulates in the blast cell, it can produce the cytolytic effect. So this gene, which is this gene for the reduced folate carrier, is localized on the chromosome 21. So extra copy of chromosome 21 is there in all cells in the Down syndrome. So what happens is all the cells will accumulate, not only the blast cell, but all the systemic cells will also accumulate the methotrexate. So severe systemic toxicity occurs. So myelosuppression, mucositis, hepatic, renal toxicity, skin toxicity. Sometimes they may develop like a toxic epidermal necrolysis. So much of toxicity can occur. That is why the dose adjustment is needed. Then now, as pediatricians, we may see these patients during the maintenance therapy. Maintenance therapy is usually a low dose maintenance therapy with the 6-mercaptopurine and methotrexate. So at that time, at a cancer center, from the cancer center, we allow the children to go home to their nearby places and then attend the local pediatrician for any problems. So at that time, they may come with problems. So we need to have a careful surveillance. When this child comes to you, if it is a Down syndrome child, you please tell them to attend you in case of any problem, because careful surveillance is required throughout the maintenance period. In a normal child, throughout the maintenance period, that time the disease is in remission, and then immunosuppression is just minimal. So we don't expect much of a infective complication. But in case of Down syndrome child, it is expected. So intense monitoring and supervision is needed. So if the child is coming to you with neutropenia, then we are giving the neutropenic care, and then neutropenia is prolonging. So that should alert you that this is a Down syndrome child. Prolonged neutropenia, complication can occur. Likewise, high induction of suspicion for infection. So see, child may come with just a fever, no other problems. But if it is a Down syndrome child, we should early initiate the antibiotic treatment and supportive care. Then suspected infections, even in the absence of neutropenia or fever, because they are immunocompromised, they may not have any fever also. So all these we should be alert to. Some of the groups are recommending the influenza immunization of the family members, because to reduce the exposure to respiratory infections to these children. We are not practicing that in RCC. And also the intravenous immunoglobulin therapies, because hypogammaglobulinemia is very much prevalent in Down syndrome per se. And due to the chemotherapy, many children are going into the hypogammaglobulinemia. To reduce the life-threatening infections, it is recommended to measure the IgG monthly and treat with the IVIG if the levels drop below 4 gram. Currently, we are not practicing this also. It is just a recommendation from the treating groups. So that is all about the ALL and AML, what the basic things as pediatricians we should know. Then this is about some novel therapies. We should be just aware of that certain these therapies are there. There are antigen-directed immune therapies like blinatumomab, or engineered autologous T cells. Why they are important in MLDS is that the risk of toxicity is less. They don't produce much of systemic toxicity. It is the directed therapy, so that only the blast cells will be affected. So people are interested in these type of therapies. And like my previous speaker mentioned, JAK and mTOR inhibitors, they are all being tried for, Down syndrome ALL also to improve the survival. Ruxolitinib. Another way is liposomal formulation of the standard agents like the daunorubicin, vincristine and all to improve the therapeutic index, so that low dose may be needed to maintain the cytolytic activity. Lower dose is needed. Lower therapeutic index is improved, so that will lead to improved outcome and a reduction in toxicities. So all said and done, as pediatricians, seeing a Down syndrome child, clinical suspicion of TMD, clinical examination for hepatomegaly and effusions and pallor, all that. Close monitoring of full blood counts and LFT, and close follow-up remains the gold standard for us. Any abnormality in between, any persisting abnormality, even though the disease is known to resolve by itself, we should be alert. Any symptoms in between or any problem in between, child should be referred to the oncology center. So I think that is all.
So thank you, Manjusha and Dr. Binida for the wonderful presentation. Please stop screen sharing.
Yeah. 1 second, sir.
So both topics are extremely covered by both speakers, Binida and Manjusha Nair. My one question to Dr. Binida, as I already put forward, because the major problem for treating leukemia in our center is the newer investigation part, which will predict the prognosis of the leukemia. So how can we tackle, how can we treat leukemia in our center, at least ALL? Previously used to treat all ALL, nowadays we are not doing it. Or how can you, more and more centers, we can adapt to treat ALL?
So the initial workup part, if flow cytometry evaluation can be done, then the treatment shouldn't be that much of a problem. Evaluation, we basically need the flow cytometry, a karyotyping, and maybe a translocation 922, because we have a directed therapy for 922. So at least if you are able to send a sample for 922 elsewhere, get a report and start treatment, that would be okay. Otherwise, giving treatment for a standard risk ALL treatment wouldn't be much of a problem. Not much of toxicities would happen. There's nothing more than a pediatrician can do. It's just basically giving the medications on time, tackling early identification of infections, giving antibiotics promptly for infections, giving transfusion support. That is all is required. But if it comes to high risk ALL, there is a requirement for giving high dose methotrexate. So as I mentioned in my talk, high dose methotrexate has to be given at a dose of around 5 grams per meter squared. So when we are giving, and that is very important for the CNS, for reducing the risk of relapses and for reducing the CNS involvement in ALL. So when we come to the part of giving high dose methotrexate, it becomes a bit difficult because you need to give hydration for nearly 40 to 72 hours. You need to give leucorin rescue promptly on time, and you really need methods to estimate the serum methotrexate level. If you're going above doses above 2 grams per meter squared, it's very important that we measure the serum methotrexate level at every 24-hour intervals and continue the leucorin rescue and hydration until the serum MTX is less than 0.2. So that part would be difficult for a peripheral center, but if that can also be done, otherwise administration of the chemotherapy is okay. Supporting as I said, Jitin will be talking later about febrile neutropenia. It's essentially febrile neutropenia management, transfusion support. Only these two parts would be difficult to start in a medical college center, sir. Otherwise, it should be done.
Is there any question to Dr. Binida from the chat box? Because I cannot see it. Any question to Dr. Binida?
Not much, sir. Not much. Can I add on to that? Yeah, I think cancer children treatment requires a multidisciplinary team actually. So that team does not only involves the doctors, but the specialized nurses, the other supporting care staff like social worker, dietitian, many others are also involved in that treatment part. So I think the cancer centers only will be able to provide that kind of multidisciplinary treatment. I think especially for the pediatric cancers. So that's why already under the government, the 3 cancer centers are already there, and I think pediatric cancers can be treated there. Adult cancer needs decentralization, but pediatric cancers, that still there is a need for decentralized support from the peripheral practicing pediatricians, because most of the although the chemotherapy part and majority of the supportive care can be given from the cancer center, but still when they go back to the home, they need the supportive care, which for which we need the support from the pediatricians.
Any other question from the floor to Dr. Binida? Dr. Sudharan is there, our senior. So what is difference in the treatment from long term? Because from previously we used to treat medical also. So what is difference? Sudharan sir, what is your opinion? Sudharan sir, retired HOD of pediatrics. Unmute, unmute. Unmute.
Sir, microphone ഒരു ബട്ടൺ ഉണ്ട്.
Okay.
Yeah.
These are all recent advances. when I was HOD in pediatrics, all these things were not there.
Yeah.
After that, I was posted, appointed as a principal, and my touch with all these things are now very, very, very meager. So it is very interesting and informative to hear you speakers, and I feel that it will be beneficial to us. I am not in a position to make comments on these recent advances. Very sorry. That's all. Okay.
So Dr. Manjushan, two questions from my side. So can you a little bit elaborate this cytarabine therapy for the GATA1, this transient myeloproliferative disorder, and also why this transient myeloproliferative disorder more common in Down syndrome? Second thing is that how common is leukemia after age of 10 years? Because now there's increased survival of Down syndrome, definitely. So after 10 years or 5 years, whatever it is, after age for after 10 years, what is chance for the fresh leukemia chance to occur? Two questions.
Thank you for that question, sir. It's a very relevant question. In the older age group, in the children with age group less than 4 years, only in that age group, this megakaryocytic leukemia, the incidence is increased. Children more than the 4 years, maybe 6 years or maybe 10 years, the chance of leukemia is as for the general population. There is actually no increase equal to the general population. And regarding the cytarabine therapy,
because general population we are not routinely following for leukemia, but here we need to regular follow up for leukemia, something like that. That is why my question.
Yes, sir. That follow up is recommended till 4 years of age. Regular follow up and monitoring is recommended till 4 years of age. After that, it is just like the other general population only. And regarding the cytarabine, TMD cytarabine therapy, actually they are very sensitive to even low doses. So actually one cycle of this 5 or 7 days of cytarabine is enough for them, because the blasts are exquisitely sensitive to the cytarabine. So this either you can have this 1.5 milligram per kg per dose or 3.3 milligram per kg per dose. Both doses have been tried by both two groups.
No,
but
we have to routinely give it or not?
No, not routinely, sir. At present, there is no evidence that in a child with TMD who doesn't have any life-threatening symptoms, just on follow-up, by giving cytarabine, we can prevent anything or leukemia. There is no evidence like that. But studies are going on. We need to wait for more results. Till 2018, this TMD study has come. They told that they have proved that there is actually, you cannot prevent leukemia by giving the cytarabine therapy. The aim of cytarabine therapy is to prevent, reduce the symptoms and prevent the early death, which is the most 15 to 20% the mortality is due to the early death. So to prevent that, we are giving the cytarabine therapy. But the transformation to leukemia is not altered by giving the cytarabine therapy. That is how much evidence we have now. It may change in the future. We don't know, because studies are still going on.
Same question is asked by Dr. Yadisham from Kasaragod also. How about TMD is very common in Down syndrome? Not seen in other regular population, something like that?
Yes, that is, sir, because of the particular trisomy 21. One is, first hit is the trisomy 21 itself, and the second hit is this, the GATA1 mutation. So,
if I may.
Yeah.
Yeah, if I may add to that, it's particularly common in Down syndrome because it has got a lot to do with the folate metabolism, as Madam rightly put it. Because of the trisomy 21, the extra dosage is of the 21 is associated with the cystathionin genes there, which is mainly involved in homocysteine folate metabolism, and that predisposes these patients to more mutations, the secondary mutations. So they are more prone to get other hits. And that GATA1 hit is more so in trisomy 21, and hence the TMDs are more. It's the abnormal folate and the cystathionin, that dosage which is due to the trisomy 21, which is caused for the more mutations and the TMDs in Down syndrome.
And if I may add, now recently they have found that even the endothelial, endothelial cells, they actually they have these changes which predict the, which children are going to develop the complication of TMD or the AMKL. So those are latest research coming on. Research is going on in the molecular levels, like which are the factors which are predisposing these children to develop. Interestingly, solid tumors are not that much common. Like only leukemia, hematological tumors are common. So research is going on. Like these mutations, they cause sort of upregulation and downregulation of the cancer-producing genes. So some are upregulated, some are downregulated. All this complex interplay, because of that only, certain cancers the incidence is increased and certain cancers the incidence is decreased. So solid tumors, there is not much increased incidence, but leukemia incidence is increased. It's all because of the upregulation and downregulation of the cancer genes. That is how much evidence we have now. Actually, people are doing more research on that to find out new, because as sir told rightly, now survivals are for survival for Down syndrome is increased. So people would like to prevent or limit the leukemia to any extent. So that's why more research is going on. Thank you.
Yeah, if there's no more further questions, we'll wind up the session because we are running short of time. I would like to thank both speakers, Dr. Manjusha Nair and Dr. Minida, for the excellent presentation, also for their taking care of our questions.
Thank you, sir. Thank you so much. Thank you, sir.
I also would like to thank the organizing committee for giving this opportunity to chair the session. Thank you. Thank you. Over to Dr. Palkanav. Dr. Jidhi.
Thank you, sir. Padmanabhan, sir. Okay. Then we can move to the next session. I invite Dr. Mohandas Nair. He is additional professor, Calicut Medical College. He was my guide and my mentor. I invite Dr. Mohandas, sir, for next session as a moderator.
Thank you, Jidin. Can you hear me?
Yes, sir. Yes, sir.
Okay. So thank you for giving me opportunity to chair the session. I want to thank both the Kanhangad IAP and Hemato-Oncology chapter of IAP. And we have already heard about leukemias, the commonest malignancy in children. And neuroblastoma is the commonest solid tumor after outside the brain, extracranial malignancy. And leukemia, we have a high index of suspicion in our clinical practice, whereas neuroblastoma, unfortunately, the index of suspicion is low, and it has got a wide range of clinical manifestations. So the topic itself is regarding how this neuroblastoma can masquerade with the different situations. And the speaker is none other than Dr. Badira. Badira is a visiting professor in Tata Memorial Institute. And I remember she has done her post-graduation in pediatrics in Trichur Medical College. And we used to hear about a brilliant and vibrant postgraduate in Trichur Medical College. So that we used to think just like Vadakan Viragathile Mammootty പറയുന്ന പോലെ നമുക്ക് ലഭിക്കാതെ പോയ ഒരു പോസ്റ്റ് ഗ്രാജുവേറ്റ് എന്ന് കാലിക്കറ്റ് നമ്മൾ ഇങ്ങനെ പറയുമായിരുന്നു. So welcome Dr. Badira for the talk.
Thank you so much.
Dr. Mohandas, Badira is our first batch student from MD student from Badira. We are very proud about Badira, and she got so many awards international level. I think she is one person not recognized by IEP and Kerala people. I think we will invite Badira for more and more seminars in future. Badira, happy to see you after a long time.
Same here, sir. Thank you so much for the inspiring words and for the kind words, sir. And if I can say, I was fortunate enough as an MBBS student to attend some of your lectures to Dr. Mohandas, because I think you were transferred at that time, but I did hear when you came back a few of the lectures that you had given when I did my MBBS course at Calicut Medical College. And I'm happy to see my teachers at Trishur Medical College. I can see Dr. Anandakeshavan sir, Dr. Parvati madam, Dr. Nisha, and my colleagues too from Trishur Medical College. And at the outset, I would like to thank the organizers for giving me this wonderful opportunity. It's indeed a great pleasure here. And I would also like to wish all the audience a very happy Kerala Piravi. I think I'll share the screen. Is it visible, Jitin? Is my screen visible?
Yes, ma'am.
Yeah, okay. Yeah, so my topic for today is aptly titled The Masquerade by Neuroblastoma. And as said by Dr. Mohandas Nair, this is actually an enigmatic disease in itself with varied presentations. And as a pediatrician also, many of you would come across some of the presentations of neuroblastoma in clinical practice. It is the perfect disguise for a lot of benign and malignant diseases. So as you know, neuroblastoma, as Sir has already said, it's the most common extracranial solid tumor in childhood, and it's the most common malignancy in infancy. And 90% of these are actually seen before 5 years of age. So hence, it's common for the pediatricians to encounter this tumor. It is an embryonal neoplasm, as the name denotes. It's blastoma. It originates from the neural crest cells, and hence the most common location are the adrenal medulla and the sympathetic ganglia extending from the neck to pelvis. So as you can see, the most common site is again the abdomen. It's mostly majority seen in adrenal medulla, the rest in the retroperitoneal sympathetic ganglia. And if you look at the age-wise distribution of the sites of disease, usually in the infants, adrenal gland, as already pointed out, it's the most common, but you get to see more of mediastinal primary neuroblastomas and connective tissue subcutaneous skin involvement in infants. Now, the thing with neuroblastoma and what makes it most interesting is it is a clinically and biologically heterogeneous disease, and at times it is remarked to have a schizophrenic personality. So at least two distinct clinico-biological entities can be recognized in neuroblastoma, as it is demonstrated here. You have the benign neuroblastomas, which usually are the low and the very low-risk neuroblastomas, which are the happy children with abdominal mass. And then you have the aggressive neuroblastomas, which are the high-risk neuroblastomas. Most of these aggressive neuroblastomas have the segmental chromosomal aberrations, which include the NMIC amplification, which all of you might be familiar. You might have heard in the context of neuroblastoma, NMIC amplifications. There are segmental chromosomal anomalies like 1p gains, 11q loss, some of which are important biological factors determining the prognosis and treatment of these neuroblastomas. And benign usually have whole chromosomal gains. So it's not like 1p, a short arm or a long arm loss or gain, but a whole chromosome might be lost or gained in a benign. This difference in the biological clinical heterogeneity is also reflected in the survival of these children. As you can see, the low risk and intermediate risk have a survival which is above 80%, and the high risk is usually, at an average around the world, it is around 35 to 40% max. So at any time point, it is never an understatement to say that if you look at the Western world, there are more researchers trying to research on a better cure for high-risk neuroblastoma than there are actually neuroblastoma patients. So you can see this is very important because the therapy also differs in low risk and intermediate risk. These are the patients which you can either observe, can do surgery alone, can do chemotherapy, or can do surgery plus chemotherapy with a prognosis, with a survival more than 80%. But the high risk patients require a very intensive treatment approach. They require intensive chemotherapy, then surgery, then they require stem cell transplantation. Post that, they require radiotherapy and an immunotherapy, which is a very intensive course. And even with this, the average survival is around 35%, but with advances, clinically tightly controlled clinical trials have improved the survival rates to 60% too. But on an average, it's still, in a country like India, it's less than 30%. This is very important because, as you can see, the 42% of the patients are still high risk, which are poor prognosis and survival rates of only 20 to 30%. The rest, around 58%, from the low and intermediate risk patients, which are our best patients. We are happy to treat them because we can see a cure. Now, the spectrum of neuroblastoma, as you might have also heard, some patients have a neuroblastoma, but without giving any therapy. So we have had patients, then we said we have to investigate. They went to alternative medicine. Then after 1 year, they come back and say, oh, I don't have the tumor anymore. So these come to that part of that neuroblastomas which undergo spontaneous regression. These are the favorable biology, which I've said, benign neuroblastoma. Some of these undergo spontaneous regression, especially those seen in the infants. Many of them mature into ganglioneuroma on treatment and has no other complications. A portion of them, especially the high risk, the 40% high risk neuroblastoma, many of them have relentless progression and many of them relapse even after intensive treatment. Now, just before we go on to the main discussion, I would like you to have an overview of the staging and risk stratification in neuroblastoma. So staging is mainly based upon imaging and the metastatic workup that we do. So based on that, we have L1, L2, M and MS. L1 and L2 is for the local staging. So this is just based on what are called the image-defined risk factors. On imaging, neuroblastoma is a disease which can encase the vessels, neurovascular bundle, the vital organs that are near the site of origin of the tumor. So the image-defined risk factors at baseline imaging tell us whether the tumor is upfront resectable or not. You don't want to create morbidity in a low-risk neuroblastoma by operating a tumor which is encasing a vessel or a nerve. So L1 is a localized tumor without any risk factors, and these are the tumors which are upfront resectable without any morbidity. L2 are the tumors which have one or more image-defined risk factors which make them a bit unoperable at the upfront, but if with chemotherapy they might shrink and you can do a surgery later. M stands for metastasis, as all of you can easily confer from the abbreviation. MS is what we usually earlier used to call 4S. It's a special neuroblastoma stage. It is seen in children less than 18 months of age. And it is usually characterized by metastasis confined to skin, liver, and bone marrow with involvement only less than 10% on the smear or biopsy. Now, evaluation on a whole, as all of us know, clinical examination, you do a local examination. And one thing which is important, especially in an abdominal neuroblastoma, is monitoring the BP, because many of them can have a renal cause of hypertension and also because of the secretion of the adrenaline metabolites. And this can actually present as malignant hypertension with hypertensive encephalopathy and an emergency. And so monitoring the BP at different time points of your conduct is important in a case of neuroblastoma. For the diagnosis, it is usually by biopsy of the mass, or in cases which are metastatic to the bone marrow, if you have a round blue cell tumor in a bone marrow together with an elevated urinary VMA, a diagnosis would suffice without a biopsy of the mass. Otherwise, we need the biopsy not only for establishing a diagnosis, but also for the biology, which I'll come to in a few seconds. Local imaging is by CECT or MRI, which is gives a better delineation of the tumor, and you can identify the image-defined risk factors and decide upon the operability. Metastasis, the workup depends upon the sites of metastasis that you encounter in neuroblastoma. The usual sites are the bone marrow and the bone. So the ideal imaging, that is the gold standard, is the MIBG imaging, which is based on the concept that the neuroblastoma cells have the noradrenaline receptor, and therefore radio-labeled benzalguanine, it will be taken up into the neuroblastoma cells and concentrated, and we can see it by the imaging. So if you don't have an MIBG, you should at least get a PET-CT at bone scan with a bilateral bone marrow aspiration and biopsy. And lastly, which is more important in risk stratification, we have to know the biology. Biology is both the histology and the chromosomal abnormalities, which are the molecular abnormalities, as I've pointed out. Histology, you have the Shimada's classification. Then NMIC, we need to do by FISH, or you can do an MLPA, which is a multiplex ligation probe amplification, which can detect many chromosomal aberrations in one go. So we look at 1P, 11Q, a lot of chromosomal aberrations which are defined in neuroblastoma by this test. So the risk stratification on a whole is based upon age. You have to remember one thing: age is either you can classify it as an infantile or a non-infantile based on a cutoff of not 1 year now. It is 18 months. Less than 18 months at symptom onset is infantile. More than 18 months is non-infantile. Then you look at the staging based upon your metastatic workup. Biology, as I've already said, in places where you cannot do NMIC FISH, you can do serum LDH and ferritin. And if both of these are elevated, it is a surrogate marker of NMIC amplification and hence a high risk tumor. Now there is a risk stratification there. It's from A to R, you have risk categories. Basically, there are three risk categories, or maybe two, we can say. The low and intermediate is one, and high risk is the other one with respect to the treatment implications. So all that you have to know is what is high risk. So metastatic disease, which is more than 18 months, that is in a non-infantile neuroblastoma, it is high risk. NMIC amplified in any stage is high risk. Levenque loss in a stage MS is high risk. So these are the three high risk categories which require treatment intensification. The rest are low to intermediate risk with a good prognosis. So I will take you through various clinical scenarios which would help you to understand the different manifestations, and many of you would also, as a pediatricians, would come across these clinical manifestations. I put this at my first case because this is what comes to our mind when we hear of neuroblastoma, the typical, the raccoon eyes. So this was a 3.5-year-old girl with a fever and this raccoon eyes for 3 weeks. She had a left eye proptosis. You can also see, it's very rare though in neuroblastoma, right LMN facial palsy. So her BP was normal, no other mass palpable, but no definite mass palpable. She had a right LMN, a urinary VMA was elevated. So this raccoon eyes is actually due to a bone metastasis in the orbital bones. This periorbital metastasis and the ecchymosis gives to this classical raccoon eyes. And I don't think we get this bilateral raccoon eyes in any other tumor other than neuroblastoma. For this child, we did a PET CT, and you can see you have a concentrating tumor. This is the site of right adrenal tumor, and there are multiple concentrating lesions in the lymph nodes, bone marrow, and all the bone marrow. You can see the focal lesions. So this is a case of non-infantile 3.5-year-old girl, an abdominal primary, a suprarenal. It's a stage M because of metastasis, and she had an unfavorable histology and NMIC amplified all the setting for a high-risk disease. She was started on intensive chemotherapy and is undergoing that right now. So the next case is a 1.5-year-old boy, fever and loose stools. Well, it's a case of gastroenteritis, and as any pediatrician, I mean, we would prescribe ORS and zinc, but an enthusiastic pediatrician just palpated the abdomen also and found out a vague mass. He did a USG abdomen. It found a suprarenal mass. For better delineation, a CT was done. So here you can see left-sided adrenal tumor with the characteristic classifications, the stipple classifications that you can see in neuroblastoma. This actually classification is seen more so in a favorable histology where there is maturation, matured cells or a differentiating cells more, less likely in an NMIC amplified tumor. So this, with the scenario here, is more likely to be a favorable histology, a favorable neuroblastoma. And this was a non-infantile suprarenal because the cutoff was a bit higher than 1.5 years. Neuroblastoma, it's an L1 disease because it's easily operable. There were no image defined risk factors. NMIC non-amplified was a low risk child because we can do just surgery in this child, and this child was just operated and no further treatment was given because everything else was low risk. Another 1.5-year-old boy with paraparesis for 4 weeks. Features were suggestive of compressive myelopathy, and at the thoracic level, outside he had a chest X-ray done, which showed a posterior mediastinal mass. So when he came to our facility, there was a CT thorax also done, which showed a posterior mediastinal mass here. You can see in the right paraspinal area, there is a mass. So with some infraspinal extension, which cannot be delineated on a CT, it's better to do an MRI. And here you can see the mass extending into the foramen, into the infraspinal spinal canal, and it is compressing the cord here. So we did so this is actually an emergency. But if you look here, the child had been paraparetic for 4 weeks. The neurological recovery prognosis is less when you have more than 4 weeks, but still, because in children, regardless of the duration, because of the plasticity of the nervous system, we should treat them as an emergency because we have seen many children walking after even a long duration of paraparesis. We started treatment immediately. We saw a bit of calcification there. Urine VMA was on the higher side. We planned for a biopsy, started on steroids, dexamethasone, and then we started him on chemotherapy. So carboplatin etoposide chemotherapy would have magical effects on neuroblastoma and the paraparesis. So after giving chemotherapy, you can actually wait for a few days. See, you don't have to go for upfront surgery as such. So if it is not improving, you can do a laminectomy, but the surgery has its own complication. And since it's a chemosensitive tumor, you can go ahead with chemotherapy and reassess and then decide upon surgery. This is an infantile thoracic neuroblastoma, infraspinal extension, cord compression. L2 disease because of the spinal cord compression. It's not upfront operable. So it's a endemic non-amplified low risk neuroblastoma. It improved actually with chemotherapy. So this is another newborn child who had skin lesions. So full-term delivery, good birth weight, no history of any fever with rash in the mother, no joint pains in the antenatal period. So these are the classical bloomery muffin lesions which you can see in IU infections and congenital leukemia. And of course, neuroblastoma is something that comes to our mind when we see these bloomery muffin lesions. And this child had a USG done at an outside peripheral area and it showed an adrenal mass. We did a CT abdomen and that showed a mass here. It's a very well-defined mass with some calcification. So this basically comes to a MS diagnosis, infantile suprarenal neuroblastoma. Stage MS because less than 18 months with dissemination to the skin. There was no dissemination to bone marrow and the rest of the biology was normal. So this is a very low risk child. And if not symptomatic for anything, you can just observe the child also. There is no need for anything unless the child has other symptoms, like in the case that we will subsequently come. So this is another 3-week-old baby with gross abdominal distension. There was no jaundice. Urine stools were all normal, but the child had severe respiratory distress. On examination, there was massive hepatomegaly. USG was done, which showed a liver, which is grossly enlarged with focal lesions. We did a CT abdomen also. The CT abdomen, you can see the multiple focal lesions, grossly enlarged liver, and you can see here a suprarenal lesion. This is the primary adrenal tumor here. So this is again an MS stage, an infantile MS as we have seen previously, but with a met to the liver, and there was no other metastasis anywhere else. But in this child, a 3-week-old baby with severe respiratory distress and massive hepatomegaly requires some treatment. And the commonest treatment that we administer in this child is chemotherapy. You can give, this is known as a life-threatening symptom in an MS child. Any life-threatening symptom in an MS child requires therapy in the form of chemotherapy. You can give carboplatin etoposide, which is they respond, or you can give single-agent cyclophosphamide. Earlier used to treat with small dose 4.5 gray RT, but that is not in vogue now because they are chemosensitive. We give 1 cycle of chemo or 2 cycles till the patient is asymptomatic, and that's the end of treatment. So again, this is this. So this is another patient. She's a 2.5-year-old girl. She came with fever, constitutional symptom, very malnourished child, abdominal distension for 3 weeks. There was a palpable mass in the right hypochondrium and lumbar region. So at this point, if you look at this child only, if you're thinking from terms of a tumor, the most common tumor, abdominal tumor in this age group is Wilms tumor, and then it is a neuroblastoma. But Wilms tumor usually will be a happy child who just runs into your OPD laughing and very playful, and neuroblastoma and the very low and the intermediate risk also will be like that. But high-risk children they have a profile like this, very malnourished, very sick-looking, constitutional symptoms, and with an abdominal mass. This child, as you can see, had a very large tumor, which is crossing the midline, and this also was encasing the vessels. This is locally an L2 tumor. And you can see there are no much calcifications in this. And this actually corresponds to an unfavorable histology. And it was rightly so in this child. The NMIC was amplified, even though there was no metastasis. So this is a non-infantile suprarenal neuroblastoma with an unfavorable histology and biology, even though there were no metastasis. So she was treated as a high-risk patient with including transplantation. Now this is a 3-year-old boy with a small swelling in the left lower neck. So it was just above the clavicle. So X-ray was done outside. USG also was done. And incidentally, they picked out a left upper zone opacity. For better delineation, CT thorax was done. Again, you can see this solid heterogeneous lesions in the posterior mediastinum, mainly occupying the left hemithorax. Again, there are not much calcification in this. Talking of its biology. So this was also an endemic amplified bad biology tumor, thoracocervical. It was the cervical extension that was manifesting as a small swelling. This child again was treated as a high risk with chemo, surgery, transplant, radiation, and immunotherapy. So this is a 5-month-old baby with fever, cough, and cold, had noisy breathing. The child was snoring a lot. There was no tachypnea. Then the child was thriving well, but the mother was very concerned and anxious. The pediatrician took an X-ray. There was a right upper lobe opacity, mediastinal-like lesion, which is extending into the right hemithorax. Well, this turned out to be it's a physiological thymus, as you can see. So there are every posterior mediastinal mass is not pathological. It is physiological too, especially in the age group. And you will have signs in the radiology like the golden wave sign or the notch sign to guide you in that. So a well, happy, thriving child with just a URI in an age group that fits into a physiological thymus, it's no risk at all to any one of us, and we are happy to leave the child back home. This is a 2.5-year-old boy, again with a lower abdominal pain, had difficulty in passing stools, a bit of constipated, and there was a hypogastric vague mass, better delineation. We did an imaging. You can see here there is a huge mass in the pelvic lower abdominal region, which is actually splaying the vessels and encasing it, but no much calcifications here. We did a scan staging. This was a neuroblastoma, a pelvic neuroblastoma, no metastasis. In this, the histology was unfavorable, but fortunately for the child, the biologic NMIC was not amplified. So we treated as intermediate risk. We gave chemotherapy first, reassessed, and then did surgery. One thing to note about neuroblastomas, in low and intermediate risk, you don't have to take out the tumor fully. You just have to debulk the tumor to remove 50% of the tumor. Unlike the high-risk neuroblastoma, where gross total resection, more than 95% of the tumor has to be removed. So we don't need any heroic surgeries in this child, just debulk more than 50% of the tumor if it is non-high risk, and the child will be fine together with chemotherapy in this child. So this is another child. Again, she had difficulty in passing urine and constipation. Otherwise, child, there was no mass palpable. We did a UST. There was some abdominal pelvic mass, but a CT was done, and it showed a presacral mass here, which was compressing the bladder. A metastatic workup was done. There were no mets. We did a biopsy. It confirmed a neuroblastoma, and this was also a good biology, a low risk. We gave chemotherapy because it couldn't be operated. The child was given chemotherapy 2 cycles. We reassessed and took the child for surgery, just 50%, more than 50%, as much you can debulk without any complication or destroying the vital structures around. This is another 1-year-old boy. So this boy had a right-sided neck swelling. It's not very visible here. So there was a neck swelling for 5 months, a change in voice. The mother was complaining of hoarseness. There was noisy breathing, no stridor at rest. And the right eye, if you carefully see, you can see this is partially ptotic. And so there was a Horner syndrome, and with a cervical location, we diagnosed a cervical mass lesion with origin from the Horner stellate ganglion, or compressing the Horner's plexus there and causing Horner syndrome. So we imaged the child, and you can see here a cervical lesion with calcification. So one of the DDs that come to your mind is, and the first that comes is neuroblastoma if with calcifications. Other DDs, that there are a lot of other tumors which can present here, but with calcification, the cervical neuroblastoma is the first DD. The child but had on staging, had a bone metastasis. It was a stage M disease, but since the child was 1 year old, that is infantile, less than 18 months, even a metastatic disease in an infant is a intermediate risk, not a high risk if the biology is good. Because the biology is good, even a metastatic disease was intermediate risk. This child was started on chemotherapy and is undergoing the same now. Now, this is another 2-year-old boy. You can see there is bilateral proptosis. There are multiple swellings here. You can see a swelling here, a swelling here. He had swellings here. His hair is lifted up there. So multiple bone and swellings and fever on and off for 1 month. In this age group with bilateral proptosis, bone swelling, Langerhans histiocytosis is something that comes to our mind. So this bone lesion, this child was imaged for the same, and we found out a left adrenal lesion also, together with the multiple bone mets involving the mandible frontal bone, and his bone marrow and aspiration was also involved with the tumor. So we have here a non-infantile neuroblastoma with so much of metastasis, a stage M, and he had an unfavorable histology and was taken in for intensive therapy. Now, this is another child, a 1.5-year-old girl, very cute child, symptomatic since 2 months, and this is a symptom that she had. she's otherwise well, developmentally normal. This was the only symptom. See, you can see the roving eye movements there, and you can see those imbalance while she's being held in the arms of the mother. So this is the typical opsoclonus, and you had seen a myoclonic jerk also, and there is ataxia in this infantile child, and there was no other cause for no other neurological symptoms. So this is a case of opsoclonus myoclonus ataxia syndrome. So the most common cause in an infant, 50% of this OMAS is associated with neuroblastomas. But if you take neuroblastoma as a whole, only 2% of them are associated with OMAS. So this child was screened, and we could find a favorable left adrenal neuroblastoma with calcification. Usually OMAS is associated with favorable histology neuroblastoma. So this was an infantile neuroblastoma. Here we could just remove the tumor, but because she has OMAS has short-term and long-term neurological deficits in picture, and because to prevent the relapse and the long-term neurocognitive abnormalities, all these children should be treated with immunosuppression, whether in the form of IVIG, steroid, rituximab, or ACTH therapy. Irrespective of whether you have removed the tumor and given chemotherapy, all these patients require immunotherapy for 6 to 12 months of duration. So this was another year. This was an interesting case. And again, a 2-year-old boy who came with respiratory distress, abdominal distension, had gross pleural effusion, right to mild to moderate effusion on the other side. We did a pigtailing, and what drained was not normal fluid, but he was chyle. So he had a chylothorax, an X-ray, the urine VMA, we had done upper limit of normal, because there was some USG done because he had that abdominal pain because of the pleuritic involvement at that initial point of time. The urine USG had picked up a mass, the retroperitoneal mass was there, and it was actually a gross mass compressing the cisterna chyli and the thoracic duct, and that was a cause for the chylothorax. So otherwise it was a favorable biology. So was symptomatically treated the child for chylothorax, given him chemotherapy, and it all improved, and he's well now. So this is another entity, perinatal neuroblastoma. When you identify a suprarenal mass in the antenatal or the immediate neonatal period, many groups have different policies, but usually the wide recommendation right now is you can observe if the size is less than 3.1 centimeter. If you have a solid mass less than 3, you can observe, but require rigorous follow-up. Usually there will be spontaneous regression. Some might require a treatment, observation with imaging, and urine VMA. So as you can see, these are the different manifestation, and also you can see you have manifestation related to the mass per se causing compression of the adjacent structures, or you have manifestations of the metastasis to the bone pain, or the bone marrow or the liver, or you have manifestations which are due to the paraneoplastic syndromes associated, the most common one being OMAS. And also you have some tumors which secrete VIP and present with secretory intractable diarrhea. These children are not like the normal gastroenteritis, severe intractable diarrhea, dyselectrolyte, they have severe hypokalemia, all dyselectrolytemia, they have dehydration, hypoglycemia, shock. So elevated VIP levels will clinch the diagnosis and will require search for the tumor and removal of the tumor and therapy for same. So as you can see, any system can be involved. It mimics benign to malignant diseases, protein manifestations. So it's a perfect disguise and the masquerade by neuroblastoma. I'd like to acknowledge my DMG, pediatric solid DMG, and also would like to acknowledge Dr. Sajid Qureshi, pediatric surgeon, Dr. Subramaniam, Dr. Maya Prasad, who have also contributed the videos and photos for this presentation, and all my patients. And thank you to all my teachers who are right now attending the webinar too. Thank you.
Thank you, Badra. It was a wonderful presentation. We have covered almost all the clinical manifestations of neuroblastoma. And I think discussion will be keeping to the last end of the session. So now we have Dr. Jitin. Badira നമുക്ക് കിട്ടാതെ പോയ പോസ്റ്റ് ഗ്രാജുവേറ്റ് ആണെങ്കിൽ ജിതിൻ did his post graduation with us. What I should say, as Jitin has mentioned, he has done his thesis under me, and it was a very difficult thesis which need a combined effort from neonatology side gynecology side, pathology side, and all. So sincerity and hard working. ഇതിന് ഒരു രൂപം കൊടുക്കുകയാണെങ്കിൽ ഐ വിൽ തിങ്ക് നമ്മുടെ ജിതിൻ്റെ രൂപമായിരിക്കും തോന്നുന്നു. സോ വെൽക്കം ജിതിൻ ഫോർ ദ ടോക്ക് ഫോർ ഓൺ ദ ടോപ്പിക് on febrile neutropenia. As there was a doubt whether all the centers can manage cancer, and Jidin was saying it is a teamwork, a lot of support is needed. Just administering a chemotherapeutic agent may be easy, but managing the complications and supportive treatment and all is not at all easy. So welcome Jidin for the talk on febrile neutropenia.
Thank you for those nice words, sir. So first of all, let me thank IAP Kanhangad for giving me this opportunity. So we'll be dealing with the febrile neutropenia management. So greetings from Malabar Cancer Center where I work. So the aim of this presentation is to how we can work up and risk stratify these children before starting treatment, and when what to start upfront, when to refer the child if you think that the child requires for the management, and principles of all this management, and how to prevent these mishaps. So the impact of febrile neutropenia is big because it is one of the commonest oncological emergencies, and usually peripheral practitioners panic when they see that okay, the count is very low and the child has fever. So what to do next, and all those things, panic can happen, and it produces a lot of unplanned admissions. Apart from the chemotherapy, regular chemotherapy admissions that we plan for during the treatment, this produces a lot of unplanned admissions, and it can produce mortality and morbidity. And after the disease, what we worry most is about the infections, complications, infectious complications that can happen during the treatment. And of course, it increases the treatment expense. So although the government covers most of the treatment in major centers here, but especially in private setup, when the infections happen, the treatment expense jumps to lakhs. So first of all, we have to clear when to call FN. So for the fever and neutropenia has been defined as fever, single oral temperature of more than 30.3 degrees Celsius, or what we usually follow is Fahrenheit, so 101 degree Fahrenheit. But we have to think that most of the time we usually don't take oral temperatures, and we should take auxiliary temperature. So the temperature is it's like 1 degree Fahrenheit lesser than what we define. So 101 becomes 100 degree Fahrenheit for auxiliary temperature. And if it is more than 99.4 to 100, which is sustained for 1 hour, we'll be taking it again as fever. Neutropenia is defined as ANC of absolute neutrophil count of less than 500, and if it is less than 1,000, and expected to decrease to less than 500 or the subsequent 48 hours. So usually after intensive chemotherapy, we will have come across such situations like ANC is less than 1,000, and the count will be falling to less than 500 within the subsequent 48 hours. So these are the scenarios when we call it is febrile neutropenia. So this is a situation where you have to make certain decisions, what to treat and what to give. So Sorry. There are many contributing factors apart from the disease and the treatment. So we will go to two cases mainly. One, a 3-year-old boy with acute lymphoblastic leukemia on maintenance chemotherapy, presenting with fever and no focus and vitals are stable. And another situation where a 10-year-old boy with a ring sarcoma on chemotherapy recently received IA chemotherapy and presenting with fever, mucositis, and tachycardia. So these are the two situations where peripheral pediatricians come across these kind of children, where in leukemia maintenance they will be staying at home and only, and during solid tumor treatment they will be going to home in between chemo treatment. So the workup algorithm is like we have to think about patient-related features, disease-related features, and episode-related features, and do the specific investigations, and stratify the patients to low risk or high risk, depending on those features, and decide whether what kind of treatment the child requires. Whether the low risk child can be treated with OP care, oral antibiotics. High risk, the child will require IP care, and depending on the situation, child will require antibiotics and other supportive care. And if needed, refer. So individually going to do each work situations, like initially patient features that we usually consider are the age. If it's younger age group, that means we expect more complications. The nourishment of the child, if the child is poorly nourished, we expect more complications. If the child has underlying, again we expect more complications with the child. If the child has lack of any family support, again we expect more complications. Disease-related features, the type of malignancy. There are. I will come to that. Type of malignancy and type of treatment determines the type of complications that we encounter. Then episode-related features. We usually look at the activity of the child, general condition of the child, the vitals like heart rate and BP, whether the child has gone into the compensated, decompensated shock, capillary filling time, central line issues. Then the focus of infections. We have to specifically look for the skin infections, oral cavity, perianal region, any rash, respiratory or GI symptoms the child has. And after that, we need to focus in the investigations, like apart from the routine blood investigation that we do, we need to do specific investigations like culture imaging and biomarkers. So the cultures we usually take from the child central line, from the central line as well as the peripheral line. So especially in child, peripheral venous access will be very difficult. So if the central line is there, central line culture is enough. Then the urine culture, again, it's a mandatory because we usually forget about the urine, focus of urinary tract. So we need to take cultures from the both blood and urine. Imaging, again, it should be focused only if X-rays need to be taken. Chest X-ray need to be taken only if there is respiratory symptoms, and UC abdomen need to be taken if there is any suspected abdominal focus. Biomarkers, although there is no much evidence of, regarding it, but many centers use it according to their policies. So CRP, there it's used in some risk assays to determine whether the child is low risk or high risk. Procalcitonin, still there is no evidence to use it. Galatomannan, it helps us to detect whether there is any fungal infection, and it has weak evidence. Beta glucan and fungal PCR is still not recommended for as a biomarkers now. And next question we ask is whether all requires a high intensity antibiotic or supportive treatment. So that's why we need the stratification for deciding whether between OP care or IP care, referral and early intervention. So stratification, many people have tried different types of stratifications, like looking at only absolute monocyte count from certain disease and episode specific factors, or like looking at certain factors like central line, CRP, CBC, like that. So what we usually follow is we take it as high risk when situations like disease specific situation like AML, if the child has AML, relapsed leukemia or lymphoma or non-Hodgkin lymphoma, the child is prone to be high risk for infections. And if the child is receiving intensive chemotherapy like salvage chemotherapy or the leukemia induction chemotherapy, child is high risk for infections. Then if there is a focus of infection, again we need to go aggressively. If the neutropenia, if the child is having severe neutropenia, it's less than 500 and expected duration is more than 7 days, again the child is going to high risk. If the child has severe mucositis more than grade 2, that means again we expect more complications. Presence of central line and poor general condition and nutrition status again point to high risk probability of infections. Disproportionate tachycardia unrelated to the anemia or fever, we think of going into decompensated hypertension. We need to step up the treatment, and if there is definite shock, we need to think of septic shock and manage accordingly. So low risk usually we consider in solid tumors and chemotherapy like ALL maintenance, but without any risk factors. So low risk, we just need to opioid-based treatment is enough, and oral antibiotic treatment is enough. High risk, the child need to be admitted and be given IV antibiotics. So usually first line antibiotics is decided by the antibiogram in the institute where they're treated. Depending on the antibiotic usual resistance pattern of the antibiotics, we will select the first line antibiotics. So usual antibiotics that we used are piperacillin tazobactam, cefoperazone sulbactam, meropenem, and cefepime. Oral antibiotics that we usually use are augmentin and ciprofloxacin, either in single agents or in combination. So second antibiotics usually, while during the treatment, we usually need to decide whether to add second antibiotic or not. So usual agents that we add are aminoglycosides or fluoroquinolones, and usual situations we add it upfront are poor general condition, high prevalence of MDR organism, and we are expecting an MDR organism, we usually add it upfront. So this is just an algorithm what we use to treat febrile neutropenia. So there is fever, we will assess regarding the different features of the child, disease related, episode related, like that. And if there is a definite sepsis, the child will be admitted and to start IV antibiotics. If there is no features of sepsis like tachycardia, all those things, child will be stratified into low risk and high risk. Low risk child will be treated in OP based antibiotics. High risk child will be admitted. In IP care, we will be reassessing the child, and if the fever is decreasing, we will be de-escalating the antibiotics as per the culture sensitivity. If the fever is persisting, depending on the general condition, the child is stable, we'll be continuing the same and changing the antibiotics as per the culture. Or if the condition is deteriorating, we'll be escalating the antibiotics. This is a practice that we follow. And there will be many other questions like when to add fungal, antifungals, when to add vancomycin, like that. So vancomycin usually add when there is gram-positive organism in the culture and sensitivity, and there is grade 3 or 4 oral mucositis, and there is definite evidence of rapidly progressing soft tissue infection, suspected CR basis, that is central line related bloodstream infection. And if the culture is showing MRSA, and the child has features of hypertension, so every shock we usually add antifungal, vancomycin. So when to add antifungals? So usually in higher situations like relapsed leukemia and AML and high risk ALL or stem cell transplantation, we will come across fungal infections. So these people are high risk for invasive fungal infections. And in high risk conditions, if the fever is persisting for more than 4 days, we will be thinking of empirical antifungals. Usual agents added are amphotericin B or caspofungin. So when should we think of this probable fungal infection? So usually in higher situations, if the imaging shows imaging like US abdomen CT shows the features of fungal infections, we think of probable fungal infections. In US abdomen, we look for hepatosplenic candidiasis, whether there is infiltrates in the liver and spleen, and CT just we look for pulmonary infiltrates suggestive of aspergillosis. So the choice of therapy depends on the clinical presentation. Hepatosplenic candidiasis, we usually add amphotericin B or the fluconazole. Pneumonia, we usually add voriconazole. And in septic shock, it's a different situation where it's an emergency where child is gone to hypotension, and we need to think of early intervention with IV antibiotics, sending cultures, procuring the IV access, and resuscitating child with fluid and appropriate inotropes. Usually we think of adding GCSF, especially neutropenia. We need to step up the neutrophil count. So whether there is any role of GCSF. So it has been studied many times, and shown that if the expected prolonged neutropenia is so like more than 7 days expected neutropenia, we can add GCSF. And if the child is very sick with profound neutropenia, less than 100 of ANC, we can add GCSF. But this has only proved to decrease the hospital stay, not the survival. When to stop the antibiotics? Usually, okay, child has neutropenia and the fever has subsided, so we'll have to think of when to stop the antibiotics. So when the counts are recovering and the general condition has improved without any focus of infection, and the child has febrile for last 48 hours, blood culture has become sterile, then we can actually safely stop the antibiotics. So what are the preventive measures that we can take to prevent this kind of situation? So the most important one is educating parents, because without the support of the parents, we cannot do anything for the child. So parents should know about the hygienic parameters, hygienic aspects of the child. So they should be knowing how to prevent such infections. So educating parents is very much important, and maintaining proper hygienic measures. Prophylactic diseases, especially if in after intensive chemotherapy, if necessary, needs to be added. And prophylactic antibiotic and fungals is a role. Antibiotics, only quarter-moxal prophylaxis is standard, because other agents have been studied, like ciprofloxacin has been studied, but still there is no much evidence to show that antibiotic prophylaxis has an impact in the prevention of the infections. Prophylactic antifungals in higher situations like AML or stem cell transplant, you can add prophylactic antifungals, fluconazole, and especially according to the institutional, if the institution has prevalence of high prevalence of invasive fungal infections, definitely prophylactic antifungals need to be added. Usual prophylaxis which been given are for the yeast, fluconazole, which is FDA approved. Voriconazole has been given for yeast and molds in certain institutions as per the institutional policy. Posaconazole is usually added as prophylactic antifungal in transplant settings. And take-home message is there should be a stratified approach for febrile neutropenia. It's an emergency; it needs to be managed aggressively. But low-risk situations can be managed with oral antibiotics alone. And early intervention saves the child, especially in a high-risk situation. If the child has features of aggressive infection, child need to be managed aggressively, and it can save the life of the child. So thank you.
Thank you, Dr. Jitin. That's a very Thank you.
Can you hear?
Can you hear? Yeah.
Yes.
Thank you. Yeah, Dr. Jitin, thank you for that tangible presentation. I think our moderator, Dr. Mohandas, has taken a break. I think perhaps we have to rush questions.
Only one question she has already answered.
Answered. Okay. Any questions to Jitin? No questions. All right. In that case, I think we will move on to next topic. That is bleeding child. Bleeding child. Hello.
Yes.
So we will move on to the next topic. That is by my best friend from IFSCIPS, Calicut, Dr. Ajit Kumar, and he will be talking on bleeding child. Yeah. So,
Screen sharing.
Pardon? Yeah, Ajit is my friend from BD days, and now he is at Rosalind head of Department of Medical College, Kozhikode. He is in charge of hemato-oncology unit of IFC, and he is trained at RCC Trivandrum and at St. Jude Cancer Center, Memphis, USA, and the National Institute of Immune Hematology, Mumbai. So Ajit, I am so happy to find you in this platform, Zoom platform, and hope to meet you more frequently. I will request Dr. Ajit to start the talk because we are short of time. Over to you, Ajit.
So, thank you. Thank you, Padman sir. Actually, I miss the pleasantries when we meet. Actually, the virtual meet. നമുക്ക് ഒന്നും സംസാരിക്കാൻ പറ്റാത്തൊരവസ്ഥയാണ് അല്ലേ? Hello, am I audible?
Yes, sir. You can continue.
So I thank IAP Kanhangad and especially Padmanabhan sir and Dr. Sureshan for giving me this opportunity. Also Jitin for inviting me. I really miss when we the real meet when we meet in our conferences. So that's what I was. So going to the topic, I'll be very short, and I know that I am the speaker between you and the lunch. Even though the lunch is, even if they want to sponsor, they cannot sponsor the lunch, the organizer. So I'll be going in a stepwise manner, and so any child coming to you with a bleeding, the first question that anyone has to ask is that whether the child does the child need any emergency care? So we always have to look for whether the child has any critical bleeds, like intracranial bleed, intra-abdominal bleeds, like sports bleed, neck bleed, or sometimes the child might be in shock, whether after a trauma, excessive bleeding after a trauma. So our priority should be to stabilize the child and then ask questions and investigate. Especially child, baby, immediate newborn period coming to you with cholestasis and evidence of raised tension, AF bulging and bleeding. You give vitamin K, most probably it will be a hemorrhagic disease. So you don't have to ask for other questions. Give vitamin K and then do all the tests. So there are situations where you have to do emergency care. So any child with a bleeding tendency, the first question that I would ask will be whether this child needs some emergency care. The second question that I would ask is whether this child is it a part of a bleeding disorder or not? Because there are some of the traumas might be proportional. Some of the bleeding might be proportionate to trauma, like after a road traffic accident, you may have profuse bleeding. But if the bleeding is not proportionate, or out of proportionate to the trauma, then you think of a bleeding disorder. And we have seen that children may have hemoptysis or hematemesis. So if they're isolated to an organ, like if they don't have other findings like petechiae or purpura ecchymosis, then it's unlikely to be due to a bleeding disorder. You may have seen umpteen number of children coming with bleeding from a single nostril, which might be due to nose picking. Sometimes molar tooth extraction, which might be slightly more prolonged than an incisor tooth extraction or a canine tooth extraction. All these are normal, but we should be always aware that sometimes it can be sometimes if you have ecchymosis in unusual sites like in back, or if you have genital area, you think of child abuse. And it is common to have bruises in children, especially young children when they're very active and young. So it is said that 50 to 80% of those bruises in young children are without any bleeding disorders. But it is very pertinent to know that severe bleeding disorders, especially the congenital varieties, they present 90% present in the early childhood because they are more prone for trauma. The third question, after the first question would be whether the child has any critical bleed. The second question would be to know whether the child is having a bleeding disorder or not. The third question I would be looking is whether we can identify whether it belongs to the phase 1, like whether it's a vascular bar platelet, or the phase 2, the coagulation defect, or is it a combined? So which part of the coagulation system this child has a bleeding? So for that we have some clues. So if the child has skin and mucous membrane bleeds, if they have petechiae and small ecchymosis, think of platelet type of bleed. And if the child has deep joint bleeds or large ecchymosis, you have to think of a coagulation type of bleed. If the bleeding is immediately after trauma, think of a platelet type of bleed. And if it's a delayed, if you have a mild ankle sprain in the morning and if you have a huge swelling of the ankle in the evening, think of a coagulation disorder. And bleeding after surgery, if it's immediate, it is platelet. If it is delayed, it is. So these are some of the clues that you get from the history in differentiating these two phases, the phase 1 and the phase 2. The fourth question to pinpoint or to direct your attention to find a cause would be to find out whether it's some congenital or acquired cause. So whether the child had any umbilical stump bleeding in the newborn period, it points to a factor 13 or a dysfibrillomia or afibrin. Or if the child had an intracranial bleed without any other risk factors, it could be a coagulation disorder, bleeding disorder. An infant with a swollen joints after a mild fall, after a small fall, or a adolescent girl who presents with excessive menstrual bleed. All this points to a congenital causes. And definitely you should take a good family history with three generations. And so go individually and very deep into the family tree. That is one of the most important thing in history of bleeding disorder. And many of them are X-linked and some of them are autosomal dominant. Hemophilias, most of the hemophilias are X-linked, and von Willebrand's disease and hereditary hemorrhagic telangiectasia, they're autosomal. But sometimes you should know that some of the hemophilias, in 1/3 of the hemophilia, they may not get a family history. So family history and some of the other coagulation factor disorders are autosomal recessive. So you may not get a family history in some. But very important to go into family tree. Some bleeding patterns may have some, can make a diagnosis, like bleeding from umbilical stump, which I already said, points to a dysfibrillomia or afibrillonemia, factor 13 deficiency, or if you have impaired wound healing, factor 13 points to a factor 13 deficiency. If you have recurrent epistaxis, or if you have chronic, along with it, you have a chronic iron deficiency, think of hereditary hemorrhagic telangiectasia. If you have eczema, neutropenia, recurrent infections, think of viscotalric syndrome, which I not said here. So if you don't have a significant bleeding after a molar tooth extraction or after surgery, especially circumcision, trauma, it includes mainly most of the congenital major hemorrhagic diseases, congenital hemorrhagic diseases. And definitely you have to go into the medication history. Very, very important, because I have seen a child who had petechiae purpura. A child was on Montelukast, and when I looked into the Montelukast child, the Montelukast has a platelet dysfunction problem. So stop the Montelukast and definitely it disappeared. So all drugs, you have to look into the minor side effects. So go into drugs and see whether there is any. And the herbal medicine, some of them, now it's a fad that many people are on some herbal teas and some other. So look into that, the gingigo, what you call gingigo biloba and all these things, ginger, garlic and all this. They have what you call bleeding tendencies, excess garlic containing medications. So look into that and see that you stop all the medications and see that. And very important that we always neglect is they may have a lot of records with them, and then we are usually not very fond of looking at the old records. But it's better to look at the old records. You may get a clue whether it's a congenital acquired, or you may get a diagnosis even. So, and whether it's a congenital variety or acquired, you always have to, some of the systemic disorders may produce a bleeding tendencies, like a chronic liver disease, especially with a failure, or chronic renal impairment with the uremia, or if malabsorption syndrome with vitamin K deficiency. All this may produce bleeding tendencies. Recently, we are seeing a lot of malnourished SAM cases, severe acute malnutrition, and we are seeing vitamin C deficiency, B12 deficiencies, and vitamin K, especially in those who are having a drought. So all this history will tell you whether it's a congenital or acquired variety. So after a history, you might get a clue whether it is a phase 1 or a phase 2 disorder. You have to have a focused examination. You have to look for, these are the main focused areas that you have to look for: pallor, the oral cavity, palms and soles. Look for whether it's a platelet type of bleed. If it's a platelet, you'll have petechiae purpura ecchymosis. If you have coagulation, you may have hemarthrosis, hematomas. Look for critical areas. Look for joint mobility. This is one, like many children come to you with joint mobility, petechiae and ecchymosis, and you look at the joint, and if the joint is hypermobile and lacks skin, then your diagnosis is there. You don't have to go anywhere. Mostly it is a Ehlers-Danlos. And you look for other infections, malignancies, collagen was, all this may produce bleeding tendencies. So you have to have focused examination on a thorough general examination and systemic examination to rule out many of the conditions. So after history and examination, you can get a diagnosis. You can, but if you're not getting a diagnosis after a history examination, at least you should know which part of the coagulation system you're planning to investigate, which your differential line, whether it is a phase 1 disorder or a phase 2 disorder. Phase 1 means platelet or vascular. Phase 2 is your coagulation system. So the initial investigation would be the very simple CBC, smear, and PT and APDT. These three investigations, even though they look very simple, but it has to be done in a very good lab where you have a good rapport with the pathologist, where they should have a quality control mechanisms, and they should be having internal and external quality control. All these things should be there, because all the other investigations depends upon these three investigations. So you may miss a diagnosis. So it is better to have a pathologist who is always talks to you over the phone, and the pathologist calls you, sir, looks like there is something abnormal in the smear. So if you think that it is a phase 1 like platelet disorder, from the CBC, you can get, a lot of information can be seen, you can get it from the CBC, like look at the count, look at the indices. All these things can be interpreted from the CBC. CBC is nothing but an objective evaluation of the smear, an objective. So this is a simple algorithm looking at the CBC and paired smear and how the platelet count. So if you have platelet count is low, and if it's large platelets, so even from the CBC you can get MPV, it's more than 12. So large platelets, think of ITP. If you have ITP and a large platelet, that means the bone marrow the chance of recovery is more. And Bernard-Soller, another condition. Platelet is low, and normal platelets, you think of other conditions like aplastic anemias, leukemias. But here the other cell lines might also be abnormal. And the platelet count is normal, and other cell lines are normal. If you have isolated plates, not in clumps, you think of Glanzmann's, von Willebrand's disease, and other vascular disease. If they're in clumps, more of clumps are seen, you can look for. It could be a type 2B, von Willebrand, or pseudo von Willebrand. So this is one of the algorithms that can be followed up. But it's better to have a great look on the smear by the pathologist, and you have to examine the CBC in detail. This is one child who came to me with a 6-year-old male child, came to me in the casual purpura 1-day duration, and the child was active, purpura was there, few mucus lesions in the mouth. So it's basically no hemathrosis, no hematomas. There was no lymph node. So basically a phase 1, basically platelet bar vascular, mainly platelet because the mucous membrane is the child. And see the cell lines, all the cell lines are normal. Platelet, only the platelet is abnormal. The MPV is high. So the smear showed platelet reduced normal RBCs, no atypical cells. APDT was normal. Actually, there is no need for doing that. Only thing reduced with the platelet count. So smear showed a reduced number of platelets. It's a large platelet, single large platelet. So this is a newly diagnosed primary immune thrombocytopenia. Actually, there is no need for further investigations. There is no need for bone marrow. There is no other even need for an APDT actually. So you can, even from a smear and from a CBC, you can make a diagnosis. So that's the beauty of the primary investigations. This is the second case, a 4-year-old boy who came with irritability, anorexia, loose stools. Child was malnourished. Child had hepatosplenomegaly. Child had some bleeding manifestations. A lymphadenopathy was there. We thought that child has PEM. Could be a viral infections, or it could be a malignancy. And but the CBC showed that child had count was low, platelet was low, but the MCV was high. So from the CBC itself, see from the MCV, left here, LDH was on the slightly higher side. See that the smear was diagnostic, the hypersegmented neutrophils, and see the megaloblast. So this is definitely B2. So even from the CBC and the smear, you can make a diagnosis of the bleeding child. This child was malnourished, which I already said. So, if you have a phase 1 disorder, do a very good smear and CBC, and work up accordingly. And if you have a phase 2 disorder, the test would be ideal would be PT. So PT actually looks at the extrinsic pathway as well as the common pathway, while the APTT looks at the intrinsic pathway as well as the common pathway. And thrombin time is another thing which we are not doing. It's look at the fibrinogen, conversion of fibrinogen into fibrin. So this is what the algorithm, if you have an abnormal APTT or PT. If it is abnormal, look at whether it's PT or APTT is abnormal. So if the PT is alone is abnormal, APTT is normal, it's a factor 7 deficiency or some anticoagulants there. If APTT is only prolonged PT, looks like the common factor, hemophilias and lupus, and it could be lupus. And lupus anticoagulant is something which you usually see. Sometimes they may have a child who comes with a slightly elevated APTT, and they have gone for a surgery checkup and they have found that APTT is slightly prone. You do a lupus anticoagulant, it might be positive. So it does not do anything unless the other things, ANA, DS, DNA, all these are negative. And usually they get over, it might be due to viral infections, maybe 1 or 2 weeks before. And you have both PT and APTT prolonged. If the child is very sick, it's DIC or sepsis or liver disease. If they are not, these are the factors, they are deficient. So very important, if both are prolonged, if the child is sick, it could be DIC or sepsis. If they are normal, sometimes the PT and APTT can be normal. Still, the child, you think of child has a bleeding. You think of factor 13 deficiency or some vulnerable disease. It can be sometimes it can PT and APTT can be normal, and platelet function disorders. So these are some of the things that the PT and APTT can be normal. So always rule out some forms of some patients with vulnerable still may have normal PT and APTT and factor 13 and platelet function disorders. Okay, this child came to us with the first episode of, there was a swelling here and then it was red and tender and child had mild fever. We initially thought that it was septic arthritis actually. And I mean, that's single joint involvement, fever, tenderness, and somebody had done an APTT and it was prolonged. So it was a hemophilia A. And this is another child who had this child, and here see the wasting. So this is a child who had hemophilia with recurrent bleeds. So the diagnosis not very difficult because child had a recurrent bleeds in the same joint, and that was a child. The previous child had a bleeding into the same first episode. So in any child with the first episode bleeding, always rule out hemophilias or coagulation disorders. This child, because see the wasting in the cordyceps. So one of the DDs that you may have to, especially in a child, mild case of hemophilia, is a differential diagnosis is a von Willebrand's disease, where the von Willebrand antigen will be low in type 1 and type 3, and all the activities will be low in all the cases, and the ristocetin-induced platelet agglutination will be usually low in most of the cases, but increase in type 2B. So these are some of the important tests that you can do in to differentiate between mild hemophilias and von Willebrand's disease. So this is a test which I already said: antigen, do a factor activity. This multimer gel electrophoresis and ristose. I mean, if you have facilities, you can do. This is how you differentiate between the type 1 and the type 3 are quantitative defects. So you have definitely a reduced amount of von Willebrand factor antigen, while type 2 is a qualitative defect. So type 2 is, you have different types, which I'm not going. The important thing is that type 2B, they have reduced platelets also. And type 2N, they may behave, type 2N and type 3, they behave as hemophilia, coagulation. They may present just like a hemophilia, is type 2N and type 3. Because type 3 have severe von Willebrand antigen deficiency. So one of the most important points during lab, very important to have a proper collection, especially in a citrated tube, 1:9, and you should not draw a blood from a hypernized line. And if you're using ADT, I mean, there might be a chance that you may have a reduced platelet. So always use citrate. And you should always say that there might be some variations in PT with APTT with the labs, and always INR has to be done, and with age also. And always use automated missions and check whether they have a good pathologist, and always talk with them and have sent to one lab. Even if you might, the people might mistake that you might get a commission on them. So better to have one lab so that you can have a good communication with them. The second tier testing, after you don't get a diagnosis from the first tier, you can do a thrombin time look for evidence of fibrinogen to fibrin, and it usually is increased in dysfibrinolemia or afibrinolemia. You can do mixing studies to look at the factor deficiency. If you have factor deficient plasma, like factor VIII deficient plasma, then you add this one, your blood serum, and it does not clot. That means it is a factor VIII deficiency. If it clots, then so using factor VIII deficient plasma, either factor IX or factor, you can definitely do from any laboratory, or you can do a specific factor assay for that. And flow cytometry, some of the Bernard's syndromes or Glanzmann thrombocytopenia, flow cytometry can be diagnostic, and some of the genetic evaluation. So these are the second tier investigations that you can do. And this is one platelet function. We are not doing platelet function here yet, but we are not an experts on that. But here, this one, platelet aggregation is done with ADP, collagen, and restositin. And you can look at very many things like Bernard-Solier or von Willebrand's disease or storage pool disorders or Glanzmann's disease. On all these things can be, or some of the, this is a Glanzmann's disease. So some of the things can be diagnosed using platelet function analysis, using ADP, collagen, and this is a algorithm for that. I'm not going to detail. So this is one entity which I was really, I think all of you should be knowing it, that is acquired platelet disorders with eosinophilia. So 11-year-old child, very common nowadays. So another thrombocythemias that we see came with bluish green colored patch on the since 4 months, and all the cell lines were normal except for the eosinophils. Look at the eosinophils, and it was 41%. Absolute eosinophil count was very high, and all the PT, APT was normal. And so then the first few cases we sent it to Vellore to look at the this one, the aggregation studies, and see, and all this were normal. No aggregation. There was no aggregation collagen. That was the most important. And reduced aggregation with, so no aggregation collagen is one of the hallmarks of this. So this is called acquired platelet disorders with eosinophilia. And usually they respond with your anti, what do you call that? I forgot, with heterogen, and then you give for 2 or 3 weeks, then respond. But the response takes about 4 to 6 months. So you have to tell them that it may recur within 4 to 6 months, then after that it will subside. So if you don't have any abnormalities, you think of factor 13 deficiency, then you have to do a factor 5 molar urea, solubility of clot in 5 molar urea. Or very important is, which I forgot, joint stability, that you have to look, you can do you think of Ehlers down. So any child coming to you, you have to look for that. Look for any extensive, what do you call joint laxity, and hinoxolin purpura, or sometimes battered baby. These are some of the things, or even milder deficiencies sometimes may go on negative in some of the tests. So to conclude, a good history and examination will definitely give a direction and sometimes a diagnosis. And a very important tool is family tree. Look at the do a 3 generation family, and a good lab, and a timely referral will save the child or make a diagnosis. So thank you.
Really nice presentation. Can you hear me at least? Yes. It's a really nice presentation, as usual. And the clarity is so good. I don't think there won't be any doubt whatsoever. But all the same, I invite questions. One or 2 questions before we conclude. Question no questions. So this is the last exam. And it is time for us to wind up. If there are no questions, if there is no questions, we will.
Thank you. Thank you, Padman sir.
We will.
Audio poor ആണ്. Audio കേൾക്കുന്നില്ല. Poor audio ആണ്. Audio കേൾക്കുന്നില്ല.
Is there a hearing? Okay. So if there is no questions, we will wind up with your permission.
Thank you.
So, Kerala Pediatric Committee of Oncology Chapter Annual Conference 2020, 11th one, is coming to an end. And it has been a great session. We had lots of very knowledgeable speakers. I'm sure that the information, the knowledge we gain here will be translated to better patient care. And I thank...
Crackling sound.
Pardon? I thank each and everyone who has participated in this conference again, and we conclude the session. Thank you once and all.